Logo mic test. Mic test. Mic test. Mic test. Hello. Mic testing. Mic test. Mic test. Hello. Hello. ಕರೆಕ್ಟ್ ಆಗಿದೆಯಾ? ಸರಿ. ಅಲ್ಲಿ ಬಂತು.
ಹಲೋ 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 ಹಲೋ
ದೈವಕ್ಕೆ ಶರಣು. ಕರ್ನಾಟಕ ವಿಜ್ಞಾನ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಅಕಾಡೆಮಿ, ವಿಜ್ಞಾನ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಇಲಾಖೆ, ಕರ್ನಾಟಕ ಸರ್ಕಾರ ಇವರು ನಡೆಸುವ 3 ದಿನಗಳ ರಾಷ್ಟ್ರೀಯ ಸಮ್ಮೇಳನ ಸೂಕ್ಷ್ಮಾಣುಜೀವಿ ನಿರೋಧಕತೆ ತಡೆಗಟ್ಟುವ ಕಾರ್ಯತಂತ್ರಗಳು ಮತ್ತು ಪರ್ಯಾಯಗಳು. ಬಹಳ ವಿಶೇಷವಾದಂತಹ ಒಂದು 3 ದಿನಗಳ ಅರ್ಥಪೂರ್ಣವಾದ ಕಾರ್ಯಾಗಾರ ಇಲ್ಲಿ ನಡೀತಾ ಇದೆ. ಆಂಟಿಮೈಕ್ರೋಬಿಯಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್, ಸ್ಟ್ರಾಟಜೀಸ್ ಫಾರ್ ಪ್ರಿವೆನ್ಷನ್ ಆ್ಯಂಡ್ ಆಲ್ಟರ್ನೇಟಿವ್ಸ್. ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್ ಟಾಪಿಕ್ಸ್. Actually, we are going to attend for the next 3 days. First of all, it's very sad news, in fact. ಮೃದುಭಾಷಿ, ಮಿತಭಾಷಿ, ಹಿತಭಾಷಿ, ಅಜಾತಶತ್ರು ನಿಮ್ಮೆಲ್ಲರ ನೆಚ್ಚಿನ ಡಾಕ್ಟರ್ ಅಯ್ಯಪ್ಪನ್ ಸರ್ನ ನಾವು ಇತ್ತೀಚೆಗಷ್ಟೇ ಅಗಲಿದ್ದೇವೆ. ಬಹಳ ವಿಶೇಷವಾದಂತಹ ವ್ಯಕ್ತಿತ್ವ. ಹಿ ವಾಸ್ ನೋನ್ ಫಾರ್ ಹಿಸ್ ಸಿಂಪ್ಲಿಸಿಟಿ. ಹಿ ವಾಸ್ ಡೌನ್ ಟು ದಿ ಅರ್ತ್. ಪದ್ಮಶ್ರೀ ಪುರಸ್ಕೃತರು. ಹಿ ವಾಸ್ ಫಾರ್ಮರ್ ICR, ಇಂಡಿಯನ್ ಕೌನ್ಸಿಲ್ ಆಫ್ ಅಗ್ರಿಕಲ್ಚರ್ DG ಆಗಿದ್ದರು. ಹಿ ವಾಸ್ ಸೆಕ್ರೆಟರಿ ಫಾರ್ ಡೇರ್. ಹಿ ಆಲ್ಸೋ ಸರ್ವ್ ಫಾರ್ chairman for NABL, National Accreditation Board for Testing and Calibration of Laboratories. And he was the Chancellor for Agriculture University, Itanagar. And he was also the chairman for Karnataka Science and Technology Academy. ತುಂಬ ನೋವಾಗುತ್ತೆ, ಅವರನ್ನು ನೆನೆಸ್ಕೊಂಡ್ರೇ ಕಣ್ಣಲ್ಲಿ ನೀರು ಬರುತ್ತೆ. ಅಂತಹ ಒಬ್ಬ ವ್ಯಕ್ತಿತ್ವನ ನಾವು ಕಳ್ಕೊಂಡಿದ್ದೀವಿ. ಈಗ ಅವರನ್ನು ಶ್ರದ್ಧಾಂಜಲಿ ಸಲ್ಲಿಸುವ ಕಾರ್ಯಕ್ರಮ. ದಯಮಾಡಿ ಎಲ್ಲರೂ ಎದ್ದು ನಿಂತು ಅವರಿಗೆ 2 ನಿಮಿಷದ ಒಂದು ಶಾಂತಿ ಕೊಡೋಣ. ಓಂ ಶಾಂತಿ ಶಾಂತಿ ಶಾಂತಿ. ಧನ್ಯವಾದಗಳು. ಈಗ ಡಾಕ್ಟರ್ ಅಯ್ಯಪ್ಪನ್ ಸರ್ ಅವರ ಭಾವಚಿತ್ರಕ್ಕೆ ಪುಷ್ಪಾರ್ಚನೆ ಮಾಡುವ ಮೂಲಕ ಅವರಿಗೆ ಒಂದು ಶ್ರದ್ಧಾಂಜಲಿಯನ್ನು ಮತ್ತೊಮ್ಮೆ ಸಲ್ಲಿಸ್ತಾ ಇದ್ದೇವೆ. ಧನ್ಯವಾದಗಳು ಸರ್. A 3 days ನ್ಯಾಷನಲ್ ಕಾನ್ಫರೆನ್ಸ್ ಆನ್ ಆಂಟಿಮೈಕ್ರೋಬಿಯಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಸ್ಟ್ರಾಟಜೀಸ್ ಫಾರ್ ಪ್ರಿವೆನ್ಷನ್ ಆ್ಯಂಡ್ ಆಲ್ಟರ್ನೇಟಿವ್ಸ್. ನಿಜವಾಗಿ ಮಾನವ ಪ್ರಾಣಿ ಪಕ್ಷಿ ಸಂಕುಲಗಳ ಸಂರಕ್ಷಣೆಗಾಗಿ ಹಲವಾರು ಪ್ರಮುಖ ವಿಷಯಗಳನ್ನು ಮುಂದಿನ 3 ದಿನಗಳ ಕಾಲ ಈ ಒಂದು ಕಾರ್ಯಾಗಾರದಲ್ಲಿ ನಡೆಯುತ್ತೆ. ಹಲವಾರು ವಿಷಯಗಳನ್ನು ಮಂಡಿಸುವ ಮೂಲಕ ತಮ್ಮನ್ನೆಲ್ಲರನ್ನು ಚಿಂತನಶೀಲರನ್ನಾಗಿ ಮಾಡುವ ಅಪರೂಪದ ಒಂದು ಕಾರ್ಯಕ್ರಮ ಇದಾಗಿದೆ. ಹಾಗೂ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಬಹಳ ವಿಶೇಷವಾದಂತಹ ವಿಷಯಗಳ ಮೂಲಕ ತಮ್ಮನ್ನೆಲ್ಲರನ್ನು ಚಿಂತನಶೀಲರನ್ನಾಗಿ ಆ ಒಂದು ಹಲವಾರು ನಿರೀಕ್ಷೆಗಳ ಮೂಲಕ ತಮ್ಮನ್ನಿಲ್ಲಿ ಬರಮಾಡಿಕೊಂಡಿದ್ದಾರೆ. ಆ ಎಲ್ಲ ನಿರೀಕ್ಷೆಗಳನ್ನು ತಾವು ನಿಜ ಮಾಡ್ತೀರಾ ಅಂಥೇಳಿ ಭಾವಿಸ್ತಾ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮವನ್ನು ನಾವೀಗ ಪ್ರಾರಂಭಿಸೋಣ. ವೇದಿಕೆ ಮೇಲೆ ನಾನು ಶ್ರೀ ಎನ್ ಬೋಸರಾಜು ಸಾಹೇಬರು, ಮಾನ್ಯ ಸಣ್ಣ ನೀರಾವರಿ ಹಾಗೂ ವಿಜ್ಞಾನ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಸಚಿವರು, ಕರ್ನಾಟಕ ಸರ್ಕಾರ. ದಯಮಾಡಿ ಆನಂದ್ ಸರ್ ಅವರು ಸಾಹೇಬರನ್ನು ವೇದಿಕೆ ಮಾಡ್ಕೋಬೇಕು. ಹಾಗೆಯೇ ಡಾಕ್ಟರ್ ಇಡಿಯಾ ಕರುಣ್ ಸಾಗರ್, ಸಲಹೆಗಾರರು, ಸಂಶೋಧನೆ ಮತ್ತು ಪೇಟೆಂಟ್ಸ್, ನಿಟ್ಟೆ ವಿಶ್ವವಿದ್ಯಾಲಯ ಮಂಗಳೂರು ಹಾಗೂ ನಿವೃತ್ತ ಹಿರಿಯ ಅಧಿಕಾರಿ. ದಯಮಾಡಿ ವೇದಿಕೆ ಮೇಲೆ ಆಗಮಿಸಬೇಕು. ಡಾಕ್ಟರ್ ರಾಘವೇಂದ್ರ ಭಟ್ಟ, ಉಪ ಮಹಾನಿರ್ದೇಶಕರು, ಪಶು ವಿಜ್ಞಾನ, ICAR, ನವದೆಹಲಿ. ದಯಮಾಡಿ ವೇದಿಕೆ ಆಗಮಿಸಬೇಕು. ಪ್ರೊಫೆಸರ್ AH ರಾಜಾ ಸಾಬ್, ಮುಖ್ಯ ಸಂಶೋಧನಾ ಸಲಹೆಗಾರರು, RUAS ಮತ್ತು ವಿಶ್ರಾಂತ ಕುಲಪತಿಗಳು, ತುಮಕೂರು ವಿಶ್ವವಿದ್ಯಾನಿಲಯ. ದಯಮಾಡಿ ಆಗಮಿಸಬೇಕು. ಶ್ರೀಯುತ ಆನಂದ್ ಸರ್ ಅವರು ಮತ್ತು ರಮೇಶ್ ಸರ್ ಸಹ ವೇದಿಕೆ ಮೇಲೆ ಆಗಮಿಸ್ಬೇಕಂತ ಹೇಳಿ ವಿನಂತಿ ಮಾಡಿಕೊಳ್ತಾ, ಯಾವುದೇ ಒಂದು ಕಾರ್ಯಕ್ರಮವನ್ನು ಸುಸೂತ್ರವಾಗಿ ನಡಿಬೇಕಾದರೆ ನಮ್ಮಲ್ಲಿ ಪ್ರಾರ್ಥನೆ ಮಾಡಿಬಿಟ್ಟು ಆ ಒಂದು ಕಾರ್ಯಕ್ರಮವನ್ನು ಪ್ರಾರಂಭಿಸುವುದು ವಾಡಿಕೆ. ಹಾಗೆಯೇ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮವನ್ನು ನಾಡಗೀತೆ ಮತ್ತು ಅಕಾಡೆಮಿ ಗೀತೆಯ ಮೂಲಕ ಒಂದು ಚಾಲನೆಯನ್ನು ತೆಗೆದುಕೊಳ್ಳೋಣ. ಮೊಟ್ಟ ಮೊದಲಿಗೆ ಕುವೆಂಪು ವಿರಚಿತ ನಾಡಗೀತೆಯೊಂದಿಗೆ ದಯಮಾಡಿ ಎದ್ದು ನಿಂತು ನಾಡಗೀತೆಗೆ ಗೌರವ ಸೂಚಿಸಬೇಕಂತ ಹೇಳಿ ಕೇಳ್ಕೊಳ್ತೇನೆ. ಮಾಡಿ ಎಲ್ಲರೂ ಆಸೀನರಾಗಬೇಕು. ಈಗ ಅಕಾಡೆಮಿಯ ಗೀತೆ. ಧನ್ಯವಾದಗಳು. highly valuable and learned experts from all over India. They are going to present their beautiful presentations for the next 3 days, and also the participants from different parts of the country, they are gathered here. एक बात कहना चाहता हूँ मैं इधर, खूबसूरती से एक पल का रिश्ता बन जाता है, खूबसूरती से एक पल का हिस्सा बन जाता है, जाने कब कौन ज़िंदगी का हिस्सा बन जाता है, कुछ ख़ास लोग मिलते हैं ज़िंदगी में जिनसे कभी ना बिछड़ने वाला रिश्ता बन जाता है. ಈಗ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಆಗಮಿಸಿದ ಎಲ್ಲ ಗಣ್ಯಮಾನ್ಯರನ್ನು ಸ್ವಾಗತ ಕೋರಲು ಮತ್ತು ಈ ಕಾರ್ಯಕ್ರಮದ ಹಿನ್ನೆಲೆಯ ಕುರಿತಾಗಿ ಪ್ರಾಸ್ತಾವಿಕ ನುಡಿಯನ್ನಾಡಲು ನಾನು ಡಾಕ್ಟರ್ ರಮೇಶ್ ಅವರಿಗೆ ನುಡಿಪೀಠಕ್ಕೆ ಆತ್ಮೀಯವಾಗಿ ಆಹ್ವಾನಿಸ್ತಾ ಇದ್ದೇನೆ. ಸರ್,
ಗುಡ್ ಮಾರ್ನಿಂಗ್, ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ ಮತ್ತು ಅಕಾಡೆಮಿಗೆ ಸ್ವಾಗತ ಸುಸ್ವಾಗತ. ಅಕಾಡೆಮಿಯ ಆಹ್ವಾನವನ್ನು ಮನ್ನಿಸಿ ತಾವೆಲ್ಲರೂ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಬಂದಿರೋದು ಭಾಳ ಸಂತೋಷದ ವಿಷಯ. ಮತ್ತೊಮ್ಮೆ ತಮಗೆಲ್ಲರಿಗೂ ಸ್ವಾಗತ. ಮಾನ್ಯ ಸಣ್ಣ ನೀರಾವರಿ ಹಾಗೂ ವಿಜ್ಞಾನ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಸಚಿವರಾದ ಶ್ರೀ ಎನ್.ಎಸ್. ಬೋಸರಾಜ್ ಸರ್ ಅವರೇ, ವಿಜ್ಞಾನ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಇಲಾಖೆಯ ಸದಾಶಿವ ಪ್ರಭು ಸರ್ ಬರಬೇಕು, ಈಸ್ ಆನ್ ದ ವೇ. ತುಮಕೂರು ವಿಶ್ವವಿದ್ಯಾಲಯದ ವಿಶ್ರಾಂತ ಕುಲಪತಿಗಳು, ಅಕಾಡೆಮಿಯ ಹಿಂದಿನ ಸದಸ್ಯರು ಆದ ಪ್ರೊಫೆಸರ್ ಎಚ್ ರಾಜಾ ಸಾಬ್ರವರೇ, ಭಾರತ ಸರ್ಕಾರದ ಭಾರತೀಯ ಕೃಷಿ ಸಂಶೋಧನಾ ಮಂಡಳಿಯ ಉಪ ಮಹಾನಿರ್ದೇಶಕರು ಮತ್ತು ಖ್ಯಾತ ವಿಜ್ಞಾನಿ ಡಾಕ್ಟರ್ ರಾಘವೇಂದ್ರ ಭಟ್ಟ ಅವರೇ, ನಿಟ್ಟೆ ವಿಶ್ವವಿದ್ಯಾಲಯದ ಸಲಹೆಗಾರರು ಮತ್ತು ವಿಶ್ವಸಂಸ್ಥೆಯ ಆಹಾರ ಮತ್ತು ಕೃಷಿ ಸಂಸ್ಥೆಯ ನಿವೃತ್ತ ಹಿರಿಯ ಅಧಿಕಾರಿಗಳು ಮತ್ತು ನನ್ನ ಗುರುಗಳಾದ ಡಾಕ್ಟರ್ ಕರುಣಾಸಾಗರ್ ಅವರೇ, ಸೆಂಟ್ರಲ್ ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ ಆಫ್ ಫಿಶರೀಸ್ ಎಜುಕೇಷನ್ ಸಂಸ್ಥೆಯ ವಿಶ್ರಾಂತ ಕುಲಪತಿಗಳಾದ ಡಾಕ್ಟರ್ CN ರವಿಶಂಕರ್ ಅವರೇ, ನಿಟ್ಟೆ ವಿಶ್ವವಿದ್ಯಾಲಯದ ನಿರ್ದೇಶಕರು, ಖ್ಯಾತ ವಿಜ್ಞಾನಿ ಹಾಗೂ ನನ್ನ ಗುರು ಪ್ರೊಫೆಸರ್ ಇಂದ್ರಾಣಿ ಕರುಣಾಸಾಗರ್ ಅವರೇ, ನನ್ನ ಸಹೋದ್ಯೋಗಿ ಮಿತ್ರ ಡಾಕ್ಟರ್ ಆನಂದ್ ಅವರೇ, ಡಾಕ್ಟರ್ ಶ್ರೀ ಮಾನ್ಯ ಸಚಿವರ ಆಪ್ತ ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಶ್ರೀ ಹಂಚಿನಾಳ್ ಸಾಹೇಬ್ರೆ ಹಾಗೂ ಎಲ್ಲ ಹಿರಿಯ ಅಧ್ಯಾಪಕರೇ, ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಸರ್, ಡೀನ್ ವೆಟರ್ನರಿ ಕಾಲೇಜ್, ಡಾಕ್ಟರ್ ಇಸ್ಲೂರ್, ಡಾಕ್ಟರ್ ಶ್ರೀನಾಥ್, ಎಲ್ಲರಿಗೂ ಮತ್ತೊಮ್ಮೆ ಸ್ವಾಗತ. ಇತ್ತೀಚೆಗೆ ನಮ್ಮ ಹಿಂದಿನ ಮಾನ್ಯ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ S. ಅಯ್ಯಪ್ಪನ್ ಸರ್ ಅವರು ನಿಧನರಾಗಿದ್ದು ನಮಗೆಲ್ಲರಿಗೂ ಬಹಳ ದುಃಖದ ಸಂಗತಿ. ಈಗಾಗಲೇ ಮೌನ ಆಚರಿಸಿ ಅವರ ಆತ್ಮಕ್ಕೆ ಗೌರವವನ್ನು ಸಲ್ಲಿಸಲಾಗಿದೆ. 3 ವರ್ಷಗಳ ಕಾಲ ಅವರ ಅಧ್ಯಕ್ಷತೆಯಲ್ಲಿ ಕಾರ್ಯನಿರ್ವಹಿಸಿದ್ದು ಬಹಳ ಖುಷಿ ಮತ್ತು ಹೆಮ್ಮೆಯ ವಿಷಯ ಆಗಿತ್ತು. ಅವರ ಒಂದು ಕಾರ್ಯಾವಧಿಯಲ್ಲಿ ಫೆಲೋಶಿಪ್ಪನ್ನು ಪ್ರಾರಂಭ ಮಾಡಲಾಯಿತು. ವಿ ಹ್ಯಾವ್ ಗಿವನ್ ಫೆಲೋಶಿಪ್ಸ್ ಟು 170 scientists and academicians across Karnataka. It has become so popular that for the last 2 years we have not been able to give any fellowship because we didn't have chairman. There have been a lot of inquiries about fellowship. That is the testimony of the significance of this fellowship. Our Islur Saab is also a fellow of KSTA and Raja Saab sir is also a fellow. And ಈ ವರ್ಷ ಮತ್ತೆ ಅದನ್ನು ಮುಂದುವರಿಸ್ಕೊಂಡು ಹೋಗ್ತೀವಿ ಮಾನ್ಯ ಸಚಿವರ ಒಂದು ಪ್ರೋತ್ಸಾಹದಿಂದ. In fact, Karnataka Science and Technology Academy was started in the year 2005 under the chairmanship of doyen of space science, Professor U.R. Rao. Under his guidance, we worked for nearly 12 years. After that, another great space scientist, Dr. S.K. Shivkumar, was our chairman for a brief period of 1.5 years. And previously, Professor Ayyappan sir was our chairman. Under their guidance, we have organized many programs covering entire educational pyramid, right from high school to the university level. Almost all districts have been covered by KSTA programs, although not in a big way, in small way we have organized. And we have organized more than 50 conferences across the state. And I'm very proud to say that in the last 2 years, we have organized more than 12 conferences. That's mainly because of unwavering support and encouragement that we got from our Honorable Minister, sir. In fact, this is a record break. The last 2 years, we have organized many programs reaching to many students and general public. And we are very grateful to our Honorable Minister, sir, for all the support that he has given us. And this year, we plan to organize a conference on antimicrobial resistance. But as you know, some of you may be knowing, I studied microbiology some 35 years ago. I was not aware of recent advances. Then I had to approach my gurus, Dr. Karunasagar sir and Indrani madam, and they helped me plan this program so well. We have invited very well internationally renowned experts to deliver talk. We have 14 talks and a panel discussion chaired by Dr. Shivkumar sir, and I am sure this will be a feast for students to learn about antimicrobial resistance. And One Health concept is the main goal. We are not taking only human health or animal health or poultry or fisheries alone. We are combining everything. We have invited medical fraternity, veterinary, fisheries, and agricultural fraternity for this conference. We have got overwhelming response, and we have made provision for oral presentation, where we have got more than 40 entries. We have selected among them, and they will be making presentation this afternoon and tomorrow. And students from Telangana, Andhra, Maharashtra also have come to attend this conference. That shows how important AMR is during the current period. We need to talk about AMR more in our homes, schools, workplaces. Only then we can spread awareness. As we know, use of antibiotics has been rampant. Misuse has always been there. Now, with this, I deem it a privilege to welcome you all to this 3-day national conference. a man of simplicity, humility, dedication, and vision. Our Honorable Minister for Minor Irrigation, Science and Technology has always been a source of inspiration and support for all our program. For the past 2 years, as I told, KST has organized many programs with the kind support. And I must say, for the first time in my 25 years of career in Karnataka state, I am feeling it going to minister's office as though it is my own office because of sir's generosity and ably supported by Hanchinal sir and others. And whenever I want, I just go without taking even permission or appointment. They have been very kind enough. Sir, we are truly very highly grateful to you for your simplicity, and it is a model for us to follow. All the officers should certainly emulate, sir. With this, on behalf of all of us, it is an honor and privilege to welcome our Honorable Minister, Bosraj sir, to this function. Welcome to you, sir. Our beloved Director, Department of Science and Technology, Shri Sadashiv Prabhu sir, has consistently encouraged us to organize many programs. For this program also, sir has given financial support and encouraged. On behalf of all of you, I extend a warm welcome to Prabhu sir. Esteemed DDG of ICR, Dr. Raghavendra Bhatt, as we know, he is very busy. In spite of his busy schedule, because of our request, he has come all the way from New Delhi for this function. On behalf of all of us, hearty welcome to you, sir. Dedicated teachers and internationally renowned scientists, my respected gurus, Professor Idya Karunasagar sir and Professor Indrani Karunasagar madam have played a crucial role in planning this conference and in identifying eminent scientists and scholars working on AMR for delivering distinguished talks. On behalf of KSTA, it is my privilege to welcome both sir and madam to this conference. We are also honored to have with us eminent botanist, former esteemed member of KSTA and former Vice Chancellor of Tumkur University, person of humility and very friendly nature, Professor H. Raja Saab is there with us. On behalf of all of us, hearty welcome to you, sir. I take this opportunity to welcome a constant source of encouragement and support for all of our programs, and always smiling senior KS officer and esteemed personal secretary to private secretary to Honorable Minister Shri Veerbhadra Anchinal sir. Welcome to you, sir. We have many luminaries and great scientists amongst us today. We have Dr. Rangareddy sir, who is the President of Infection Control Academy of India. Welcome to you, sir. We have Dr. Shivkumar Gowda sir. He is the Dean of Veterinary College. On behalf of all of us, welcome to you, sir. Dr. C.N. Ravishankar, former Director and Vice Chancellor, CIFE, and my good friend, hearty welcome to you. Dr. Krishna Islur sir, welcome to you, sir. Dr. Chandrasekhar Biradar is always on tour. Yesterday night I called him, today he is here. Welcome to you, sir. Dr. Srinath Ratnakumar sir, welcome to you. He is a senior scientist in ISRO, and he is the member secretary of a committee which has brought out a strategy paper on quantum science and technology for Karnataka. In fact, the chair of the committee, Dr. Usha madam, was supposed to be here, but due to her ill health, she could not be here. And we will be releasing the book today with Sir, Honorable Minister Sir will be releasing the book. And we have Dr. Ravi Kumar Vishwanath and all the Rudresh and Arun Sharanu. For all of you, hearty welcome. Senior academicians are here, young students are here, young scholars are here. for all of you, hearty welcome. And for the next 3 days, you will be having wonderful sessions. I urge all of you to make use of this conference, and you can certainly take up research in your career on antimicrobial research if you attend all the sessions. We have arranged everything right from breakfast to dinner. You can be here and enjoy our hospitality and enjoy the talks also. With this, finally, I welcome all the delegates, members of the media, and my dear colleagues to this important function. And not to forget, we have received a grant from Karnataka Science and Technology Promotion Society because of our Honorable Director, and also Karnataka Technology Innovation Society, which is also a part of Department of Science and Technology, ITBT. For both of them, we are very grateful for this support. With this, I welcome everyone. Thank you.
I also extend a warm welcome to Dr. A.M. Ramesh, CEO, KSTA. Now, the inauguration of this workshop. ಕಾರ್ಯಕ್ರಮದ ಉದ್ಘಾಟನೆ ದಯಮಾಡಿ ಶ್ರೀ ಎಸ್ ಬೋಸರಾಜು ಸಾಹೇಬರು, ಮಾನ್ಯ ಸಣ್ಣ ನೀರಾವರಿ ಹಾಗೂ ವಿಜ್ಞಾನ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಸಚಿವರು, ಕರ್ನಾಟಕ ಸರ್ಕಾರ, ಗಿಡಕ್ಕೆ ನೀರೆರೆಯುವ ಮೂಲಕ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮದ ವಿದ್ಯುಕ್ತ ಚಾಲನೆ ಉದ್ಘಾಟನೆಯನ್ನು ನೆರವೇರಿಸಿಕೊಡ್ಬೇಕು ಅಂತ ಹೇಳಿ ತಮಗೆ ಆತ್ಮೀಯವಾಗಿ ಸ್ವಾಗತ ಕೋರ್ತೇನೆ ಸರ್. ಎಲ್ಲ ಗಣ್ಯಮಾನ್ಯರು ಸನ್ಮಾನ್ಯ ಬೋಸರಾಜು ಸಾಹೇಬರಿಗೆ ಕೈ ಜೋಡಿಸ್ಬೇಕಂತ ಹೇಳಿ ಕೇಳ್ಕೊಳ್ತೇನೆ. Thank you so much, sir. We have got 2 releases in this workshop today. One is Quantum Technologies for Karnataka, a strategy paper by Dr. Srinath Ratnakumar. Please, I may now invite Dr. Srinath Ratnakumar on the stage, sir, please. ದಯಮಾಡಿ ಮಾನ್ಯ ಸಚಿವರಾದ ಬೋಸರಾಜ್ ಸಾಹೇಬರು Quantum Technologies for Karnataka, a strategy paper. May I expect a big round of applause for this release, please. So another abstract, that is abstract compendium of this conference. One more release, abstract, yeah.
In fact, it was the vision of Dr. Ayyappan sir to bring out a quantum technology paper. When he was here as a chairman, he tried, but by the time we planned, his tenure was over, and I carried it on. Thank you.
ಈಗ ಡಾಕ್ಟರ್ ಇಡ್ಯಾ ಕರುಣ್ ಸಾಗರ್ ಸಾಹೇಬರು, ಸಲಹೆಗಾರರು, ಸಂಶೋಧನೆ ಮತ್ತು ಪೇಟೆಂಟ್ಸ್, ನಿಟ್ಟೆ ವಿಶ್ವವಿದ್ಯಾಲಯ ಮಂಗಳೂರು ಹಾಗೂ ಮಾಜಿ ಹಿರಿಯ ಅಧಿಕಾರಿ, ವಿಶ್ವಸಂಸ್ಥೆ ಆಹಾರ ಮತ್ತು ಕೃಷಿ ಸಂಸ್ಥೆ FAO, ಅವರಿಗೆ ಅತ್ಯಂತ ಆತ್ಮೀಯವಾಗಿ ನುಡಿಪೀಠಕ್ಕೆ ಆಹ್ವಾನಿಸಿ ತಮ್ಮ 2 ನುಡಿಗಳನ್ನು ಆಡಬೇಕು ಅಂತ ಹೇಳಿ ಕೇಳ್ಕೊಳ್ತೇನೆ ಸರ್.
ಮಾನ್ಯ ಸಚಿವರಾದ ಕೃಷಿ ಮತ್ತು ವಿಜ್ಞಾನ ಸಚಿವರಾದ ಶ್ರೀ ಬೋಸರಾಜ್ ಅವರೇ, ಮತ್ತು ತುಮಕೂರು ವಿಶ್ವವಿದ್ಯಾಲಯದ ವಿಶ್ರಾಂತ ಕುಲಪತಿಗಳಾದ ಡಾಕ್ಟರ್ ರಾಜಸಾಹೇಬರ್ ಅವರೇ, ಭಾರತೀಯ ಕೃಷಿ ಸಂಶೋಧನಾ ಆರ್ಗನೈಸೇಷನ್, ಇಂಡಿಯನ್ ಕೌನ್ಸಿಲ್ ಆಫ್ ಅಗ್ರಿಕಲ್ಚರಲ್ ರಿಸರ್ಚ್, ಇದರ ಡಿಪ್ಟಿ ಡೈರೆಕ್ಟರ್ ಜನರಲ್ ಡಾಕ್ಟರ್ ರಾಘವೇಂದ್ರ ಭಟ್ ಅವರೇ, ಆಮೇಲೆ ಇಲ್ಲಿ ತುಂಬ ಗಣ್ಯರಿದ್ದಾರೆ. ಡಾಕ್ಟರ್ ರವಿಶಂಕರ್, ರಿಟೈರ್ಡ್ ವೈಸ್ ಚಾನ್ಸಲರ್ CAFE Mumbai, and of course Dr. Sadashiv Prabhu, who is the Director, Department of Science and Technology, Government of Karnataka, Dr. Ramesh, Mr. Anand, then Dr. Ranga Reddy, and Dean of Veterinary College, Dr. Islur, and all the distinguished speakers of this workshop or national conference. It's indeed a great pleasure for me to be part of this program, which is a national workshop on antimicrobial resistance and strategies for prevention and alternatives. Of course, this is a topic that is of great importance today. Now, we all have been hearing about COVID, which has been a pandemic, which has caused so many deaths, and we called it a pandemic. That is, it has touched everybody because so many deaths occurred at one time. But antimicrobial resistance is considered a silent pandemic. Now, deaths are occurring due to infection due to antimicrobial resistant microorganisms. But we are not realizing it as a pandemic, and it is occurring globally, not only in any country, single country, but globally. That's why antimicrobial resistance is considered a global pandemic, silent pandemic, and according to WHO estimates, about 1.3 million people die every year due to infection by antimicrobial resistant microorganisms. And as it has been pointed out earlier by Dr. Ramesh, this is not an issue only in hospitals, in the human sector, but it's also an issue in the animal sector, agriculture. So we need to address this together in all sectors. And we all realize this, antibiotics were discovered by Alexander Fleming. So he discovered something which was existing. That means antibiotics have been there in nature, and of course humans discovered it, but then started producing it and utilizing it in a big way. So similarly, microorganisms have been there in the environment, so they have been having resistance, but we have not realized how much of that was there existing in the environment before antibiotics were discovered, and they were used by humans. But once we started using them, the opportunity for microorganisms to become resistant increased, and as the use increases, the resistance also increases. So we have contributed to increase in resistance by our use of antimicrobials. And what is happening is also antimicrobial resistance can jump from one organism to another. So if it is used, for example, for a plant disease, because plants also have bacterial diseases. So to treat plant diseases, if we use antibiotics, and if there are resistant microorganisms developing there, those resistance genes can jump into either animal pathogens or human pathogens. So it does not have any borders. So there is no geographical border or any taxonomic border. So it can jump from one organism to other. So it is a great problem because it is spreading so rapidly. And today, if there are many scientists and researchers here, you are all aware, you find, wherever you look, you will find resistant microorganisms. So how to address this? So because this is involving so many different sectors, even globally there is a realization that even international organizations have to work together. Like human health, we have the WHO. For agriculture, we have the Food and Agriculture Organization. For animal health, we have the World Organization for Animal Health, or OIE, which was how it was called before. And then resistant microorganisms are there in the environment. So the United Nations Program for Environment, UNEP. So internationally this is considered a quadripartite program, and it has been highlighted not only by technical organizations of United Nations, but also at the General Assembly. So it only shows how important the problem is. And in 2016, the United Nations General Assembly highlighted the importance of antimicrobial resistance and how we need to address this. And this was again repeated in 2024. The UN General Assembly adopted a political resolution where the main thought was that we need to act now. So we have to act together. All sectors need to come together, and taking action today to achieve this freedom from to reduce the problem due to antimicrobial resistance. So this was a major decision taken by the United Nations General Assembly. So every country has realized this, and all countries are to have national action plan. So India also has national action plan, but then it's not sufficient to have national action plan, because we are almost like a federal country. So we need to come to state level, and at state level also we need to take action. So it is very apt that Karnataka Science and Technology Academy has taken this topic to highlight so that everybody is aware. So it's not the problem of doctors or veterinarians or agriculturists, but everybody need to work together, even common man, because we consume antibiotics as common man. How we consume antibiotics, and do we follow a full course, or do we take it only after prescription? So there are so many issues, even general public need to be aware. So we need to create awareness about resistance in all sectors, including common man. So this is a great topic. So I think we need to deliberate on this, and it is also technically complex. So we need to understand the technicalities involved, how resistance is emerging, how it is spreading from one sector to another. So many of the distinguished speakers will be addressing this. So I would like to congratulate Karnataka Science and Technology Academy for organizing this, and I am sure everybody will have enjoy this national conference. And to highlight the importance, the presence of the Honorable Minister here shows how much importance Karnataka government is giving to this topic. And also the Karnataka, the director from the Science and Technology department is here. So there is a great interest even in the government, and government, I understand Karnataka government also has developed a state action plan on antimicrobial resistance. This is what I was told by our colleague from WHO. He will be here shortly. Karnataka is taking lead in many of these topics. So we need to highlight it and reach everybody who is dealing with antimicrobial resistance. So once again, I would like to congratulate the Academy for taking up this topic, and also thank the Honorable Minister for his presence here, which shows the importance the government is giving for this important topic. Thank you very much.
Thank you very much, sir, for sharing your insightful words and valuable experience. Now, may I request Dr. Raghavendra Bhatta to share your few words, sir, please.
Thank you. Everybody, namaskara. Honorable Minister, dignitaries on the dais, invited delegates, students, ladies and gentlemen. If I remember, the last visit to this prestigious institute on this podium was 1st of March, I think 2021. Myself and Dr. Ravi Shankar, I think we were the first batch of KSTA fellows. We were here. Honorable our Ayyappan sir and Dr. Karunasagar were, Kasturangan were, they were there, and extremely sorry to know that his untimely demise, and I pray his soul rest in peace. I'd like to thank the KSTA for the invite. I represent the Indian Council of Agricultural Research. We have 113 research institutes. Out of that, 19 institutes are for animal science. And whenever I attend a meeting, especially with on two topics, one is on the climate change and global warming, and other is on AMR. See, though we talk about India has the highest livestock population, we have the large number of lactating cows, and we are number one in the world with regard to the milk production. We produce around 239.5 million metric tons. And the average availability of milk is also about more than 471 grams per head per day, which is much higher than the ICM requirement. And by 2030, we are expecting around 300 million metric tons, and by Viksit Bharat 2047, we are expecting around 600 million tons. But all the good news, all the time people say your cattle are producing a lot of enteric methane emission and causing global warming. And the second thing is that most of the AMR, all because of the livestock. I was very happy to see one of the articles published very recently, that a very comprehensive study conducted by the ICMR, the Cambridge University, and the CMC Vellore. The title of the article was that the hospitals are identified at the hotspots for superbugs, and not because of the animals or the environment. So I was very happy that when this AMR conference was held in Delhi, so I shared that article, and if somebody is interested, again, I can share that article with you. So that gave us a lot of confidence that what exactly is, talking about the antimicrobial resistance. See, I think many times we do agree that, we make statement, we don't have proper data. We are talking about the global warming. You said in India is producing about 20 teragrams of greenhouse gas emission. But when we really asked, who gave this data? We never had the private data. What we all did, we have the quinquennial livestock census, we have 550 million livestock, and multiplied that by the IPCC data and said, we are producing 19 teragrams of enteric methane emission, which is equating the cattle in Punjab and Haryana with that of Rajasthan, with Uttar Pradesh, and so we equated everything. The point I was trying to make, when we don't have the data, I think we should be very guarded in making statements saying that it is the livestock which is, causing the antimicrobial resistance, and the same thing is the poultry. So every time, we always have this issue that most of this, the broilers, most of these layers, especially the broilers, people keep asking, these are all, you are losing a lot of hormones, you are losing a lot of antibiotics, and before that is coming in the food chain. Okay, but if you really look at the data, see what was the poultry development that has taken place, it's not because of the hormones, it's not because of the antibiotic, it's because of the best management we give and the best breeds we have. It's not because of the, we use hormones, it's not really, worth it. Now coming to the most important component, the AMR surveillance, I would just like to highlight here what are the programs Government of India we have at the national level, and some of the bottlenecks what we have and what is the way forward. The first one is, as all of us know, that antimicrobial resistance occurs when the pathogens, they become resistant to most of these conventional drugs and used against these diseases, and it becomes making the infections extremely hard to control, and also it becomes very expensive for the treatment also. And the second point is, the antimicrobial resistance also threatens the prevention and treatment of a range of infection caused by the bacteria or the virus or the protozoa or the fungus. And the third point is, it also, we are talking about the sustainable development goals. And one of the components of the SDP is that of the health, the food security, and so that is also, is endangered because of the AMR. The genesis of the National Action Plan, it started with the Delhi Declaration. I think all of you know that in way back on the 19th of April in 2017. And out of that, we have specific objectives of the this National Action Plan. Primarily, what we wanted to do is to improve the awareness of and understanding of the AMR. The second one is strengthening the knowledge and evidence to the surveillance. That's the most important component. And reduce the incidence of the infectious through effective infection prevention as well as the control. Then optimize the use of antimicrobial agents in health, animals, and the food. Then promote investment in the AMR activities, research, and innovations, and strengthen India's leadership as far as the AMR is concerned. Now, as far as the Indian Council of Agricultural Research is concerned, we have a Indian network program. It is called the INFAR. Both fisheries and animal science are the component in that. We have 12 institutes within INFAR. It is the Indian Network on Fisheries and Animal Antimicrobial Resistance at Government of India. And we target the cattle, buffalo, pig, sheep, goat, and poultry, and specifically targeting the E. coli, Streptococcus aureus, and the CONS, the coagulase negative streptococci are the one. With regard to the Department of Health, DGHS, NCD is the one which takes care of this, and we have a 12-year plan of 2012 to 2017 was the earlier one. More or less the objectives were similar. Then we started the National Action Plan AMR2 2022 to 2028, and under the sub-project 2.1, so we have the strengthening the microbiology laboratories at different places, including the national, state, and the district level AMR detection. Then the development and implementation of the standardized protocol for pathogen identification, because there is an issue, because many times when you don't follow the proper protocol, obviously, the data cannot be compared. So we always have this issue. Somebody says it's very high titer, somebody says it's very low titer, and we also don't follow the proper protocol or the latest advanced technology. There is also a problem. And the third one is establish a mechanism for implementing laboratory quality management programs. Then establishing laboratory information management system under the WHO. With regard to the Department of Animal Husbandry and Dairying, Government of India, we have two programs which are under this. One is the National Livestock Mission. After that, we have a program, antimicrobial usage, one of the ICR Institute based in Bangalore, that is ICR Nivedi. We have the National Institute for Veterinary Epidemiology and Disease Informatics. They are working on that. And AMR specifically for poultry, so we have the Indian Veterinary Institute at Aizat Nagar. And DBT is also working on that with the, DBT Barak, the program is there. And we have developed the India's first indigenous antibiotic. I think all of you know that naphthomycin. And now it's almost ready. It has been released by the November 2024 by the Union Minister, Dr. Jitendra Singh. And it is awaiting the DGSO clearance. I think once that is ready, I think we'll be extremely confident that it will be able to address most of these issues. Now, coming to the some of the gaps, which are very, very critical, I'm sure that during this 3 days conference, we will be highlighting some of them. The most important thing is that we don't have the data, which I also mentioned. We don't have data. We always make statement, without having the actual data. So there's an agency we called INFA, that is the International Animal Health Group. So there also we ask, what is the amount of total antibiotic that is produced in India? And what is the quantity of total antibiotic that is prescribed or that is consumed in India? So we get, everyone has a different data altogether. So this is the first priority, we should have the proper database as far as the antibiotics are concerned. Then in addition to AMR, AMU, the antimicrobial usage is also very important. So we have series of these different antibiotics. So that also we don't have the proper data. The AMU is another important component. And other gap is various departments are working. We have the ICAR, we have the ICMR, we have the Department of Health, we have the state government, but always, we don't have the proper mechanism for data sharing. Since we don't share the data, so the overall picture what we get as far as this one is concerned is always, is not one figure. We have too many figures, and even when you don't have a common figure, we find it extremely difficult to know what is the way forward. And other point which I also mentioned earlier, that is, there is no uniform protocol for AMR testing or the survey. So everybody, depending on the facilities that are available, from the miniature, the smallest of the laboratories, the most sophisticated, gene identification and testing of that at a very higher level, very sophisticated level. This is the point. So the future directions which I would like to suggest at this point is, the first one is the strengthening and sustaining AMR surveillance for the future. I think that's the one point which you have to take it up. Then surveillance of antibiotic use in animals, humans, as well as in fishery, aquatic animals should be taken up. The environment and genomic surveillance for AMR, that is another important point. Then development of adequate human resource to undertake AMR activities, the laboratory network, uniform protocol for survey and the data sharing. That is the most important component. Then we also should find out what is the economic impact of all these diseases. So we really don't know. See, what is the effect of this particular disease? For example, we do that in case of the livestock diseases. For example, if you ask me what is the economic importance of the foot and mouth disease, we have the data. For the PPR, we have the data. Rinderpest, we have the data. Now, lumpy skin disease, we have the data. Similarly, all these diseases, what is the economic impact? How much of loss? And based on that, it becomes easy for you for the investment. For the government of India or for government of Karnataka, you say for example, if you don't control this disease, see the total economic income something like about 8,000 crores or the 9,000 crores or 10,000 crore rupees. Then the government will think, okay, let me invest 500 crores or 1,000 crores on this. So economic impact of the disease makes very, very crucial as far as the government decisions are to be concerned. Now the last point is the data generation on the antibiotic production and also return of the expired antibiotics. We really have no idea how much of expired antibiotics is coming back to the shelf. And do you quantify this? What is the way out? Are you going to recycle it? Are you going to dispose it off? And this is also required for quantifying over-the-counter sale. Because we have a lot of these antibiotics, we have the over-the-counter sale. So sometimes, we don't get the proper data on that. So I'm sure that all these points will be discussed and deliberated, and I would like to congratulate KSTA, especially Dr. Ramesh, for taking up this very important, and especially for the students, that it's a really great area for research, for taking up future. AMR is going to continue maybe for another 10 or 15 years, so if you really, it's a very challenging area. I call it as a really virgin area. If you really want to take up this research work and go for a higher studies, for a postdoc, I think you are in the right area and you are in the right platform. I'm sure these 2 days, you will get much more enlightened and which are the areas that can be taken up and the institutions where they are working, and I'm sure that it will be highly beneficial to all of you. So with this, once again, thank you so much. Wish you all a great day. Thanks for the opportunity.
Thank you very much, sir. We are really impressed by your ability to view complex concepts into understandable terms, and also a lot of programs on AMR and the way forward. Thank you so much, sir. May I now request Professor H. Raja Saab, ಇವರು ಮುಖ್ಯ ಸಂಶೋಧನಾ ಸಲಹೆಗಾರರು RUAS ಮತ್ತು ವಿಶ್ರಾಂತ ಕುಲಪತಿಗಳು ತುಮಕೂರು ವಿಶ್ವವಿದ್ಯಾಲಯ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. ನಮ್ಮ ಅಕಾಡೆಮಿ ಮತ್ತು ಅವರ ಅಕಾಡೆಮಿಗೆ ಬಂದಿರುವಂಥ ಮಾನ್ಯ ಮಂತ್ರಿಗಳಿಗೆ ವಿಶೇಷವಾದ ಆಹ್ವಾನ. ವೈಯಕ್ತಿಕವಾಗಿ ತಾವೆಲ್ಲರೂ ಭಾರತದ ಬೇರೆ ಬೇರೆ ಪ್ರದೇಶಗಳಿಂದ ಬಂದಿದ್ದೀರಿ. ತಮ್ಮೆಲ್ಲರಿಗೂ ಸ್ವಾಗತ. ಇಂತಹ ಒಳ್ಳೆಯ ಕಾನ್ಫರೆನ್ಸನ್ನು ಆರ್ಗನೈಸ್ ಮಾಡಿ ನಮ್ಮನ್ನು ಇಲ್ಲಿಗೆ ಬರಮಾಡಿಕೊಂಡದಕ್ಕಾಗಿ ಡಾಕ್ಟರ್ ರಮೇಶ್ ಮತ್ತು ಇನ್ನುಳಿದ ಎಲ್ಲ ಅಕಾಡೆಮಿಯ ಆಫೀಸರ್ಸ್ಗಳಿಗೆ ನನ್ನ ವೈಯಕ್ತಿಕವಾದ ಧನ್ಯವಾದಗಳು. ಆಂಟಿಮೈಕ್ರೋಬಿಯಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್. ಇದು ನಿರಂತರವಾಗಿ ನಡೆದು ಬರ್ತಕ್ಕಂಥ ಕ್ರಿಯೆ. ಇವತ್ತಿಂದಲ್ಲ, ನಾಳೆದೂ ಅಲ್ಲ, ನಿರಂತರವಾಗಿ ಇಡುತ್ತೆ ಇದು. ಎಲ್ಲಿವರೆಗೂ ಸಸ್ಯಗಳು, ಪ್ರಾಣಿಗಳು, ವನ್ಯಜೀವಿಗಳು, ಮನುಷ್ಯರು ಇದ್ದಾರೋ ಅಲ್ಲೇವರೆಗೂ ಇದು ಆಂಟಿಮೈಕ್ರೋಬಿಯಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಪ್ರಾಬ್ಲಮ್ ಇದ್ದೇ ಇರುತ್ತೆ. ಇದೊಂಥರ ಬಯೋಲಾಜಿಕಲ್ ವಾರ್ಫೇರ್ ಇದ್ದ ಹಾಗೆ. ಈ ಮೈಕ್ರೋಬ್ಸನ್ನು ನಾವು ನಮ್ಮ ವೈರಿಗಳು ಅಂತ ತಿಳಿಯುವ ಅವಶ್ಯಕತೆಯೂ ಇಲ್ಲ. ಭಾಳಷ್ಟು ಒಳ್ಳೆಯ ಮೈಕ್ರೋಬ್ಸು ಇದ್ದಾವೆ. ಆದರೆ ನಮಗೆ ತೊಂದರೆ ಕೊಡುವಂಥ ಮೈಕ್ರೋಬ್ಸು ಪ್ಯಾಥೋಜನ್ಸ್ ಅಂತ ನಾವು ಹೇಳ್ತೀವಿ. ಅದ್ರ ಬಗ್ಗೆ ನಾವು ಅಂದರೆ ಎಲ್ಲ ಸಮಸ್ತ ಜೀವಿಗಳು ಹುಷಾರಾಗಿರಬೇಕಾಗುತ್ತೆ. ಆದ್ದರಿಂದನೇ ಲೂಯಿಸ್ ಪಾಶ್ಚರ್ನಿಂದ ಹಿಡಿದು ಇಲ್ಲಿಯವರೆಗೂ ಆಂಟಿಬಯೋಟಿಕ್ಗಳ ಡಿಸ್ಕವರಿ ಆಗಿದೆ. ಈಗ ಆಲ್ಮೋಸ್ಟ್ ಎಲ್ಲಿನೂ ನಾವು ಪೆನ್ಸಿಲಿನ್ ನೋಡೋದಿಲ್ಲ. ಕಾರಣ ಏನಂದರೆ ನಮ್ಮ ಎಲ್ಲ ಸೂಕ್ಷ್ಮಜೀವಿಗಳು, ಬ್ಯಾಕ್ಟೀರಿಯಾಗಳನ್ನ ಹಿಡ್ಕೊಂಡು ರೆಸಿಸ್ಟೆನ್ಸನ್ನು ಪಡ್ಕೊಂಡಿದ್ದಾವೆ. ಈ ರೆಸಿಸ್ಟೆನ್ಸ್ ಅವು ಯಾಕೆ ಪಡ್ಕೊಳ್ತವೆ? ಅವು ಸಹ ಸರ್ವೈವ್ ಆಗಬೇಕು. ಆದ್ದರಿಂದ ಸಹಜವಾಗಿಯೇ ಅವು ಏನು ಅಡೆತಡೆಗಳು ಇರ್ತವೆ ಆಂಟಿಬಯೋಟಿಕ್ಸ್ನಿಂದ, ಆ ಆಂಟಿಬಯೋಟಿಕ್ಗಳನ್ನು ನಲ್ಲಿಫೈ ಮಾಡಲಿಕ್ಕೆ ರೆಸಿಸ್ಟೆನ್ಸನ್ನು ಪಡ್ಕೊಳ್ತವೆ. ಇದು ಪ್ರಕೃತಿಯಲ್ಲಿ ಯಾವಾಗಲೂ ನಡೆದುಕೊಂಡು ಬಂದಂತಹ ಕ್ರಿಯೆ. ಪ್ರಾಚೀನ ಭಾರತದಲ್ಲಿ ಪೆನ್ಸಿಲಿನ್ ಆಗೋದಕ್ಕಿಂತ ಮೊದಲಿನಿಂದನೂ ಆಯುರ್ವೇದದಲ್ಲಿ, ಸಿದ್ಧದಲ್ಲಿ ಹಾಗೂ ಇನ್ನಿತರೆ ಟ್ರೆಡಿಷನಲ್ ಮೆಡಿಸಿನ್ ಸಿಸ್ಟಮ್ಸ್ನಲ್ಲೂ ಇಂಡೈರೆಕ್ಟಾಗಿ ಆಂಟಿಬಯೋಟಿಕ್ಸ್ಗಳನ್ನು ನಾವು ಉಪಯೋಗಿಸ್ತಾ ಇದ್ದೀವಿ. ನಮ್ಮ ಆಹಾರ ಪದ್ಧತಿಯಲ್ಲೂ ಹಲವಾರು ನಾವು ಏನು ಆಹಾರಗಳನ್ನು ನಾವು ಸೇವಿಸ್ತೀವಿ ಅದರಲ್ಲಿ ಮೈಕ್ರೋಬ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಮಾಡುವಂಥ ಶಕ್ತಿ ಆಹಾರ ಪದಾರ್ಥಗಳಲ್ಲೂ ಇದೆ. ನಾವು ಸೇವಿಸುವ ಆಹಾರ ಪದಾರ್ಥದಲ್ಲಿ ಒಂದು ವೇಳೆ ಮೈಕ್ರೋಬ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಆಗುವಂಥ ಶಕ್ತಿ ಇಲ್ಲದೇ ಇದ್ದಿದ್ದರೆ ನಾವು ಯಾರೂ ಇಲ್ಲಿರ್ತಾ ಇರಲಿಲ್ಲ. ಆದ್ದರಿಂದ ಪ್ರಕೃತಿನಲ್ಲಿ ಯಾವಾಗಲೂ ನಡೀತಾ ಇರುವಂಥ ಕ್ರಿಯೆ. ವರ್ಲ್ಡ್ ಬ್ಯಾಂಕ್ ಪ್ರಕಾರ ಲ್ಯಾನ್ಸೆಟ್ನಲ್ಲಿ ಒಂದು ಪೇಪರ್ ಪಬ್ಲಿಷ್ ಆಗಿದೆ 2022ರಲ್ಲಿ. ಅದರ ಪ್ರಕಾರ 2019ನೇ ಇಸ್ವಿವರೆಗೂ ಇಲ್ಲಿವರೆಗೂ ಸುಮಾರು 1.27 ಮಿಲಿಯನ್ ಜನರು ಆಂಟಿ ಮೈಕ್ರೋಬಿಯಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ನಿಂದ ಸಾವನ್ನಪ್ಪಿದ್ದಾರೆ. ಅಂದರೆ ಡ್ರಗ್ಸ್ ಏನು ಎಫೆಕ್ಟ್ ಮಾಡಲಿಲ್ಲ. ವರ್ಲ್ಡ್ ಬ್ಯಾಂಕ್ ಎಸ್ಟಿಮೇಟ್ ಪ್ರಕಾರ 2050ರ ಹೊತ್ತಿಗೆ 28 ಮಿಲಿಯನ್ ಜನರಿಗೆ ಸಾವಿನ ನಿರೀಕ್ಷೆ ಇದೆ. ಇಲ್ಲೇ ಗೊತ್ತಾಗುತ್ತೆ ಆಂಟಿಬಯೋಟಿಕ್ ರೆಸಿಸ್ಟೆನ್ಸು ಎಷ್ಟು ಇಂಪಾರ್ಟೆಂಟ್ ಆಗುತ್ತೆ. ಅದರ ವಿರುದ್ಧ ನಾವು ನಮ್ಮ ಸಂಶೋಧನೆಗಳನ್ನು ಕೈಗೊಳ್ಳಬೇಕಾಗುತ್ತೆ. ಉದಾಹರಣೆಗೆ ಬೀಟಾ ಲ್ಯಾಕ್ಟೇಸ್ ಡೆಸ್ಟ್ರಾಯಿಂಗ್ ಪೆನಿಸಿಲಿನ್ ಇದೇನೆಂದರೆ ಎನ್ಸೈಮ್ ಇನ್ಯಾಕ್ಟಿವೇಷನ್ ಮಾಡುವಂಥ ಕ್ರಿಯೆ ಬ್ಯಾಕ್ಟೀರಿಯಾಗಳಲ್ಲಿ, ಪ್ಯಾಥೋಜೆನಿಕ್ ಬ್ಯಾಕ್ಟೀರಿಯಾಗಳಲ್ಲಿ ನಡೆಯುತ್ತೆ. ಆಮೇಲೆ ಡ್ರಗ್ಗನ್ನು ಟಾರ್ಗೆಟ್ ಮಾಡಲಿಕ್ಕೆ MRSA ವಿತ್ ಮಾಡಿಫೈಡ್ PBP ಸಿಸ್ಟಮ್ ಬ್ಯಾಕ್ಟೀರಿಯಾದಲ್ಲಿ ಡೆವಲಪ್ ಆಗುತ್ತೆ. ಪೋರಿನ್ ಲಾಸ್ ಇನ್ ಎಸ್ಚೆರಿಷಿಯಾ ಕೋಲಿ ಪರ್ಮಿಯಬಿಲಿಟಿಯನ್ನೇ ಸ್ಟಾಪ್ ಮಾಡುತ್ತೆ, ಆಂಟಿಬಯೋಟಿಕ್ಗಳ ಪರ್ಮಿಯಬಿಲಿಟಿಯನ್ನು. ಹೀಗೆ ಹಲವಾರು ಎಕ್ಸಾಂಪಲ್ಗಳಿದ್ದಾವೆ. ಸುಮಾರು 2000 ಇಸ್ವಿವರೆಗೂ 1980ರಿಂದ 2000 ಇಸ್ವಿವರೆಗೂ 30 ಆಂಟಿಬಯೋಟಿಕ್ಗಳನ್ನು ವಿಜ್ಞಾನಿಗಳು ಕಂಡುಹಿಡಿದಿದ್ದಾರೆ. 2000ರಿಂದ ಇಲ್ಲಿವರೆಗೂ ಹೆಚ್ಚು ಕಡಿಮೆ 15 ಹೊಸ ಆಂಟಿಬಯೋಟಿಕ್ಗಳನ್ನು ಕಂಡುಹಿಡಿದಿದ್ದಾರೆ. ಆದರೆ ಇಷ್ಟು ಆಂಟಿಬಯೋಟಿಕ್ಗಳಿಗೆ ಒಂದಲ್ಲ ಒಂದು ಮೈಕ್ರೋಬ್ ಸೂಕ್ಷ್ಮಜೀವಿ ರೆಸಿಸ್ಟೆನ್ಸನ್ನು ಬೆಳೆಸ್ಕೊಳ್ಳುತ್ತೆ. ಸೈಂಟಿಸ್ಟ್ಗಳು ಒಂದು ಆಂಟಿಬಯೋಟಿಕ್ ರಿಸರ್ಚ್ ಮಾಡಿ ಸಕ್ಸಸ್ಫುಲ್ ಆಂಟಿಬಯೋಟಿಕ್ಕನ್ನು ಎಲ್ಲ ಟೆಸ್ಟ್ ಮಾಡಿ ಹೊರ ತರೋದಕ್ಕೆ ಹೆಚ್ಚು ಕಡಿಮೆ 5ರಿಂದ 10 ವರ್ಷ ಬೇಕು ಒಂದು ಆಂಟಿಬಯೋಟಿಕ್. ಆದರೆ ಮೈಕ್ರೋಬ್ಸ್, ಪ್ಯಾಥೋಜನ್ಸು 3 ವರ್ಷ, 2 ವರ್ಷ ನೀವು ಎಷ್ಟು ಅದರ ಮೇಲೆ ಪ್ರೆಷರ್ ಹಾಕ್ತಿರೋ ಅಷ್ಟು ರೆಸಿಸ್ಟೆನ್ಸನ್ನು ಹೆಚ್ಚು ಮಾಡಿಕೊಳ್ಳುತ್ತೆ. ಆದ್ದರಿಂದನೇ ಓವರ್ ಯೂಸ್ ಆಫ್ ಆಂಟಿಬಯೋಟಿಕ್ಸ್ನಿಂದ ಆಂಟಿಮೈಕ್ರೋಬಿಯಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಉತ್ಪತ್ತಿಯಾಗುತ್ತೆ. ನಾವು ಎಷ್ಟು ಒಬ್ಬ ವ್ಯಕ್ತಿ ಮೇಲೆ ಪ್ರೆಷರ್ ಹಾಕ್ತೀವೋ ಅಷ್ಟು ನಿಮ್ಮ ವಿರೋಧ ಮಾಡ್ತಾನೆ ಆ ವ್ಯಕ್ತಿ. ಸೇಮ್ ಪ್ರಿನ್ಸಿಪಲ್ ಮೈಕ್ರೋಬ್ಸ್ನಲ್ಲೂ ಆಗುತ್ತೆ. ಉರ್ದುನಲ್ಲಿ ಸರ್ ಅವರು ರಾಯಚೂರಿಂದ ಬಂದವರು, ಅವರಿಗೆ ಉರ್ದು ಭಾಳ ಚೆನ್ನಾಗಿ ಗೊತ್ತಿದೆ. ಉರ್ದುನಲ್ಲಿ ಒಂದು ಸೇಯಿಂಗ್ ಇದೆ, ದುಶ್ಮನ್ ಬಾಹರ್ ನೈ, ವೈರಿ ಹೊರಗಡೆ ಇಲ್ಲ. ಬಾಹರ್ ಮತ್ ಢೂಂಡೋ, ವೈರಿಯನ್ನು ಹೊರಗಡೆ ಹುಡುಕಬೇಡಿ. ದುಶ್ಮನ್ ಆಪ್ಕೆ ಅಂದರಿ ಹೇ, ನಿಮ್ಮ ಒಳಗಡೆನೇ ವೈರಿ ಇದ್ದಾನೆ ಅಂತ. ನಮ್ಮಲ್ಲೂ ಇದ್ದಾನೆ. ನಮ್ಮ ಶರೀರದ ವಿವಿಧ ಭಾಗಗಳಲ್ಲಿ ಆಲ್ರೆಡಿ ಮೈಕ್ರೋಬ್ಸ್ ಈಗಲೂ ಇದೆ. ಆದರೂ ನಾನು ಇಲ್ಲಿ ನಿಂತು ಮಾತಾಡ್ತಿದ್ದೀನಿ, ಜೀವಂತವಾಗಿದ್ದೀನಿ ಅನ್ನೋದಕ್ಕೆ ಕಾರಣ ಏನಂದರೆ, ನನ್ನಲ್ಲಿ ಮೈಕ್ರೋಬ್ಸ್ ಈ ಸೂಕ್ಷ್ಮ ಜೀವಿಗಳು ಏನು ಅಟ್ಯಾಕ್ ಮಾಡ್ತವೆ, ರೆಸಿಸ್ಟೆನ್ಸ್ ಮಾಡೋ ಕೆಪಾಸಿಟಿ ನಮ್ಮಲ್ಲಿದೆ. ಆದ್ದರಿಂದ ನಾವು ಬದುಕಿದ್ದೀವಿ. ವಯಸ್ಸು ಆಗ್ತಾ ಆಗ್ತಾ ಜನಗಳು ಯಾಕೆ ಸಾಯ್ತಾರೆ? ರೆಸಿಸ್ಟೆನ್ಸ್ ಕಡಿಮೆ ಆಗುತ್ತೆ. ಈ ಥ್ರೋಟ್ನಲ್ಲಿರೋ ಬ್ಯಾಕ್ಟೀರಿಯಾನೇ ಶ್ವಾಸಕೋಶಗಳಿಗೆ ಹೋಗ್ತವೆ, ನ್ಯೂಮೋನಿಯಾ ಆಗುತ್ತೆ. ಅವು ಆಲ್ರೆಡಿ ಇದ್ದಾವೆ ನಮ್ಮಲ್ಲಿ. ನಾವು ಹೆಚ್ಚು ಹೆಚ್ಚು ಆಂಟಿಬಯೋಟಿಕ್ಸ್ ನಾವು ಎಷ್ಟು ಬಳಸ್ತೀವೋ ಅಷ್ಟು ಬೇಗ ಬೇಗ ಅವು ರೆಸಿಸ್ಟೆನ್ಸನ್ನು ಮಾಡಿಕೊಂಡು ನಮ್ಮನ್ನು ಅಟ್ಯಾಕ್ ಮಾಡ್ತವೆ. ಸೊ ಫಿಲಾಸಫಿ ಇಷ್ಟೇ. ನಮ್ಮ ರಿಸರ್ಚ್, ನಮ್ಮ ರಾಘವೇಂದ್ರ ಭಟ್ ಅವರು ಭಾಳ ಚೆನ್ನಾಗಿ ಮಾತಾಡಿದರು. ಮುಂದಿನ ಯೋಜನೆಗಳ ಬಗ್ಗೆನೂ ಮಾತಾಡಿದರು. ರಿಸರ್ಚ್ ನಿರಂತರವಾಗಿ ನಡಿಬೇಕು, ಅದಕ್ಕೆ ಸರಿಯಾದ ಸಲಕರಣೆಗಳು ಇರಬೇಕು, ವೈಜ್ಞಾನಿಕ ಅನ್ವೇಷಣೆಗಳಾಗಬೇಕು, ಹೊಸ ಹೊಸ ಆಂಟಿಬಯೋಟಿಕ್ಗಳು ಬರಬೇಕು. ಬರೀ ಬ್ಯಾಕ್ಟೀರಿಯಾಕ್ಕೆ ಅಷ್ಟೇ ಅಲ್ಲ, ಇನ್ನು ಉಳಿದ ಸೂಕ್ಷ್ಮಜೀವಿಗಳು, ಫಂಗೈ, ವೈರಸಸ್, ಇವಕ್ಕೆಲ್ಲ, ವೈರಸ್ಗೆ ಈಗ ಆಂಟಿಬಯೋಟಿಕ್ ಇಲ್ಲ, ಇವೆಲ್ಲ ಬರಬೇಕು. ಆವಾಗ ನಮ್ಮಲ್ಲಿ ಹೆಚ್ಚು ಇಳುವರಿ ಮಾಡ್ಬೋದು, ಹೆಚ್ಚು ಆರೋಗ್ಯವಂತ ಪ್ರಜೆಗಳನ್ನು ಹೊಂದ್ಬೋದು. ಆದ್ದರಿಂದ ಇದು ನಿರಂತರವಾದ ಕ್ರಿಯೆ, ಇವತ್ತಿಗೆ ಮುಗಿಯುವಂಥದ್ದಲ್ಲ. ಎಲ್ಲಿವರೆಗೂ ಜೀವರಾಶಿಗಳು ಈ ಜಗತ್ತಿನಲ್ಲಿದ್ದಾವೋ ಅಲ್ಲಿವರೆಗೂ ಬಯೋಲಾಜಿಕಲ್ ಸಂಘರ್ಷ ನಡೀತಾ ಇರುತ್ತೆ. ಹಾಗಾದರೆ ಸೊಲ್ಯೂಷನ್ ಏನು? ಸೊಲ್ಯೂಷನ್ನು ಬಹಳ ಯೋಚಿಸಿ ವೈಜ್ಞಾನಿಕ ದೃಷ್ಟಿಯಿಂದ ಮಾತ್ರ ಆಂಟಿಬಯೋಟಿಕ್ಸನ್ನು ನಾವು ಸೇವನೆ ಮಾಡಬೇಕು. ಈಗ ಹೊರದೇಶಗಳಲ್ಲಿ ಒಂದು ಆಂಟಿಬಯೋಟಿಕ್ ತೊಗೊಳ್ಬೇಕಂದ್ರೆ ಅಷ್ಟು ಸುಲಭದ ಕೆಲಸ ಅಲ್ಲ. ಡಾಕ್ಟ್ರ್ ಹತ್ರ ಹೋಗ್ಬೇಕು, ಪ್ರಿಸ್ಕ್ರಿಪ್ಷನ್, ಡಾಕ್ಟ್ರ್ ಹತ್ರ ಹೋಗೋಕ್ಕೂ ನೀವು ವೆಯ್ಟ್ ಮಾಡಬೇಕಾಗುತ್ತೆ 3 ತಿಂಗಳು, 1 ತಿಂಗಳು, 5 ತಿಂಗಳು. ಪ್ರಿಸ್ಕ್ರಿಪ್ಷನ್ ಇಲ್ಲದೆ ಆಂಟಿಬಯೋಟಿಕ್ ಸಿಕ್ಕೋದಿಲ್ಲ ಅಮೆರಿಕದಲ್ಲಿ. ನಮ್ಮಲ್ಲಿ ರೋಡ್ನಲ್ಲಿ ಸಿಗ್ತವೆ, ಎಲ್ಲಿ ಹೋದರೂ ಸಿಗ್ತವೆ ಆಂಟಿಬಯೋಟಿಕ್. ನೀವು ಯಾವ ಆಂಟಿಬಯೋಟಿಕ್ ಕೇಳ್ತೀರಿ ಅದು ಕೊಡ್ತಾರೆ. ಡ್ರಗ್ ಕಂಟ್ರೋಲ್ ಮಸೂದೆ ಇದೆ, ಆದರೆ ಅದನ್ನು ಯಾರೂ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡಿಲ್ಲ. ಇಲ್ಲ, ಅದನ್ನು ಎಫೆಕ್ಟಿವ್ ಆಗಿ ಜಾರಿಗೆ ತರೋದರಲ್ಲಿ ನಾವು ವಿಫಲರಾಗಿದ್ದೀವಿ. ನಮ್ಮ ಜನತೆಯ ಕೋಆಪ್ರೇಷನ್ ಇದರಲ್ಲಿ ಬಹಳ ಮುಖ್ಯ. ಅಂದರೆ ಅವರಿಗೆ ಈ ವೈಜ್ಞಾನಿಕ ತಿಳುವಳಿಕೆ ಇಲ್ಲ. ಡಾಕ್ಟ್ರು 4 ಮಾತ್ರೆ ಕೊಟ್ಟರೆ 4 ಯಾಕೆ ಸೇವಿಸೋದು, 4 ದಿನ ಯಾಕೆ, 2 ದಿನ ಸಾಕು, ಸ್ವಲ್ಪ ಆರಾಮಾಗುತ್ತೆ, ಆರಾಮಾಯಿತು. ಡೋಸೇಜ್ ಸರಿಯಾಗಿ ತಗೊಳ್ಳಿಲ್ಲ, ಕೋರ್ಸ್ ಕಂಪ್ಲೀಟ್ ಮಾಡಲಿಲ್ಲ. ಹೀಗೆ ಮಾಡ್ಕೊಳ್ತಾ ಹೋದಾಗ ಆ ಬ್ಯಾಕ್ಟೀರಿಯಾ ರೆಸಿಸ್ಟೆನ್ಸನ್ನು ಡೆವಲಪ್, ಸ್ಲೋ ಆಗಿ ಅದು ರೆಸಿಸ್ಟೆನ್ಸ್ ಡೆವಲಪ್ ಮಾಡುತ್ತೆ. ನಾಳೆ ನೀವು ಎಫೆಕ್ಟಿವ್ ಆಂಟಿಬಯೋಟಿಕ್ ತೊಗೊಂಡ್ರೂ ಬ್ಯಾಕ್ಟೀರಿಯಾ ಇನ್ಎಫೆಕ್ಟಿವ್ ಮಾಡ್ತದೆ. ಇದು ಬಹಳ ಮುಖ್ಯವಾದದ್ದು. ಆದ್ದರಿಂದ ಜನರಿಗೆ ಶಿಕ್ಷಣವನ್ನು ಕೊಡಬೇಕು ಈ ವಿಷಯದ ಬಗ್ಗೆ. ಡಾಕ್ಟ್ರ್ ಕನ್ಸಲ್ಟ್ ಮಾಡಬೇಕು, ಹೇಳಿದ ಮೆಡಿಸಿನ್ ತಗೋಬೇಕು, ಕರೆಕ್ಟ್ ಡೋಸೇಜ್ನಲ್ಲಿ ತಗೋಬೇಕು, ಕರೆಕ್ಟ್ ಅವಧಿ ಮುಗಿಯೋವರೆಗೂ ತಗೋಬೇಕು. ಆಮೇಲೆ ಒನ್ ಹೆಲ್ತ್ ಕಾನ್ಸೆಪ್ಟ್ ಡಾಕ್ಟರ್ ರಮೇಶ್ ಅವರು ಹೇಳ್ತಾಯಿದ್ರು, ಸೆಂಟ್ರಲ್ ಗೌರ್ಮೆಂಟು ಎಲ್ಲ ಗೌರ್ಮೆಂಟ್ಗಳದ್ದು ಇಂಪಾರ್ಟೆಂಟ್ ಕಾನ್ಸೆಪ್ಟ್ ಇದು, ಒನ್ ಹೆಲ್ತ್ ಕಾನ್ಫರೆನ್ಸ್. ಯಾವುದೇ ಒಂದು ರೋಗವನ್ನು ನಾವು ಟ್ರೀಟ್ ಮಾಡಬೇಕು ಅಂದರೆ ಬರೀ ಒಂದು ಸಿಸ್ಟಮ್ ಆಫ್ ಮೆಡಿಸಿನ್ ಫಾಲೋ ಮಾಡಿದರೆ ಅಷ್ಟೇ ಸಾಲ್ದು. ಅಲೋಪತಿ, ಆಯುರ್ವೇದ, ಸಿದ್ಧ, ಯುನಾನಿ, ಯೋಗ, ಡಿಸಿಪ್ಲಿನ್ಡ್ ಲೈಫು, ಗುಡ್ ಫುಡ್ಡು, ಜೊತೆಗೆ ಜೀನ್ ಬೇಸ್ಡ್ ಥೆರಪಿ. ಅಂದರೆ ನಮ್ಮಲ್ಲಿ ನಾವು ಪ್ರತಿಯೊಬ್ಬರದಲ್ಲೂ ನಮ್ಮ ಸೆಟ್ ಆಫ್ ಜೀನ್ಸ್ ನಮ್ಮ ಬೇರೆ ಬೇರೆ ಇದ್ದಾವೆ. ನಾನು ಪೆನ್ಸಿಲಿನ್ಗೆ ರಿಯಾಕ್ಟ್ ಮಾಡ್ಬೋದು, ಇನ್ನೊಬ್ಬರು ಅದಕ್ಕೆ ಒಳ್ಳೇದಿರ್ಬೋದು ಅವ್ರಿಗೆ. ಒಬ್ಬರಿಗೆ ಆಂಫಿಸಿಲಿನ್ ರಿಯಾಕ್ಟ್ ಮಾಡ್ಬೋದು, ಇನ್ನೊಬ್ಬರಿಗೆ ಕ್ಲೋರೋಮೈಸ್ಟಿನ್ ರಿಯಾಕ್ಷನ್ ಆಗ್ಬೋದು. ಎಲ್ಲರಿಗೂ ಒಂದೇ ಆಂಟಿಬಯೋಟಿಕ್ ಡಾಕ್ಟ್ರ್ ಕೊಟ್ಟರೆ ಅದು ಅನ್ಸೈಂಟಿಫಿಕ್. ಅಂದರೆ ನಿಮ್ಮ ಜೆನೆಟಿಕ್ ಮೇಕಪ್ ಪ್ರಕಾರ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಗಳನ್ನು ಡಿಸೈಡ್ ಮಾಡಿದಾಗ ಎಫೆಕ್ಟ್ ಜಾಸ್ತಿ ಇರುತ್ತೆ, ರೋಗ ಬೇಗ ಗುಣವಾಗ್ತದೆ. ಸೊ ಒನ್ ಹೆಲ್ತ್ ಥೆರಪಿ, ಜೀನ್ ಬೇಸ್ಡ್ ಥೆರಪಿ, ಒಬ್ಬೊಬ್ರಿಗೂ ವ್ಯತ್ಯಾಸ ಇರುತ್ತೆ. ಅದಕ್ಕೆ ಏನಾದರೂ ಕಿಟ್ಸ್, ಫಾಸ್ಟ್ ಡಯಾಗ್ನೋಸಿಂಗ್ ಕಿಟ್ಸ್ ಬಂದರೆ ಆ ಕಿಟ್ನಿಂದ ನನ್ನನ್ನು ಟೆಸ್ಟ್ ಮಾಡಿ ಇವರಿಗೆ ಈ ಆಂಟಿಬಯೋಟಿಕ್ ಪ್ರಾಪರ್ ಅಂತ ಗೊತ್ತಾದರೆ ಆ ಆಂಟಿಬಯೋಟಿಕ್ ಡಾಕ್ಟ್ರ್ ಕರೆಕ್ಟ್ ಡೋಸೇಜ್ ಕೊಟ್ಟರೆ ಮೈಕ್ರೋಬಿಯಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಸ್ವಲ್ಪ ಹತೋಟಿಯಲ್ಲಿಡಲಿಕ್ಕೆ ಸಹಾಯ ಆಗ್ತದೆ. ಸುಮ್ಮನೆ ಆಂಟಿಬಯೋಟಿಕ್ ತಗೊಳ್ಳೋದು ತಪ್ತದೆ. ಇನ್ನೂ ಹಲವಾರು ಮೆಥಡ್ಗಳಿದ್ದಾವೆ. ಪೇಜ್ ಥೆರಪಿ ಬಂದಿದೆ, ಅಂದರೆ ಬ್ಯಾಕ್ಟೀರಿಯಾಗಳನ್ನು ಸಾಯಿಸೋದು, ಫೇಜ್ ವೈರಸ್ ಯೂಸ್ ಮಾಡಿ. ಆಮೇಲೆ CRISPR ಕ್ರಿಸ್ಪರ್ ಜೀನ್ ಎಡಿಟಿಂಗ್, ಯಾವ ಜೀನು ಆಂಟಿಬಯೋಟಿಕ್ ರೆಸಿಸ್ಟೆನ್ಸ್ಗೆ ಸಂಬಂಧಪಟ್ಟಿದ್ದಾವೋ ಬ್ಯಾಕ್ಟೀರಿಯಾಗಳಲ್ಲಿ ಆ ಜೀನ್ಗಳನ್ನು ಎಡಿಟ್ ಮಾಡೋದು ಅಥವಾ ತೆಗೆದುಹಾಕೋದು ಸಾಧ್ಯತೆ ಇದೆ. ಇವು ಹೊಸ ಟೆಕ್ನಾಲಜೀಸು. ವ್ಯಾಕ್ಸಿನೇಷನ್ನು, ಈ ರೀತಿ ಹಲವಾರು ಪ್ರೋಗ್ರಾಮ್ಗಳು ಇದ್ದಾವೆ ಗೌರ್ಮೆಂಟ್ದು. ಅವನ್ನೆಲ್ಲ ಸಮಗ್ರವಾಗಿ ಉಪಯೋಗ ಮಾಡಿದರೆ ಸಾಧ್ಯತೆ ಇದೆ. ಆಮೇಲೆ ನಮ್ಮ ಫುಡ್ ಸಿಸ್ಟಮ್ನಲ್ಲೂ ಯಾವ ಕಾಯಿಲೆಗೆ ಯಾವ ಫುಡ್ ಒಳ್ಳೆಯದು. ನಮ್ಮ ಅರಿಶಿನದಲ್ಲಿ ಆಂಟಿಬಯೋಟಿಕ್ ಇದೆ, ಟರ್ಮರಿಕ್ನಲ್ಲಿ ಆಂಟಿಬಯೋಟಿಕ್ ಇದೆ, ಹಲವಾರು ಪ್ಲ್ಯಾಂಟ್ ಪ್ರಾಡಕ್ಟ್ಸ್ನಲ್ಲಿ ಆಂಟಿಬಯೋಟಿಕ್ಸ್ ಇದ್ದಾವೆ. ಟ್ರೆಡಿಷನಲ್ ಸಿಸ್ಟಮ್ ಆಫ್ ಮೆಡಿಸಿನ್ನು ಕಂಪ್ಲೀಟಾಗಿ ಅನ್ಸೈಂಟಿಫಿಕ್ ಅಲ್ಲ, ಇಟ್ ಈಸ್ ಸೈಂಟಿಫಿಕ್ ಓನ್ಲಿ, ಪ್ರಾಕ್ಟೀಸ್ಡ್ ಥ್ರೂ ಜನರೇಷನ್ಸ್. ಸೊ ಸೈಂಟಿಫಿಕ್ ಯೂಸ್ ಆಫ್ ಫುಡ್, ವಾಟ್ ಫುಡ್ ಫಾರ್ ವಾಟ್ ಏಲ್ಮೆಂಟ್, ಅದು ಇಂಪಾರ್ಟೆಂಟ್. ಹೀಗೆ ಹಲವಾರು ವಿಷಯಗಳು ಭಾಳ ಇಂಟ್ರೆಸ್ಟಿಂಗ್ ಇದ್ದಾವೆ. ಹಾಸ್ಪಿಟಲ್ಸ್ ಆರ್ ದಿ ಹಾಟ್ ಸ್ಪಾಟ್ಸ್ ಆಫ್, ದೇ ಗಿವ್ ಎನ್ ಅಪರ್ಚುನಿಟಿ ಫಾರ್ ದೀಸ್ ಮೈಕ್ರೋಬ್ಸ್ ಟು ಡೆವಲಪ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಅನ್ನೋದು ಒಪ್ತಕ್ಕಂಥ ವಿಷಯ. ಭಾಳ ಇಂಟ್ರೆಸ್ಟಿಂಗ್ ಟಾಪಿಕ್ ಅದು. ನಾನು ಅದನ್ನು ಬರ್ಕೊಂಡು ಬಂದಿದ್ದೆ. ಹಾಸ್ಪಿಟಲ್ನಲ್ಲೇ ಜಾಸ್ತಿ ರೆಸಿಸ್ಟೆನ್ಸ್ ಆಗೋದು, ಯಾಕೆಂದರೆ ಅಲ್ಲಿ ವೀಕ್ ರೋಗಿಗಳಿರ್ತಾರೆ. ಹ್ಯೂಮನ್ ಬೀಯಿಂಗ್ಸ್ ವೀಕ್ ಆಗಿರೋರಿಗೆ ಕಾಯಿಲೆ ಬರೋದು, ಕಾಯಿಲೆ ಬಂದವರು ಹಾಸ್ಪಿಟಲ್ಗೆ ಹೋಗ್ತಾರೆ. ಆವಾಗ ಅಲ್ಲಿರುವಂಥ ಮೈಕ್ರೋಬ್ಸ್ಗೆ ಹೊಸ ಅಪರ್ಚುನಿಟಿ ಸಿಕ್ಕುತ್ತೆ, ಜೀನ್ಸನ್ನು ಚೇಂಜ್ ಮಾಡ್ಕೊಳ್ತಾವೆ, ಒಬ್ಬರಿಂದ ಇನ್ನೊಬ್ಬರಿಗೆ ಓಡಾಡ್ತವೆ. ಒಂದು ವೇಳೆ ಸರ್ಜರಿನಲ್ಲಿ ಸರಿಯಾದ ಆಂಟಿಬಯೋಟಿಕ್ ಕೆಲಸ ಮಾಡದೇ ಇದ್ದರೆ ಏನಾಗ್ಬೋದು? ಹಾರ್ಟ್ ಇರ್ಬೋದು, ಕಿಡ್ನಿ ಇರ್ಬೋದು, ಲಿವರ್ದಿರ್ಬೋದು, ಅಥವಾ ಆರ್ಥೋಪೆಡಿಕ್ ಸರ್ಜರೀಸ್ ಇರ್ಬೋದು, ಗೈನಕಾಲಜಿ ಸಂಬಂಧಪಟ್ಟಂಥ ಚೈಲ್ಡ್ ಬರ್ತ್ಸ್. ಆವಾಗ ಎಲ್ಲ ಡಾಕ್ಟ್ರುಗಳು ಒಂದು ಆಂಟಿಬಯೋಟಿಕ್ ಕೊಡ್ತಾರೆ, ಅಂದರೆ ಯಾವುದು ಕ್ರಾಸ್ ಇನ್ಫೆಕ್ಷನ್ ಆಗಬಾರ್ದು ಅಂತ. ಒಂದು ವೇಳೆ ಅಲ್ಲಿ ಆಂಟಿಬಯೋಟಿಕ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಬಂದರೆ ಎಂಥ ಟ್ರ್ಯಾಜಿಡಿ ಅದು, ಭಾಳ ಇಂಪಾರ್ಟೆಂಟು. ಅದೇ ರೀತಿ ಕ್ಯಾನ್ಸರ್ ಟ್ರೀಟ್ಮೆಂಟ್ಸ್ನಲ್ಲಿ, ಚೈಲ್ಡ್ ಬರ್ತ್ನಲ್ಲಿ ಆಂಟಿಬಯೋಟಿಕ್ ಯೂಸೇಜ್ ಇದೆ. ಸೊ ಯಾವ ವೇಳೆಗೆ ಯಾವ ಆಂಟಿಬಯೋಟಿಕ್ಕು ಡಿಟರ್ಮಿನ್ ಮಾಡಬೇಕು, ಆ ಆಂಟಿಬಯೋಟಿಕ್ ಕೊಡಬೇಕು, ಕರೆಕ್ಟ್ ಡೋಸ್ನಲ್ಲಿ ಕೊಡಬೇಕು. ಹೀಗೆ ಭಾಳ ಇಂಟ್ರೆಸ್ಟಿಂಗ್ ಆದಂಥ ವಿಷಯ ಇದೆ. ಇಂಥ ಒಂದು ಇಂಟ್ರೆಸ್ಟಿಂಗ್ ವಿಷಯದ ಮೇಲೆ ನಮ್ಮ ಅಕಾಡೆಮಿನವರು ಮತ್ತು ಪ್ರೊಫೆಸರ್ ಕರುಣಾಸಾಗರ್, ಮೇಡಮ್ ಕರುಣಾಸಾಗರ್ ಅವ್ರ ಸಹಾಯದಿಂದ ಮಾಡಿರೋದು ಬಹಳ ಅಭಿನಂದನೀಯವಾದದ್ದು, ಶ್ಲಾಘನೀಯವಾದದ್ದು. ಅವರ ಒಂದು ಸಹಾಯಕ್ಕೆ ನಾವು ಚಿರುಣಿಯಾಗಿದ್ದೀವಿ. ಒಳ್ಳೆಯ ಕಾನ್ಫರೆನ್ಸನ್ನು ಆರ್ಗನೈಸ್ ಮಾಡಿದ್ದಾರೆ. ಅಂಥ ಕಾನ್ಫರೆನ್ಸ್ಗೆ ನಮ್ಮನ್ನು ಕರೆದಿದ್ದಾರೆ. ಆದ್ದರಿಂದ ತಮ್ಮೆಲ್ಲರಿಗೂ ಧನ್ಯವಾದ. ಜೊತೆಗೆ ಪ್ರೊಫೆಸರ್ ಅಯ್ಯಪ್ಪನವ್ರ ಜೊತೆಗೆ ನಾನು 3 ವರ್ಷ ಸತತವಾಗಿ ಕೆಲಸ ಮಾಡಿದ್ದೀನಿ. ಅವರು ಚೇರ್ಮನ್ ಇದ್ದರು, ನಾನು ಮೆಂಬರ್ ಇದ್ದೆ. ಪ್ರತಿಯೊಂದಕ್ಕೂ ಕರೆಯೋರು, ಪ್ರತಿಯೊಂದು ವಿಷಯಕ್ಕೂ ಕರೆಯೋರು. ಬಹಳ ಸುದೀರ್ಘವಾಗಿ ಎಲ್ಲ ಚರ್ಚೆ ಮಾಡಿ ಡಿಸಿಷನ್ ತಗೊಳ್ಳೋರು. ಬಹಳ ಸೌಮ್ಯವಾದ ವ್ಯಕ್ತಿ, ಅಷ್ಟೇ ಜ್ಞಾನಿ. ಅವರು ಏನು ಒಂದು 3 ವರ್ಷದಲ್ಲಿ ಏನು ಸೇವೆಯನ್ನು ಸಲ್ಲಿಸಿದರು, ಅದು ನಾನಂತೂ ಎಂದಿಗೂ ಮರೀಲಿಕ್ಕಾಗೋದಿಲ್ಲ. ಆ ಸಮಯದಲ್ಲೇ ನಾವು ಫೆಲೋಶಿಪ್ ಕೊಡಲಿಕ್ಕೆ ಸ್ಟಾರ್ಟ್ ಮಾಡಿದ್ವಿ, ಹಾನರರಿ ಫೆಲೋಶಿಪ್ ಕೊಡಲಿಕ್ಕೆ ಸ್ಟಾರ್ಟ್ ಮಾಡಿದ್ವಿ, ಕೆಲವು ಅವಾರ್ಡ್ಸ್ ಕೊಡಲಿಕ್ಕೆ ಸ್ಟಾರ್ಟ್ ಮಾಡಿದ್ವಿ. ಆಮೇಲೆ ಇನ್ಸ್ಟಿಟ್ಯೂಷನಲ್ ಮೆಂಬರ್ಶಿಪ್ ಇನ್ವೈಟ್ ಮಾಡಿ ಅವ್ರನ್ನ ಮೆಂಬರ್ ಮಾಡಿಕೊಂಡ್ವಿ. ಎಷ್ಟೋ ಆರ್ಗನೈಸೇಷನ್ಸ್ನವ್ರು ಬಂದು ಇಲ್ಲಿ ಲೆಕ್ಚರ್ಸ್ ಕೊಟ್ಟಿದ್ದಾರೆ. ಥೀಮ್ ಪೇಪರ್ಸು, ನೀವು ಏನು ಥೀಮ್ ಪೇಪರ್ ಬರೆದಿದ್ದೀರಿ, ಇಟ್ ಈಸ್ ಓನ್ಲಿ ಕಂಟಿನ್ಯೂಯೇಷನ್ ಅಂತ. ನಿಮ್ಮಂಥ ವಿಜ್ಞಾನಿಗಳಿಂದ ಹಲವಾರು ಫೀಲ್ಡ್ಸಲ್ಲಿ ಒಂದು ದಾಖಲೆ ಮಾಡಿದ್ದೀವಿ ಸೈಂಟಿಫಿಕ್ಕಾಗಿ. ಅಂಥ ಪುಸ್ತಕಗಳನ್ನು ಬಿಡುಗಡೆ ಮಾಡಿದ್ದೀವಿ. ಯಾರು ಈ ಕಾನ್ಫರೆನ್ಸಿಗೆ ಬಂದರೆ ಅದರದ್ದು ಕಾಪೀಸ್ ಇದ್ದರೆ ತಾವು ಓದಿ ನೋಡಿ ಜಾಸ್ತಿ ಕಾಪೀಸ್ ಇದ್ದರೆ ತಗೊಂಡೋಗಿ. ಭಾಳ ಒಳ್ಳೊಳ್ಳೆ ಆರ್ಟಿಕಲ್ಸ್ ಇದ್ದಾವೆ. ಇಸ್ರೋ ಸೈಂಟಿಸ್ಟ್ಗಳು ಬರೆದಿದ್ದಾರೆ, ಅಗ್ರಿಕಲ್ಚರ್ ಸೈಂಟಿಸ್ಟ್ಗಳು ಬರೆದಿದ್ದಾರೆ, ಥೀಮ್ ಪೇಪರ್ಸ್, ಭಾಳ ಒಳ್ಳೊಳ್ಳೆ ಪೇಪರ್ಸ್ ಇದ್ದಾವೆ. ತುಂಬ ಒಳ್ಳೆಯ ಕೆಲಸ ಮಾಡಿ, ಭಾಳ ಸೌಮ್ಯವಾದರು, ಅವರು ಭಾಳ ಸಾತ್ವಿಕವಾದಂಥ ವ್ಯಕ್ತಿ. ಅವರ ಸಾವು ಏನಿದೆಯಲ್ಲ, ಅವರ ಸಾವು ನನಗೆ ಕಾಡಿಸಿದಷ್ಟು ಇನ್ನು ಯಾರ ಸಾವು ನನಗೆ ಕಾಡಿಸಿರಲಿಲ್ಲ. ಹೆಚ್ಚು ಕಡಿಮೆ 3 ದಿನ ಏನೋ ಮನಸ್ಸಿನಲ್ಲಿ ದುಗುಡ, ಏನೋ ಕಳ್ಕೊಂಡಿದ್ದೀನಿ ಅನ್ನೋದು, ಅದು ಹೇಳೋಕ್ಕಾಗೋದಿಲ್ಲ. ಏನೋ ಒಬ್ಬ ನನ್ನ ಸಹೋದರನೇ ಕಳ್ಕೊಂಡೇನೋ ಅನ್ನೋ ಅನ್ನಿಸ್ತಾ ಇತ್ತು ನನಗೆ ಇತ್ತೀಚಿನ 3-4 ದಿನಗಳಲ್ಲಿ. ಅದೇನೇ ಆಗಲಿ, ಅವರ ಆತ್ಮಕ್ಕೆ ಶಾಂತಿ ಸಿಗಲಿ, ಅವ್ರ ಫ್ಯಾಮಿಲಿಗೆ ಧೈರ್ಯ ದೇವರ ಕರುಣಿಸಲಿ ಅಂತ ಹೇಳಿ ಮತ್ತೊಮ್ಮೆ ಅವರ ಆತ್ಮಕ್ಕೆ ಶಾಂತಿಯನ್ನು ಕೋರಿ ನನ್ನ ಮಾತನ್ನು ಮುಗಿಸ್ತೀನಿ. ಧನ್ಯವಾದ.
ಧನ್ಯವಾದಗಳು ಡಾಕ್ಟರ್ ರಾಜಾ ಸಾಹೇಬ್ರವರಿಗೆ. ತಮ್ಮ ಅದ್ಭುತವಾದ ನುಡಿಗಳು, ಎಸ್ಪೆಷಲಿ ರೆಸಿಸ್ಟೆನ್ಸ್ ಬಗ್ಗೆ, ನಿರೋಧಕತೆ ಬಗ್ಗೆ ತುಂಬ ಚೆನ್ನಾಗಿ ಹೇಳಿದ್ದಾರೆ. ಅಂದರೆ ನಾನು ಕೀಟಶಾಸ್ತ್ರಜ್ಞರಾಗಿದ್ದರಿಂದ ಕೀಟಗಳಲ್ಲಿ ವಿಶೇಷವಾದಂತಹ ನಿರೋಧಕತೆ ಅಂತಂದರೆ ರೆಸಿಸ್ಟೆನ್ಸ್ ಇನ್ ಇನ್ಸೆಕ್ಟ್ಸ್, ಅಂದರೆ ಎಸ್ಪೆಷಲಿ ರೆಸಿಸ್ಟೆನ್ಸ್ ಅಗೇನ್ಸ್ಟ್ ಇನ್ಸೆಕ್ಟಿಸೈಡ್ಸ್. ಅದು ಯಾವ್ಯಾವ ರೀತಿ ಮಾಡ್ಕೊಳ್ಳುತ್ತೆ ಅಂದರೆ ಕೀಟಗಳು, ಜೆನೆಟಿಕಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ವಿ ನೋ, ಜಿಯೋಗ್ರಫಿಕ್, ಜೆನೆಟಿಕಲ್, ಆಲ್ ದೋಸ್ ವಿ ನೋ, ಬಟ್ ಬಿಹೇವಿಯರಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಮೆಕ್ಯಾನಿಸಮ್ ಅನ್ನೋದೊಂದು ವೆರಿ ಇಂಟ್ರೆಸ್ಟಿಂಗ್ ಟಾಪಿಕ್. ಏನಂತಂದರೆ ನಮ್ಮಲ್ಲಿ ವಜ್ರ ಬೆನ್ನಿನ ಪತಂಗ ಅಂತ ಇದೆ, ಡೈಮಂಡ್ ಬ್ಯಾಕ್ ಮಾತ್ ಆನ್ ಕ್ರೂಸಿಫೆರಸ್. ಕ್ಯಾಬೇಜ್, ಕಾಲಿಫ್ಲವರ್, ಗೋಬಿ ಮಂಚೂರಿ ತಿನ್ನೋದಿದ್ರೆ ಗೊತ್ತಿರುತ್ತೆ, ಹಸಿರು ಹುಳ. ಆ ಒಂದು ಪತಂಗ ವೆರಿ ಮೈನ್ಯೂಟ್ ಮಾತ್, ಡೈಮಂಡ್ ಬ್ಯಾಕ್ ಮಾತ್, ಇಟ್ ಹ್ಯಾಸ್ ಡೆವಲಪ್ಡ್ ಬಿಹೇವಿಯರಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಮೆಕ್ಯಾನಿಸಮ್. ಹೇಗೆ ಅಂತಂದರೆ, ನಾವು ಕ್ಯಾಬೇಜ್ ಕ್ರಾಪ್ ಮೇಲೆ ಏನಾದರೂ ಅಥವಾ ಕ್ರೂಸಿಫರಸ್ ಮೇಲೆ ಇನ್ಸೆಕ್ಟಿಸೈಡ್ ಸ್ಪ್ರೇ ಮಾಡಿದ್ರೆ, ಸೊ ವಾಟ್ ಇಟ್ ಡಸ್ ಇಟ್, ದಿ ಮೊಮೆಂಟ್ ವೆನ್ ಇಟ್ ಕಮ್ಸ್ ಆ್ಯಂಡ್ ಸಿಟ್ಸ್ ಆನ್ ದಿ ಟ್ರೀಟೆಡ್ ಸಬ್ಸ್ಟ್ರೇಟ್ ಆನ್ ದಿ ಸರ್ಫೇಸ್, ಇಟ್ ಶೆಡ್ಸ್ ಇಟ್ಸ್ ಲೆಗ್ಸ್. ಅಲ್ಲಿ ಲೆಗ್ ಪ್ಯಾಡ್ಸ್ ಇದ್ದಾವೆ ಲೆಗ್ಸಲ್ಲಿ, ಅದು ಎಲ್ಲಿ ಸೆನ್ಸ್ ಮಾಡುತ್ತೋ ಇನ್ಸೆಕ್ಟಿಸೈಡು, ಇಮಿಡಿಯೇಟ್ಲಿ ಆ್ಯಕ್ಚುಲಿ ಇಟ್ ಶೆಡ್ಸ್ ಇಟ್ಸ್ ಲೆಗ್ಸ್. ದಟ್ಸ್ ಕಾಲ್ಡ್ ಬಿಹೇವಿಯರಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಮೆಕ್ಯಾನಿಸಮ್. ತುಂಬ ಅದ್ಭುತವಾದ ಒಂದು ಇದು ಮಾಡ್ಕೊಳ್ಳುತ್ತೆ ಅದು. ಆಮೇಲೆ ಅಗೇನ್ ಇಟ್ ವಿಲ್ ಡೆವಲಪ್, ಹಲ್ಲಿ ಹೇಗೆ ಬಾಲ ಮತ್ತು ಅದನ್ನು ಗ್ರೋತ್ ಆಗುತ್ತೋ ಅದೇ ರೀತಿ ಅಗೇನ್ ಇಟ್ ವಿಲ್ ರೀಗೇನ್ ಇಟ್ಸ್ ಲೆಗ್ಸ್. ಅಂದರೆ ಇಟ್ಸ್ ಕಾಲ್ಡ್ ಆಟೋಟಮಿ ಇನ್ ಎಂಟಮಾಲಜಿ ಇದರಲ್ಲಿದೆ. ಅಷ್ಟು ಒಳ್ಳೆ, ದೇರ್ ಸೋ ಮೆನಿ ರೆಸಿಸ್ಟೆನ್ಸ್ ಮೆಕ್ಯಾನಿಸಮ್ಸ್ ಆರ್ ದೇರ್ ನಾವು. ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್ ಸರ್. ಈಗ ಶ್ರೀಯುತ ಸದಾಶಿವ ಪ್ರಭು ಅವರು ಸಮಯದಾನ ಮಾಡಿದ್ದಾರೆ ನಮಗೆ. ಅವ್ರ ಗಂಟಲು ಸ್ವಲ್ಪ ಮಾತಾಡೋದು ಇದು ಅಂತ ಹೇಳಿಕೊಂಡು ಪ್ರಾಯಶಃ ಅವರು ಸಮಯದಾನ ಮಾಡಿದ್ದಾರೆ ಅಂತ ನನ್ನ ಭಾವನೆ. ಈಗ ಸರ್ ಸಾಹೇಬರು, ತಮ್ಮ ಸಿಹಿ ನುಡಿಗಳು ಸವಿಯಲು ಬಲು ಚೆಂದ, ಅಂತರಂಗದ ಅನುಭವ ಅರಿತವರಿಗೆ ಅಮೃತ. ಸನ್ಮಾನ್ಯ ಬೋಸರ ಸಾಹೇಬರು ಉದ್ಘಾಟಕರ ನುಡಿಯ ಮತ್ತು ಆಶಯ ನುಡಿಗಳನ್ನು ಆಡಬೇಕು ಅಂಥೇಳಿ ತಮಗೆ ಅತ್ಯಂತ ಆತ್ಮೀಯವಾಗಿ ನುಡಿಪೀಠಕ್ಕೆ ಆಹ್ವಾನಿಸ್ತಾ ಇದ್ದೇನೆ ಸರ್.
ಎಲ್ಲರಿಗೂ ನನ್ನ ನಮಸ್ಕಾರ. ವೇದಿಕೆ ಮೇಲೆ ಇರುವಂಥ ಹಾಗೂ ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಭಾಗವಹಿಸ್ತಕ್ಕಂಥ ಎಲ್ಲ ವಿವಿಧ ರಾಜ್ಯಗಳಿಂದ ಬಂದಿರತಕ್ಕಂಥ ಎಲ್ಲ ಎಕ್ಸ್ಪರ್ಟ್ಸ್ಗೆಲ್ಲ ನನ್ನ ಗೌರವಗಳನ್ನು ಸಲ್ಲಿಸಿ, ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಭಾಗವಹಿಸಿರ್ತಕ್ಕಂಥ ಬೇರೆ ಬೇರೆ ರಾಜ್ಯಗಳಿಂದ ಬಂದಿರುವಂಥ ನಮ್ಮ ಸ್ಟೂಡೆಂಟ್ಸ್ ಇರ್ಬೋದು, ಸೈಂಟಿಸ್ಟ್ ಇರ್ಬೋದು, ಹಾಗೂ ಮೀಡಿಯಾದವ್ರಿಗೆಲ್ಲರಿಗೂ ನಾನು ವಂದನೆಗಳು ಸಲ್ಲಿಸಿ, ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ರಮೇಶ್ ಅವರು 3 ದಿನಗಳ ಕಾಲ ನಡೆಯುವಂಥ ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಭಾಳ ಅನುಭವ ಇರತಕ್ಕಂಥವ್ರು ಮತ್ತು ವಿವಿಧ ಸಬ್ಜೆಕ್ಟ್ಸ್ ಬಗ್ಗೆ ಹೇಳ್ತಕ್ಕಂಥ ಮಾನ್ಯರನ್ನೆಲ್ಲ ಕರೆಸಿದ್ದಾರೆ. ಅವರೆಲ್ಲರೂ ಈಗಾಗಲೇ ಅವರ ವಿಷಯಗಳ ಬಗ್ಗೆ ಉತ್ತಮ ರೀತಿಯಲ್ಲಿ ಪ್ರೆಸೆಂಟೇಷನ್ ಮಾಡಿರ್ತಕ್ಕಂತೆಲ್ಲ ನಾವು ಗಮನಿಸಿದ್ದೀವಿ. ಸೊ ಈ ಸಂದರ್ಭದಲ್ಲಿ ಈಗಾಗಲೇ ಸ್ನೇಹಿತರು ಹೇಳಿದಂತೆ ಅಕಾಡೆಮಿಯ ಹಿಂದಿನ ಅಧ್ಯಕ್ಷರು ಮತ್ತು ಭಾರತ ಸರ್ಕಾರದ ಭಾರತೀಯ ಕೃಷಿ ಸಂಶೋಧನಾ ಪರಿಷತ್ತಿನ ನಿವೃತ್ತ ಮಹಾನಿರ್ದೇಶಕರಾಗಿ ಪದ್ಮಶ್ರೀ ಪುರಸ್ಕೃತರಾದ ಪ್ರೊಫೆಸರ್ ಸುಬ್ಬಣ್ಣ ಅಯ್ಯಪ್ಪನವರು ನಿಧನದಿಂದ ಸುದ್ದಿ ತಿಳಿದು ಭಾಳ ಬೇಸರವಾಯಿತು. ಅವರು ಭಾರತ ದೇಶದಲ್ಲಿ ಕೃಷಿ ಮತ್ತು ಮೀನುಗಾರಿಕೆ ಅಭಿವೃದ್ಧಿಗೆ ದೊಡ್ಡ ಕೊಡುಗೆಯನ್ನು ನೀಡಿದ್ದಾರೆ. ಸರಳ ಸಜ್ಜನಿಕ ಮೇಧಾವಿಜ್ಞಾನಿಗಳಾದ ಪ್ರೊಫೆಸರ್ ಅಯ್ಯಪ್ಪನವರು ಅಗಲಿಕೆಯಿಂದ ಕೃಷಿ ಕ್ಷೇತ್ರಕ್ಕೆ ತುಂಬಲಾರದ ನಷ್ಟವಾಗಿದೆ. ಈ ಸಂದರ್ಭದಲ್ಲಿ ನಮ್ಮ ಸರ್ಕಾರದ ಪರವಾಗಿ ಗೌರವಪೂರ್ವಕ ಶ್ರದ್ಧಾಂಜಲಿಯನ್ನು ಅರ್ಪಿಸ್ತೇನೆ. ನಮ್ಮ ಇಲಾಖೆಯ ಅಂಗಸಂಸ್ಥೆಯಾದ ಕರ್ನಾಟಕ ವಿಜ್ಞಾನ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಅಕಾಡೆಮಿ ಆ್ಯಂಟಿಮೈಕ್ರೋಬಿಯಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಚಾಲೆಂಜಸ್ ಆ್ಯಂಡ್ ಆಲ್ಟರ್ನೇಟಿವ್ಸ್ ಎಂಬ ಭಾಳ ಮುಖ್ಯವಾದ ವಿಷಯದ ಬಗ್ಗೆ ರಾಷ್ಟ್ರೀಯ ಸಮ್ಮೇಳನ ಆಯೋಜಿಸಿದ್ದು ಸರ್ಕಾರದ ಪರವಾಗಿ ಇಲಾಖೆಗೆ ನಾನು ನನ್ನ ಅಭಿನಂದನೆ ಸಲ್ಲಿಸಿ, ಇಟ್ ಈಸ್ ಮೈ ಪ್ರಿವಿಲೇಜ್ ಟು ಅಡ್ರೆಸ್ ದಿ ಆಗಸ್ಟ್ ಆಡಿಯನ್ಸ್ ಎಟ್ ದಿ ನ್ಯಾಷನಲ್ ಕಾನ್ಫರೆನ್ಸ್ organized by the Karnataka Science and Technology Academy. This conference is a timely and necessary initiative that brings together experts, academicians, scientists, policy makers, professionals, and students to discuss the importance of the addressing antimicrobial resistance, a growing global health threat that requires our collective attention and action. Addressing AMR necessities novel approaches and scientific advancements. The World Health Organization Global Research Agenda for AMR identified 40 critical research priorities, including creating a new diagnostic tools, alternative therapies. In India, AMR Innovate Hub is at the forefront of the battle, encouraging researchers, clinicians, and policymakers to collaborate on context-specific solutions. The union and state governments have taken multiple steps to fight AMR through the national and state-level action plans, which aim to raise awareness, monitor antibiotic use, control their sale, and encourage their proper use among people and animals. Our state, Karnataka, is leading research efforts to fight against AMR, with well-known research institutes in Bangalore developing a new approaches on the problem. As we gather here today, a compendium of abstracts is being published, encompass insights and research outcome from students conducted by the researchers across the state and behind. I am confident that this compendium will be an invaluable resources for the research working to the contain AMR. On behalf of the government of Karnataka, I thank all the scientists, experts, and delegates who have gathered here to share their knowledge and expertise. I wish this conference great success and look forward and valuable outcome. Thank you all of you.
ಧನ್ಯವಾದಗಳು ಬೋಸರಾಜ್ ಸಾಹೇಬರಿಗೆ ತಮ್ಮ ಅದ್ಭುತವಾದ ಒಂದು ಅಧ್ಯಕ್ಷೀಯ ನುಡಿಗಳಿಗೆ. ಈಗ ಕಾರ್ಯಕ್ರಮದ ಅಂತಿಮ ಘಟ್ಟಕ್ಕೆ ನಾವು ತಲುಪಿದ್ದೇವೆ. ವಂದನಾರ್ಪಣೆಯನ್ನು ಡಾಕ್ಟರ್ ಆನಂದ್ ಆರ್, ಹಿರಿಯ ವೈಜ್ಞಾನಿಕ ಅಧಿಕಾರಿಗಳು, KSTA, ದಯಮಾಡಿ ಆಗುತ್ತೆ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಅಕಾಡೆಮಿಯ ಎಲ್ಲ ಕಾರ್ಯಕ್ರಮಗಳಿಗೆ ಪ್ರೋತ್ಸಾಹ ನೀಡುತ್ತಿರುವ ಮಾನ್ಯ ಸಣ್ಣ ನೀರಾವರಿ ಮತ್ತು ವಿಜ್ಞಾನ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಇಲಾಖೆ ಸಚಿವರಾಗಿರುವ ಸನ್ಮಾನ್ಯ ಶ್ರೀ NS ಬೋಸರಾಜುರವರು ಈ ಸಮಾರಂಭದ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿ ಸಮಾರಂಭವನ್ನು ಉದ್ಘಾಟಿಸಿ ಈ ರಾಷ್ಟ್ರೀಯ ಸಮ್ಮೇಳನಕ್ಕೆ ಚಾಲನೆ ನೀಡಿದ್ದಾರೆ. ಸನ್ಮಾನ್ಯರಿಗೆ ಅಕಾಡೆಮಿಯ ಪರವಾಗಿ, ತಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಹಾಗೂ ವೈಯಕ್ತಿಕವಾಗಿ ಹೃತ್ಪೂರ್ವಕ ವಂದನೆಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ವಿದ್ಯುನ್ಮಾನ ಮಾಹಿತಿ ತಂತ್ರಜ್ಞಾನ, ಜೈವಿಕ ತಂತ್ರಜ್ಞಾನ, ವಿಜ್ಞಾನ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಇಲಾಖೆಯ ಮಾನ್ಯ ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಡಾಕ್ಟರ್ ಏಕ್ರೂಪ್ ಕೌರ್ ಅವರು ಭಾರತೀಯ ಆಡಳಿತ ಸೇವೆ ಇವರು ಅಕಾಡೆಮಿಗೆ ಸೂಕ್ತ ಮಾರ್ಗದರ್ಶನ ನೀಡಿ ಮುನ್ನಡೆಸುತ್ತಿದ್ದಾರೆ. ಅವರ ಅನುಪಸ್ಥಿತಿಯಲ್ಲಿ ಅವರ ಪ್ರೋತ್ಸಾಹಕ್ಕೆ ಅಕಾಡೆಮಿಯ ಪರವಾಗಿ ವಂದನೆಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ವಿಜ್ಞಾನ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಇಲಾಖೆಯ ನಿರ್ದೇಶಕರು ಹಾಗೂ ಕೆಸ್ಟೆಪ್ ಸಂಸ್ಥೆಯ ಮಾನ್ಯ ವ್ಯವಸ್ಥಾಪಕ ನಿರ್ದೇಶಕರಾದ ಶ್ರೀ ಸದಾಶಿವಪ್ರಭು ಭಾರತೀಯ ಆಡಳಿತ ಸೇವೆ ಇವರು ಗೌರವಾನ್ವಿತ ಅತಿಥಿಗಳಾಗಿ ಭಾಗವಹಿಸಿದ್ದಾರೆ. ಇವರು ಅಕಾಡೆಮಿಗೆ ಪ್ರೋತ್ಸಾಹ ನೀಡುತ್ತಿದ್ದಾರೆ. ಅವರಿಗೆ ಅಕಾಡೆಮಿ ಪರವಾಗಿ ವಂದನೆಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಈ ಸಮಾರಂಭದ ಗೌರವಾನ್ವಿತ ಅತಿಥಿಗಳಾಗಿ ಕರ್ನಾಟಕ ನಾವೀನ್ಯತೆ ಮತ್ತು ತಂತ್ರಜ್ಞಾನ ಸೊಸೈಟಿಯ ವ್ಯವಸ್ಥಾಪಕ ನಿರ್ದೇಶಕರಾದ ಶ್ರೀ ರಾಹುಲ್ ಶರಣಪ್ಪ ಸಂಕನೂರ್ ಭಾರತೀಯ ಆಡಳಿತ ಸೇವೆ ಇವರು ಭಾಗವಹಿಸಿದ್ದಾರೆ ಹಾಗೂ ಸಮ್ಮೇಳನಕ್ಕೆ ಅನುದಾನ ನೀಡಿ ಪ್ರೋತ್ಸಾಹಿಸಿದ್ದಾರೆ. ಶ್ರೀಯುತರಿಗೆ ಅಕಾಡೆಮಿಯ ಪರವಾಗಿ ನಿಮ್ಮೆಲ್ಲ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಈ ಸಮಾರಂಭದಲ್ಲಿ ಅಕಾಡೆಮಿಯ ನಿಕಟಪೂರ್ವ ಸದಸ್ಯರು ಹಾಗೂ ತುಮಕೂರು ವಿಶ್ವವಿದ್ಯಾಲಯದ ವಿಶ್ರಾಂತ ಕುಲಪತಿಗಳಾದ ಪ್ರೊಫೆಸರ್ ಎಚ್ ರಾಜಸಬ್ರವರು ಭಾಗವಹಿಸಿ ಸಮಾರಂಭದ ಯಶಸ್ಸಿಗೆ ಕಾರಣರಾಗಿದ್ದಾರೆ. ಶ್ರೀಯುತರಿಗೆ ಅಕಾಡೆಮಿ ಪರವಾಗಿ ನಿಮ್ಮೆಲ್ಲ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಈ ಸಮಾರಂಭದ ಗೌರವಾನ್ವಿತ ಅತಿಥಿಗಳಾಗಿ ನವದೆಹಲಿಯ ICARನ ಪಶು ವಿಜ್ಞಾನ ವಿಭಾಗದ ಉಪನಿರ್ದೇಶಕರಾದ ಡಾಕ್ಟರ್ ರಾಘವೇಂದ್ರ ಭಟ್ಟ ಇವರು ಭಾಗವಹಿಸಿದ್ದಾರೆ. ಶ್ರೀಯುತರಿಗೆ ಅಕಾಡೆಮಿ ಪರವಾಗಿ ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ನಮ್ಮೊಂದಿಗೆ ಈ ಸಮಾರಂಭದಲ್ಲಿ ವಿಶ್ವಸಂಸ್ಥೆಯ ಆಹಾರ ಮತ್ತು ಕೃಷಿ ಸಂಸ್ಥೆಯ ನಿವೃತ್ತ ಹಿರಿಯ ಅಧಿಕಾರಿ ಹಾಗೂ ನಿಟ್ಟೆ ವಿಶ್ವವಿದ್ಯಾನಿಲಯದ ಸಂಶೋಧನೆ ಮತ್ತು ಪೇಟೆಂಟ್ ವಿಭಾಗದ ಸಲಹೆಗಾರರಾದ ಡಾಕ್ಟರ್ ಇಡ್ಯಾ ಕರುಣಾಸಾಗರ್ ಅವರು ಭಾಗವಹಿಸಿದ್ದಾರೆ. ಶ್ರೀಯುತರಿಗೆ ಅಕಾಡೆಮಿ ಪರವಾಗಿ ನಿಮ್ಮೆಲ್ಲ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಅಕಾಡೆಮಿಯ ಕಾರ್ಯಕ್ರಮವನ್ನು ಸುಸೂತ್ರವಾಗಿ ನಡೆಸಲು ಅಕಾಡೆಮಿಯ ಕಾರ್ಯಕ್ರಮಗಳಿಗೆ ಎಲ್ಲ ರೀತಿಯ ಪ್ರೋತ್ಸಾಹ ನೀಡಿ ಮುನ್ನಡೆಸುತ್ತಿರುವ ಅಕಾಡೆಮಿಯ ಮುಖ್ಯ ಕಾರ್ಯನಿರ್ವಾಹಕ ಅಧಿಕಾರಿಗಳಾದ ಡಾಕ್ಟರ್ AM ರಮೇಶ್ ರವರಿಗೆ ತುಂಬು ಹೃದಯದ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಈ ಸಮಾರಂಭದಲ್ಲಿ ಮಾನ್ಯ ಸಚಿವರ ಆಪ್ತ ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಶ್ರೀ ವೀರಭದ್ರಪ್ಪ ಹಂಚಿನಾಳ್ ಸರ್ ಅವರು ಕರ್ನಾಟಕ ಆಡಳಿತ ಸೇರಿ ಇವರು ಭಾಗವಹಿಸಿ ಪ್ರೋತ್ಸಾಹ ನೀಡಿದ್ದಾರೆ. ಅವರಿಗೆ ಅಕಾಡೆಮಿ ಪರವಾಗಿ ವೈಯಕ್ತಿಕವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಹಾಗೆ ಸಚಿವರ ವಿಶೇಷ ಅಧಿಕಾರಿಗಳಾದ ಶ್ರೀ ರುದ್ರೇಶ್ ರವರು ಭಾಗವಹಿಸಿದ್ದಾರೆ. ಅವರಿಗೆ ಅಕಾಡೆಮಿ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಈ ಸಮ್ಮೇಳನ ನಡೆಸಲು ಅನುದಾನ ನೀಡಿ ಕಾರ್ಯಕ್ರಮದ ಅಸೋಸಿಯೇಟ್ ಪಾರ್ಟ್ನರ್ ಆದ ಕೆಟೆಕ್ ಮತ್ತು ಸ್ಟಾರ್ಟಪ್ ಕರ್ನಾಟಕ ಸಂಸ್ಥೆಯವರಿಗೆ ಅಕಾಡೆಮಿ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಈ ಸಮ್ಮೇಳನದಲ್ಲಿ ತಮ್ಮ ಜ್ಞಾನವನ್ನು ಹಂಚಿಕೊಳ್ಳಲು ಒಪ್ಪಿಗೆ ನೀಡಿ ಉಪನ್ಯಾಸ ನೀಡುತ್ತಿರುವ ಎಲ್ಲ ಸಂಪನ್ಮೂಲ ತಜ್ಞರಿಗೆ ಧನ್ಯವಾದಗಳು. ಈ ಸಮಾರಂಭದಲ್ಲಿ ಭಾಗವಹಿಸಿರುವ ಇಸ್ರೋ ಸೈಂಟಿಸ್ಟ್ಗಳಾದ ಡಾಕ್ಟರ್ ಶ್ರೀನಾಥ್ ರತ್ನಕುಮಾರ್ ಅವರಿಗೆ ಅಕಾಡೆಮಿ ಪರವಾಗಿ ಹಾಗೂ ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಈ ಸಮಾರಂಭದಲ್ಲಿ ಅನೇಕ ಗಣ್ಯರು ಭಾಗವಹಿಸಿದ್ದಾರೆ. ಅವರಲ್ಲಿ ಡಾಕ್ಟರ್ ರಂಗಾರೆಡ್ಡಿ ಬೂರಿ, ಪ್ರೆಸಿಡೆಂಟ್ ಇನ್ಫೆಕ್ಷನ್ ಕಂಟ್ರೋಲ್ ಅಕಾಡೆಮಿ ಆಫ್ ಇಂಡಿಯಾ ಹೈದರಾಬಾದ್, ಪ್ರೊಫೆಸರ್ ಇಂದ್ರಾಣಿ ಕರುಣಸಾಗರ್ ಮೇಡಮ್, ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಗೌಡ, ಡಾಕ್ಟರ್ CN ರವಿಶಂಕರ್, ಡಾಕ್ಟರ್ ಕೃಷ್ಣ ಇಸ್ಲೂರ್, ಡಾಕ್ಟರ್ ಚಂದ್ರಶೇಖರ್ ಬಿರದಾರ್, ಡಾಕ್ಟರ್ ರವಿಕುಮಾರ್ ಮತ್ತು ಇನ್ನೂ ಅನೇಕ ಗಣ್ಯರಿಗೆ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಈ ರಾಷ್ಟ್ರೀಯ ಸಮ್ಮೇಳನದಲ್ಲಿ ಭಾಗವಹಿಸಲು ವಿವಿಧೆಡೆಗಳಿಂದ ಆಗಮಿಸಿರುವ ಎಲ್ಲ ಶಿಬಿರಾರ್ಥಿಗಳಿಗೆ ಹಾಗೂ ಸಂಶೋಧನಾ ಪ್ರಬಂಧಗಳನ್ನು ಮಂಡಿಸುತ್ತಿರುವ ಶಿಬಿರಾರ್ಥಿಗಳಿಗೆ ಎಲ್ಲರಿಗೂ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಈ ಸಮಾರಂಭದ ಭಾಗವಹಿಸಲು ಮಾಧ್ಯಮ ಮಿತ್ರರಿಗೆ ಆಡಿಯೋ ವಿಡಿಯೋ ಟೀಮ್ರವರಿಗೆ ಅಕಾಡೆಮಿ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳು. ಕಾರ್ಯಕ್ರಮವನ್ನು ಸಾಮಾಜಿಕ ಜಾಲತಾಣದಲ್ಲಿ ವೀಕ್ಷಿಸುತ್ತಿರುವ ಎಲ್ಲರಿಗೂ ಧನ್ಯವಾದಗಳು. ಕಾರ್ಯಕ್ರಮವನ್ನು ಆಯೋಜಿಸಲು ಶ್ರಮಿಸಿರುವ ನನ್ನ ಎಲ್ಲ ಸಹೋದ್ಯೋಗಿಗಳಿಗೆ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಧನ್ಯವಾದ.
ಈ ಸಂದರ್ಭದಲ್ಲಿ ನಮ್ಮ ಹಂಚಿನಾಳ್ ಸರ್, he has been helping us in all respect, in all programs. On behalf of KST and on behalf of all of you, we want to felicitate him. Please accept, sir, with the permission of Honorable Minister, sir.
ವಂದನೆಗಳನ್ನು ಸಲ್ಲಿಸಿದ ಡಾಕ್ಟರ್ ಆನಂದ್ರವರಿಗೆ ಧನ್ಯವಾದಗಳು. ದಯಮಾಡಿ ಎಲ್ಲ ಹೊರಗಡೆ ಒಂದು ಗ್ರೂಪ್ ಫೋಟೋ ಇರುತ್ತೆ, ದಯಮಾಡಿ ತಕ್ಷಣ ಈ ಒಂದು ವೇದಿಕೆಯ ಅಂದರೆ ಈ ಒಂದು ಸಭಾಂಗಣದ ಹೊರಗಡೆ ಎಂಟ್ರೆನ್ಸಲ್ಲಿ ಅಸೆಂಬಲ್ ಆಗಬೇಕಂತ ಹೇಳಿ ವಿನಂತಿ ಮಾಡ್ಕೊಳ್ತೇನೆ. I request all the dignitaries and the audience to we'll break for a small lunch now and we'll reassemble here. Alla, after the group photo. Alva? ಈಗ ಸೂಕ್ಷ್ಮಾಣುಜೀವಿ ನಿರೋಧಕತೆ ತಡೆಗಟ್ಟುವ ಕಾರ್ಯತಂತ್ರಗಳು ಮತ್ತು ಪರ್ಯಾಯಗಳು. Antimicrobial resistance strategies for prevention and alternatives. ಈ ಒಂದು ಟೆಕ್ನಿಕಲ್ ಸೆಷನ್ ಅಂದರೆ ತಾಂತ್ರಿಕ ಅಧಿವೇಶನ ಈಗ ಪ್ರಾರಂಭ ಮಾಡ್ತಾ ಇದ್ದೇವೆ ನಾವು. ಮೊಟ್ಟ ಮೊದಲಿಗೆ ಡಾಕ್ಟರ್ ಅನುಜ್ ಶರ್ಮಾ ಫ್ರಮ್ WHO India, New Delhi. I'll invite Dr. Anuj Sharma from WHO, New Delhi, please. And the topic is ಆಂಟಿಮೈಕ್ರೋಬಿಯಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಕಂಟೈನ್ಮೆಂಟ್ ಈಸ್ ಎವ್ರಿಬಡೀಸ್ ಬಿಸ್ನೆಸ್ ಅನ್ನುವ ಒಂದು ವಿಷಯವನ್ನು ಕುರಿತು ಅನುಜ್ ಶರ್ಮಾ ಅವರು ವಿಷಯವನ್ನು ಮಂಡನೆ ಮಾಡ್ತಾರೆ. ಪ್ಲೀಸ್ ಬಿ ಸೀಟೆಡ್ ಸರ್. ಡಾಕ್ಟರ್ CN ರವಿಶಂಕರ್, former director and vice chancellor, Central Institute of Fisheries Education, Mumbai, will chair this session. I may now request Dr. CN Ravishankar to please chair this session, sir. Just to brief about Dr. CN Ravishankar, he is the former director and vice chancellor, ICR CIFE, Mumbai. He did BFSc, MFSc and PhD from College of Fisheries, Mangalore, US, Bangalore. Certificate course from University of Bradford and Royal Institute of Public Health and Hygiene, UK, and PGTM from Norm, Hyderabad. A brief profile here. Dr. CN Ravishankar is working as Director ICR CAFT Kochi, where he is responsible for fish prevention and packaging technologies, thermal and non-thermal food processing technologies, smart and intelligent packaging system, development of nutraceutical and nutritional products from fishery wastes, development of value-added and convenience products from fish and shellfish, not selfish, shellfish, seafood safety, design and development of cost-effective machinery for fish processing and business incubations. He has got so many publications and so many awards to his quill. I think ಅದು ಹೇಳ್ತಾ ಹೋದರೆ ಪ್ರಶಸ್ತಿಗಳೇ ಅಥವಾ ಅವರ ಒಂದು ಸಾಧನೆ ಒಂದು ನಾಚುವಂಥ ಸದ್ಗುಣಿ ಇವರ ಒಂದು ಸ್ವಭಾವ. ಈಗ ನಾನು ಡಾಕ್ಟರ್ ಅನುಜ್ ಶರ್ಮಾ ಅವರಿಗೆ AMR ಕಂಟೈನ್ಮೆಂಟ್ ಈಸ್ ಎವ್ರಿಬಡೀಸ್ ಬಿಸ್ನೆಸ್ ಅನ್ನುವ ಒಂದು ವಿಷಯವನ್ನು ಮಂಡಿಸೋದಕ್ಕೆ ನುಡಿಪೀಠಕ್ಕೆ ಪ್ರೀತಿಯಿಂದ ಸ್ವಾಗತ ಕೋರ್ತೇನೆ ಸರ್.
A very good afternoon to all of you, and I'd like to thank the organizers for inviting me to speak to you. And I understand this is a mixed group with participants from various sectors. And I think the topic that I chose was containment of antimicrobial resistance. It's everybody's business, because antimicrobial resistance needs a lot of us to work together.
Please sit, sir.
I thought after his presentation, actually, Dr. CN Ravishankar sir will introduce Dr. Anuj Sharma. I request Dr. CN Ravishankar to do just before the presentation, sir, please.
Yeah, sorry for the interruption here. Yeah, good afternoon to everyone. Most respected my teachers, Kstacademy sir and madam, my friend Dr. Bhatta, and all the other invited delegates here. Let me take the pleasure to introduce Dr. Anuj Sharma, the technical lead and focal point of AMR and IPC, WHP Country Office of India. Dr. Anuj Sharma graduated from Maulana Azad Medical College and completed his MD and senior residency in medical microbiology from Lady Harding Medical College. He worked as a senior faculty in clinical microbiology at a tertiary care trust and teaching hospital in Delhi for nearly 14 years. While still based in Delhi, he undertook numerous international assignments with WHO between 2000 to 2008. In October 2008, he joined WHO full-time, and since then has worked on AMR, infection prevention and control, laboratory strengthening and e-health in WHO country offices in Southeast Asia, including India, and the Western Pacific regions. He rejoined WHO India in 2016, and currently he leads the AMR IPC team to support the government and other key stakeholders for AMR and IPC activities. He coordinates the publication of the monthly publications AMR Samiksha and IPC Samiksha. He is a member of WHO 3-level working groups on AMR and IPC and has contributed to many WHO documents and resources. It's a pleasure to have you here. And I would like to welcome you on behalf of KSTA, and the floor is yours. Thank you.
Thank you, sir, for the kind introduction. So I will be talking about why AMR needs everyone to work together. Yeah, I think that will be good. all of you are aware that antimicrobial resistance has a huge impact. In terms of the impact, it affects the patients who are sick for a longer time, higher deaths, the need for more toxic and more expensive drugs, longer hospitalizations, and also loss of earnings for the patients. So it has an economic impact for the patient as well as for the hospitals and the health system as well. So for the hospitals and the health system, the biggest challenge is all the major medical advances like cancer treatment, advanced surgery like transplantation, liver transplants, heart transplants, even lung transplants, all these are being done quite a lot now, and these are at risk if antimicrobial resistance is not contained. Also at the health system level, higher costs for diagnosis and treatment, loss of revenue for the hospital, especially in the private sector, and also the reputational risk for the hospitals. But at the global level, the number of deaths which are estimated, this is the Lancet Burden of Disease study, which estimated 4.95 million deaths are associated with AMR every year, out of which 1.3 million, 1.27 to be exact, are directly attributable to antimicrobial resistance. That means antimicrobial resistance in bacteria. It also has a global impact on the global GDP, extra health costs, as well as it can push people into poverty. Some of the high-end antibiotics are extremely expensive, especially some of the antifungals. And it also impacts tourism, industry, and food exports. All of you might remember the NDM1 publication back in 2010 when it came out. It impacted India's medical tourism industry in a big way because a lot of people used to come to India for advanced healthcare, and after that publication, India's medical tourism was impacted. And a lot of people still worry about coming to India because India is seen as having very high levels of resistance. So this is something which is of concern for us. And at the global level also, sustainable development goals are also impacted. Action on AMR will contribute towards the achievement of around 6 to 8 of the 17 SDGs, Sustainable Development Goals. And initially there weren't AMR indicators, but now SDG has 2 AMR indicators which are being monitored at the global level. And these 2 indicators are ESBL producing E. coli in bloodstream infections and MRSA in bloodstream infections. Now, why it's everybody's business is antimicrobial resistant bacteria, they cause infections in humans and animals, but they are also present in the human and the animal gut. So they are part of the microbiome of the humans and animals. Secondly, these bacteria can also be transmitted through food and water, through the environment and the food. So this has an implication of these AMR bacteria being spread across sectors. Secondly, antimicrobials are used primarily for treatment in humans, to a certain extent to prevent infections in humans, especially surgical chemo prophylaxis, where antibiotics are used to prevent any post-operative infections. But in the animal sector, antimicrobials are used primarily for growth promotion and disease prevention rather than treatment. So antimicrobials are used in humans and animals, but the residues are found and are spread through food and the environment, primarily water and sewage. So this is a cycle that connects all the sectors, and in addition we have the pharmaceutical sector as well. The pharmaceutical industry, if they are not careful, can also contaminate the environment. If their effluents, especially antibiotic producing companies, if they are not careful, their effluents may contaminate the water bodies into which the effluents flow. And all this comes back to us through the animals which may be drinking that water, and it comes back to us through food. So AMR needs various people across all these sectors to work together to prevent AMR. Now, if you look at the key people that need to work together, on the left hand side you have the list of people which have to work on AMR across all sectors. So you need microbiologists to work in humans, in animals, food microbiology and environmental microbiology to pick up the drug resistant bacteria. You need pharmacologists across sectors, primarily humans and the animal sector, to monitor the antimicrobial use. You need researchers and scientists in all sectors, not just in human health. You need researchers and scientists in food, in the animal sector, as well as in the environment to work at looking at newer alternatives, innovative approaches or alternatives to antimicrobials that can be used. Also, you need epidemiologists and public health experts working across sectors. You also need regulators across sectors. You need the food, food regulator, the drug regulator to also monitor the sales of drugs, the quality of the food, etc. You also need economists to look at the impact of AMR. What's the cost of AMR across sectors, not just on human health? And as someone was talking in the earlier things, AMR is, and sir, I think you mentioned it, AMR is something which is within, and it's also a behavioral issue. So you need behavior experts to look at why people do the things that they do and ensure that we can actually change the behavior of people when we are looking at containment of AMR. In addition, you need doctors and specialists in human health, nurses, pharmacists, administrators to work on AMR. You need veterinarians, you need paravets, you need fishery experts, and you need farmers to work in the animal sector, both terrestrial and aquatic. You need agriculture experts and farmers to work on this. You also need the dairy and the food technologists to be aware and to be focused on this. And you also need the environment professionals, pollution control experts, sanitation and biomedical waste managers and handlers to be aware and address this issue. But most important are the policy makers, public and the media. Their role is extremely important. Policy makers, so that they can identify this as an important issue, and it was very heartening to see the policy makers here, the Minister for Science and Technology here in the morning inaugurating the conference. You also need the public, because public has a huge role to play. They misuse antimicrobials, take antimicrobials over the counter, reuse prescriptions. And a lot of times, India, we have this national pastime, playing doctor, doctor. My doctor has given me this medicine, you also take it. This is, my doctor is very good, you should also take it. So this is again a behavioral issue, and this needs to be addressed, and the media also has a very important role to play. Now, just to take you through how it actually got prioritized over the years, back in 2001, WHO came out with this global strategy for containment of antimicrobial resistance. It looked at 66 recommendations from cutting across primarily two sectors. At that time, the environment sector was not really identified as a key stakeholder, but the food and the animal sector was definitely identified as a stakeholder, and human health. Unfortunately, this did not get the attention that it deserved. 10 years passed, before it became the theme of the World Health Day. In 2011, the theme was Combat Drug Resistance, No Action Today, No Cure Tomorrow. Same year, the health ministers of the Southeast Asia region, WHO Southeast Asia region has 11 member states. The health ministers signed the Jaipur Declaration on AMR, saying this is a priority for all of us. We need to work together, and they signed this declaration which actually comprehensively says how they will address AMR in the region. 2015, WHO came out with a global action plan on antimicrobial resistance. Subsequently, FAO also came out with their action plan. UNEP also has an action plan. And now the global action plan is being revised, and we'll have a quadripartite. That means all the 4 organizations, WHO, FAO, World Organization for Animal Health, and the UNEP will together have a global action plan on AMR 2.0. 2016, we had the first high-level meeting on AMR at the UN General Assembly. That means heads of state identified AMR as a problem and committed that they will address this issue. Same year, we had the first G20 declaration on AMR by the health ministers, followed by every year there has been a G20 declaration on AMR. In 2023, under India's presidency also, the leaders' declaration and the health minister's declaration had a mention of AMR as a priority. But in 2019, WHO recognized AMR as one of the 10 threats to global health. And in 2020, it was recognized as an urgent health challenge for the next decade. One of the 13 urgent health challenges that need to be addressed, AMR was one of them. But subsequently, the COVID pandemic struck, and AMR actually again went back onto the back burner. But now again at the World Health Assembly this year, there is again renewed interest and commitment from all the WHO member states to address AMR. We have a global action plan on infection prevention and control, which has a huge role to play. If we are able to prevent infections, we can prevent AMR. And also we had the second high-level meeting on AMR at the UN General Assembly in September last year, followed by the 4th ministerial meeting on AMR in Jeddah, Saudi Arabia in November last year. So strong commitment from the health ministers and the heads of state for AMR. So there's a lot of commitment happening, but how does it translate into action at the local level? And I'll come back to that in a bit. But just to tell you a little bit about what is WHO? You know, just to explain, we are an intergovernmental organization. We are a specialized agency of the United Nations for health. And most importantly, we are a member state organization. What that means is we work with the government and the health ministries, and the health ministers of our 194 member states, which are countries, they are the ones who decide WHO agenda. So our highest governing body is the World Health Assembly, composed of the health ministers, 194 health ministers of the countries which are members of WHO. We have a secretariat which has global experts, staff and field workers, and we are spread at in a tiered way. We have headquarters in Geneva, 6 regional offices. Southeast Asia regional office is in New Delhi, and we have more than 150 country offices across the world. At the country office, AMR is one of the priorities under the WHO India Country Cooperation Strategy. What this means is the Ministry of Health and WHO Country Office jointly decided these are our priorities on which we will work together, and antimicrobial resistance is part of the priority on protection from health emergencies. Now, I will take you through some of the actions which are happening at the global level and what all is happening across at the global level, and a little bit I'll give you a glimpse of what's happening in India. These are the 6 WHO core functions. Research is a strong focus area to generate, translate, and disseminate knowledge. Now, knowledge is something which is extremely important. We need to have the knowledge on what needs to be done. We also set the norms and standards and promote and monitor their implementation. Also advise the ministries of health and the other stakeholders on evidence-based policy options for containment for various issues. And I will give you examples with respect to AMR for all of these. Also monitor the health situation and the health trends, primarily surveillance. Also provide leadership on matters critical to health and engage in partnerships. And provide technical support, catalyze change, and build sustainable institutional capacity. So the first priority is research, and at the global level there's a lot of work which is happening. WHO comes out with, monitors the antibacterial agents in clinical and preclinical development, also monitors bacterial vaccines in clinical and preclinical development periodically. Last year, WHO came out with a publication estimating the impact of vaccines in reducing AMR and antibiotic use. The estimates are, if all vaccines are used effectively, 500,000 deaths every year can be saved, and 2.5 billion doses of antibiotics can be reduced every year if vaccines are used effectively. Also, we have the WHO bacterial priority pathogen list and the fungal priority pathogen list. These lists primarily aim to incentivize research and development of newer antibacterials, newer antifungals from the global perspective, and I will talk about the India thing later, and the molecular markers and sequences. You can actually connect the 3 sectors and look at the directionality of AMR. Is it moving from humans to animals, or what's the role of food, what's the role of the environment, etc. So this is something which cuts across all sectors. And at the global level, there's a partnership between DNDi and WHO which helped to establish the Global Antimicrobial Resistance Research and Development Partnership. At the WHO office, knowledge management is one of our key focus areas, and we publish this AMR Samiksha and IPC Samiksha, which actually started as the IPC for COVID-19 Samiksha. During the COVID pandemic, we used infection prevention as an entry point for AMR work. We realized, because antimicrobials were misused a lot during the COVID, and if we are able to prevent infections, we can prevent AMR as well. So this started on a monthly basis in March 2020, every month. So this actually summarized the publications, guidelines, training resources on COVID, especially IPC for COVID, into 2 or 3 bullet points with a link to the full text resource. So publications from scientific journals, guidelines, training and IC resources were the thing. And after COVID was declared not to be a public health emergency of international concern, it was widened to cover all aspects of infection prevention and control, and this is again being published, and this is available on the WHO India website. We also started the AMR Samiksha in 2021, doing the same thing for AMR, but using India's National Action Plan priorities, 6 priorities, and I'll talk about them later. And we do the same thing, guidelines, scientific publications, but which are more important for Indians to be aware of. Good examples from other countries and good examples from India itself. Second function is setting norms and standards. Antimicrobial stewardship is a critical function to optimize antimicrobial use in healthcare facilities. So this actually talks of how countries can practice antimicrobial stewardship. India is adapting this and developing its own national guidelines as well for antimicrobial stewardship. We also have the WHO point prevalence survey on antimicrobial use in hospitals to monitor antimicrobial use in healthcare facilities. And also we have the WHO aware classification. I'll talk about this in a bit, but we also have two tools developed by WHO collaborating centers. The WHONET tool, which was developed by the team, the WHO collaborating center in Boston at Harvard University. The WHONET is a tool which can make sense of antimicrobial resistance data across sectors, not just in human health, but in food labs, in animal labs and environmental labs. And you can use specific breakpoints, not just for humans, but the CLSI wet breakpoints can also be used now. And the second is the antimicrobial consumption tool, which can make sense of the sales and purchase data or dispensing data or procurement data of a pharmacy or a hospital or a government and convert it into daily defined doses, and then you can compare your consumption, which is not the same as usage, because consumption means something which is sold, dispensed. Whether the patient has taken it or not is still a question, but it's a good surrogate to look at antimicrobial consumption as well. But the aware classification is something which is extremely important to help optimize the antimicrobial use. Antimicrobials are classified into access, watch and reserve. And access group of antibiotics are the first line drugs which should be widely available. Watch are the second line which should be used with caution. Reserve are the last resort drugs which should be used only when needed. And WHO recommends at least 60% of antibiotics used should be from the access group. The second high-level meeting on AMR at the UN General Assembly last year said that this should be increased to 70%. And in India, Kerala state has set a benchmark for themselves. They want to achieve 90% of access usage in Kerala state should be from the access group. First line drugs. And Kerala's Amrit program, coupled with their aware sort of usage promotion, they have saved 1,200 crores of rupees in just 1 year by preventing over-the-counter sale of antimicrobials and optimizing the use using the aware approach. Infection prevention and control is another key important area. There are guidelines on the core components for infection prevention and control of multi-drug resistant organisms, improving IPC in the health facilities. Also the minimum requirements for infection prevention and control. The core components is the ideal scenario, and if you look at this graphic here, this is the ideal scenario where you achieve all the core components of infection prevention and control. But then a lot of member states had problem in achieving those core components, so WHO came out with this minimum requirements for IPC programs, not just at the national level but at the healthcare facility level, that if you're able to achieve the initial bit, half of the thing, that is also a good starting point. So the minimum requirements are also extremely important, and there are assessment tools for monitoring and assessing IPC programs at the national level and the facility level. When we talk of policy options, there are a number of, I have just picked up few of these documents. There are more than 200 documents available on WHO website. Just to give you a glimpse of some of the policy options, we have a costing and budgeting tool for estimating how much it needs the national action plan or a state action plan funding for implementing that action plan. Also looking at AMR in the curriculum in medical education. So this is again curriculum assessment tool which is available, and the latest one is people-centered approach to addressing AMR in human health, which keeps patient at the center of the response and says 4 pillars are important: prevent infections, have good diagnostic pathways, access to diagnostics, optimize antimicrobial use, and then ensure the whatever antimicrobials are available are of good quality and are available for use in the facility. In addition, to promote awareness, WHO started this campaign last year, AMR is invisible, I am not, to give a face to AMR, because a lot of people don't even realize how many people are dying. I can tell you, my father died of AMR infection, a ventilator-associated pneumonia, in which Acinetobacter baumannii was the culprit. But a lot of lay people don't even understand the deaths which AMR is causing, the number of illnesses, prolonged illnesses, etc. So this is to share patient stories, survivor stories, so that people can understand the devastation AMR causes. There's also a working group to engage the youth. This is a quadripartite working group, and we have also facilitated the formation. This is an independent initiative but encouraged by WHO, a global AMR media alliance, GAMA, and this has journalists from across the world pushing AMR in the news. Monitoring health trends. WHO came out with the WHO Global AMR Surveillance System called GLASS. This was in 2015, after the first global report on AMR came out in 2014, in which only 122 of the 194 member states shared some data on 10 drug-bug combinations. A lot of countries didn't have the data. India at that point in time didn't have data to submit to that, but all that has changed now. So there is routine surveillance looking at AMR infections, monitoring antimicrobial consumption, routine surveillance, AMR prevalence surveys, surveillance of antimicrobial consumption, the point prevalence surveys to monitor antimicrobial use. Candida has been added for to monitor invasive fungal infections. Gonococcal AMR is also being followed up through enhanced GASP program. There's a GLASS methodology for estimating the attributable mortality due to AMR, and the ESBL E. coli tricycle protocol, I already showed that to you, and also monitoring emerging AMR as well. AMR surveillance in India, now we have good systems in place. We have the NARSNet and NACNet coordinated by National Center for Disease Control, which coordinates the National AMR Containment Program. In addition, ICMR has their own research and surveillance network, which looks at higher end molecular mechanisms of resistance, and the HAI surveillance network is also supported by ICMR and NCDC, the HAI surveillance network. But we have state surveillance networks also now, Mahasar in Maharashtra, Karsnet in Kerala, Densar in Delhi, and their data is also being submitted to NARSNet, and NCDC submits this data to WHO in the GLASS system. In addition, all the disease control programs, TB, the STI program, HIV program, the leprosy program and the malaria program have strong focus on drug-resistant infections, and you have the INFAR network coordinated by Indian Council of Agricultural Research, which looks at AMR in fisheries and animals. Fifth is leadership and partnerships. Quadripartite, as I told you, WHO works closely with FAO, World Organization for Animal Health, and the United Nations Environment Program to work together on AMR. UNEP joined in 2019. Before that, it was the tripartite for the last 10 years. And there's strong, we monitor the World AMR Awareness Week together and the TRACS database, which is available online on WHO, FAO, and the other quadripartite websites, where all countries submit what they are doing about AMR. Also, WHO is the secretariat for the Global Leaders Group on AMR, also has promoted the AMR Multi-Partner Trust Fund, and has also ensured that AMR is part of the Global Fund and the Pandemic Fund as well. There's the Global Action Plan on AMR, there's a Global Action Plan and Monitoring Framework on IPC as well. But in India, India's National Action Plan has 6 priorities strongly aligned to the Global Action Plan on AMR, which has only 5 priorities. 6th priority is purely specific to India. They have added this in addition. 16 focus areas. The color of the focus areas denotes the sectors that need to work on it. So if it is white, that means these are cross-cutting across all sectors. If it's blue, it's only human health, yellow for food and animals, and green for the environment. Looking at awareness and understanding, ensuring labs are able to detect AMR and residues, and the data is combined to generate information and knowledge, reduce infections, prevent infections across sectors, optimize the use of antimicrobials, monitor antimicrobial consumption and use, ensuring regulations are in place, ensuring access to safe and quality antimicrobials, and antimicrobial stewardship in humans and the animal sector. And of course, looking at research and innovations, neodiagnostics, vaccines, antimicrobials, innovations, looking at alternatives to antimicrobials that can be used, especially in the non-human health sectors. Financing is another focus area. But 6th strategic priority is extremely important, looking at international collaborations, national level collaborations across the disease control programs, but most importantly, the state AMR action plans. State AMR action plans are extremely important in India. And the reason is quite simple. All the 4 sectors which are important for AMR have state government responsibility. Health is a state subject under the Indian Constitution. So is agriculture, so is animal husbandry, so is fisheries, so is water and sanitation, which is environment. Food is on the concurrent list, joint responsibility of the union and the state government. So action on the ground has to have state action plans, and India has 7 states which already have their state action plans, starting with Kerala in 2018, Madhya Pradesh 2019, Delhi in 2020. Then there was a gap, but then there's been Sikkim, Andhra Pradesh, Sikkim, Rajasthan, Gujarat, which have also developed their state action plans. Technical support, we have 26 WHO collaborating centers on AMR, international centers of excellence, which are not just for the country, but for the entire sort of international perspective. They provide support on various facets of AMR, technical support to WHO as well as to member states. We worked closely with the government on the National Action Plan on AMR and the National Action Plan on AMR 2.0 and the state action plans on AMR. We are also supporting AMR and the AMC and AMU surveillance networks, also supporting AMR awareness and trainings, national guidelines. In partnership with NCDC, we developed national guidelines for infection prevention and control. Antimicrobial stewardship are in process, and standard treatment guidelines are being revised currently. Also, the national IPC curriculum has been revised for in-service trainings. This is again work in progress. Working on strengthening regulations, also raising awareness every year World AMR Awareness Week, 18 to 24th November every year, and also the World Hand Hygiene Day, 5th May. Also, some of the publications from India, and this is primarily the work of the government, but we've been strongly working very closely with the government, especially for the NACNET report, the antimicrobial consumption and the antimicrobial use reports, and the national IPC guidelines, but national patient safety implementation framework also. This is also being revised right now. Also, the Kayakalp is important. You have the standard treatment guidelines, both from NCDC and ICMR. Now a revised one is going to be a combined standard treatment guidelines with both NCDC and ICMR coming together. For research and development, we partnered with Department of Biotechnology to adapt the global priority pathogen list from India's perspective to develop the Indian priority pathogen list. We are proud to be part of the India AMR Innovations Hub, led by the Office of the Principal Scientific Advisor to the Government of India, with CCAMP as the secretariat, which has a large number of organizations which are working together for this. And of course, CCAMP is also leading Index 2.0, the National Diagnostic Catapult, in which AMR is one of the key priorities. They want to look at developing low-cost quality diagnostics at the point of care to better able to faster diagnose AMR infections. We don't work alone, we work, because AMR is everybody's business, we work with a large number of organizations. We work with a lot of government departments and organizations, a lot of donors and partners, specifically the UNEP and the FAO country offices in India, a large number of state governments as well here, as well as a number of medical colleges and institutions across India, but also a lot of civil society organizations, Center for Science and Environment, DISPROD, IFCAI, and a number of other professional associations as well. So I'd like to stop here and just reiterate that AMR is a global priority, it's a WHO priority, and it's a national and state priority. You'll be proud to know that Karnataka has already developed its state action plan on AMR, and what I understand, it is being finalized, and hopefully we will see the launch soon. It's a cross-cutting area of work, and partnerships and collaborations are essential. And again, AMR is everybody's business. We all need to prevent AMR together. Thank you.
So now the topic is open for discussion.
Thank you very much, Dr. Anuj. It was a very comprehensive and very informative talk. So now I think we can take few questions. Yeah, there are many people. Somebody can pass the mic.
Wonderful talk, Dr. Anuj Sharma. I'm Professor Mayur Ergeri. I come from pharma background. So basically, I was holding a pharmacy license in Norway. I have relatives running pharmacies in Switzerland, Germany, who are my first cousins.
It may be several decades to come up with some solution. But I think in the very beginning, at the very beginning, from the human health perspective, I think doctors would have to be at the forefront of deciding what antibiotic to give. You rightly pointed out microbiologists at the top. I'm talking about the system in some other countries where a microbiologist is invariably contacted to decide on the utility or the antibiotic that has to be given, even if there is more than one to which an organism is sensitive. I say it because my daughter is one. And I am very surprised that in India the microbiologist is only a laboratory personnel, a very highly glorified technician if you want to call it that way, managing a lot of people, giving the reports. But I don't think they have a say. So much, that is my feeling. Maybe a couple of corporate hospitals may be using that, but that will not reflect the general way it is happening. Now that would be the first steps, where a concerted effort can be made by your good selves, but WHO, yes, but you're also associated with the ICMR through your good offices to have some plans in place. Next comes, okay, the responsibility of a doctor to, of course, give a prescription. It has to play a very major role. This over-the-counter sale of antibiotics is another thing that happens in India, and people abroad load themselves with antibiotics from India because it is easily available, they can take it, but they cannot have that in another country. But the rate at which there is movement of people from one country to another, resistance is spreading, we know, and nobody can stop it. It's almost become like the air traffic that happens, the resistance spreading. Now the expiry date on antibiotics is a very important issue, and it's in such small letters that at my age, even if I use a lens with the shining silver, I cannot read it. And most often, the period that is available for some antibiotics or some of the chemicals is so less that you cannot even sometimes use it during the period of your illness. And of course, there will be quacks who will be basing their sales on the expired antibiotics which they get either at a low rate. There are government policies by which they can take back the antibiotics, But the next question is, what do they do with it? It is like we all say plastic should be banned, and then plastic is there, taken away, but after that what happens to it? I would very much want to know the life cycle of that, or the chemical. So eventually everything is coming back to maybe the aquatic environment, and though I come from the medical microbiology sector, but I am more into aquaculture and aquatic field, and I realize that very often aquaculture is termed, yes, a culprit, when the water body becomes a victim of the revenue from the pharmaceutical industry, from the hospitals, from poultry, from anywhere where it is used. We always try to blame other sector, but you rightly said, it's an intelligent pollution that is happening because the effluent of one becomes the influent of another sometimes. Therefore, it's very, very hard, and it needs a lot of people coming in to decide the modus operandi of management. Bottom, we have to have a top-down approach, where I think the public awareness, Kerala has, of course, with all their strikes, they have to be complimented for being up in arms for any decision that gets taken. But I'm not sure, because if it is convenient for me, I'd rather just take something off the counter. But does the government have a list that can be allowed over the counter and that will not be allowed? That will also save. Because even here for Dolo or anything, if we say we need a prescription, it happened during COVID, right? Now, paracetamol is a drug that's just available off the counter. So if we have a list that is prescribed, that can be, given from the counter, and all sectors, I will not talk about veterinary, but fisheries and all, they draw all their lessons from the medical sector. A drug works well for an organism, colistin for instance, they will use it to curtail a disease. And therefore, what can be used, what cannot be used, instead of only talking about what cannot be used, I have always been pleading in many organizations, whichever we are associated with, a list of what can be used, what is safe, with all the pharmacokinetic information that is available, needs to be actually informed even to the farmer, because AMU surveys generally are based on knowing how much sales happens or other. Thank you. I'm sorry, it was not a question, it was just a comment. Thank you.
I think for your inputs, I think we will, please, it's already time. So, Dr. Anuj is here. Maybe during lunch, I think you can catch up and clarify a few points. I don't know whether you will take few more because there are many people raising their hands. Okay. I know it's very important, so thank you very much for the very enlightening talk. You're free to discuss with him, okay? Please, we are not preventing you from discussing. So let's catch up during the lunch break. So thanks to the organizers for the opportunity, and thanks to Dr. Anuj for a wonderful talk. Yeah.
Okay.
Big hand to him.
I would request, please be seated, sir, please, once again. I would request Dr. A.M. Ramesh, sir, to present a token of respect to the speaker and also to the chairperson, Dr. Anuj Sharma and Dr. C.N. Ravi Shankar, sir, please. Thank you so much, sir. Now we'll break for lunch for half an hour time, please. We're running short of time. Just take half an hour, please reassemble here in this hall, please. Thank you so much.
CSIR of Science Communication and Policy Research, New Delhi, and he regularly writes for various national level science magazines and also newspapers like Science Reporter, Science India, The Pioneer, The Statesman, The Telegraph, Daily Excelsior, The Daily and the Hindu, etc. He is also involved with various science popularization and also outreach programs for the Government of India. He received several recognitions, including the prestigious P.T. Bhaskara Panikkar Science Writing Fellowship, instituted by the Kerala State Council for Science and Technology and also Environment, Government of Kerala in 2018, and also is the National Award for Outstanding Efforts in Science and Technology Communication through print media, including books and magazines, by the Government of India in 2023. With this brief introduction about Dharmapalan sir, hearty welcome you sir for this wonderful program, for chairing this session. On behalf of KSTA, my own behalf, and all of you, hearty welcome you sir, and I request you to please introduce the today's speaker.
So, good afternoon. I would like to thank KST, especially Dr. Ramesh and his colleagues, for inviting me to this prestigious conference. So, I understand that most of you sitting here are students or students, okay. So, this antimicrobial resistance, it is one of the serious issues that we face in our generation. And I think you might be started today, right? So you'll be deliberating on various aspects. But as an youngsters, what you can do is you have to minimize the usage of antimicrobials. Sometimes it is essential, but what is seen is even if you have a small fever, you will take antimicrobial drugs, and even you like the doctors who prescribe more drugs. If the doctor is saying that, okay, you keep take rest for a few days, you will say that that doctor is not qualified. If the doctor is giving 10 or 20 antibacterial drugs or more drugs, the doctor is good. So that culture is there. So that culture has to be changed, and I hope the deliberations that is happening here will help in judicious use of antimicrobials. So with this, I'm very happy to introduce today's speaker, Dr. Rangareddy Buri, okay. So Dr. Rangareddy, he's a versatile professional serving as a physician, public health policy advisor, academician, and social entrepreneur. His work focuses on improving public health awareness, infection prevention, and patient safety, especially in low resource settings like India. He aims to establish standards for credentialing infection control professionals globally. Founder of Infection Control Academy of India and an honorary professor, Dr. Reddy has trained over 10,000 healthcare workers. He advocates for antimicrobial resistant policies and serves as an advisor to the Andhra Pradesh government. With global experience, he fosters collaborations to improve patient safety and health equity. He is holding many positions. Some of the prominent positions are President, Infection Control Academy of India, Honorary Professor, University of Hyderabad, Adjunct Professor, Public Health Foundation of India, Chief Editor, Infection Control Trends, Expert Advisor, Telangana Action Plan for Containment of AMR, and Chair Global South Conference on IPCI and AMS. So I think with his vast experience, he would be able to give insights into this major problem that is facing our society in today's world. So with these few words, I welcome Dr. Rangareddy to take the stage.
Thank you, Vijay sir. Thank you for that wonderful introduction. I hope you can hear me. I know, I think what is heavier than the lunch what we had is probably our eyelids. I promise that, I will not go heavy making your postprandial kind of situation, was. I will try to be, as light as possible, especially from the fact that Dr. Ramesh yesterday have told me that there are very few healthcare workers who are going to be present here. It is going to be a mixed audience, predominantly coming from the science streams like microbiology, biochemistry, and all that stuff. So the topic which was chosen, the stewardship, right? Initially, it was actually most emphasis was given for healthcare workers, but I have tried and actually moved some of the slides so that it can remain interesting and beneficial for all of you. Before I go on to my presentation, I would like to sincerely thank KSTA, its dynamic leader, Dr. Ramesh, and the gurus, Dr. Karuna Sagar and Mrs. Karuna Sagar, for giving me this opportunity to come and present a little bit of what we know, right? And of course, already the heavy lifting was done by Dr. Anuj, which is making my life much easier. And after me, there is another star. Dr. Vandana is there, so she will try and fill in all the gaps which may come in my presentation. So, who is this? Loud. Wonderful, we are all very knowledgeable, right? We'll say like this. So, let us say, who is this? Who is this? I can't hear. Thank God. Okay. I thought I will start with, the father of antibiotics. And it was, as you probably would know, a chance situation where he has made a discovery which has kind of changed the direction of the modern medicine. With one single product, he could change the trajectory of how the humans are going to deal with a baggage and a variety of infections which otherwise were causing mortality in most countries. If you look at the trajectory of this miracle which has happened, which happened to be the foundation for modern medicine and which has started the new era in modern medicine, its origins go into 1928, when Alexander Fleming, coming back from his vacation, suddenly noticing a petri dish where he saw there was no growth, and then that has become the origin, and his curiosity has become the origin of a new direction for the humanity. Although it was 1928 when it was kind of discovered, it took almost like 20 years before the product was developed. It was the idea, but as you know, some of you are the pharmacists, the idea to actually the marketable commercial product, it takes a longer time. You had to study, various factors, including the toxicity, efficacy, the route of administration, and various other things before you are going to offer the product on a mass scale. And one such event which has actually accelerated the whole availability of the penicillin was World War II. There was a lot of soldiers who were dying in the front lines of the war, and some of them were coming back crippled or with infections, with amputations and all that stuff. And every government, especially some of those who were forming a coalition against the Nazis, that is the UK, US. These guys thought, we should have something in order to safeguard our soldiers and put a very strong front against Nazis. And that actually has led within 2 years to mass produce. And by 1943, not only the mass production has started, but it has started being available widely across the world. For which, of course, Fleming got the Nobel Prize, which you all know, right? So, Fleming, while accepting the award for this invention or the miracle, right? He has, kind of predicted that the thoughtlessness of a person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin resistant organism. So that means he had actually he could see the future, that the generation of the physicians and the common people alike would misuse it, rendering it useless for every kind of setting, including the clinical setting. And as you know very well, that antibiotics today are the most important weapons for the treatment of many infectious diseases caused by bacteria. After penicillin, subsequently there were many classes of antibiotics have come into the commercial mode. But alas, the problem is, as usual, our misuse has rendered them useless very quickly. When the antibiotics had the golden period, that is the period during 1940s to 1970, the average death rate, or what we call it as mortality of infectious diseases, has sharply fell from almost 45%. That means every second person who was having an infectious disease prior to penicillin was dying. But post availability of different antibiotics, the death rate or the mortality rate has significantly come down. And if you look at the death rate from the infectious diseases come down to something like 5% on an average. Of course, it varies from country to country. You could very clearly see in this particular timeline which is given. Of course, we don't consider Salvarsan as something which has revolutionized anything. That's why we will start everything with penicillin only, right? From penicillin, you would see every antibiotic which is subsequently been introduced, within no time, it is getting the resistance developed by various microorganisms, right? And the more you go, the shorter the lifespan of the antibiotics is becoming, which is the kind of worrisome thing. And it is not only the antibiotics. When we talk about antimicrobials, it is not only antibiotics. There are antivirals, there are antifungals, right? So there are various classes of antimicrobials available. Of course, antibiotics is the major chunk of all these antimicrobials. And since most of you are, I was told that some of you are coming from the agri background. I am sure you all know that over 1/3 of potential crop production worldwide is getting lost due to the plant diseases, including fungal infection. This is not me. This was published in January 2025 in Trends in Microbiology. I will talk about it a little later. It is what it means is it is not only about the human morbidity and mortality, but it is also going to have significant impact on the other aspects of our life on this planet. Okay, so some of you, who are into probably the agri, this is what actually is happening. I am not going to comment in detail, but these slides would be available. You can go through that leisurely to understand how the evolution of this antifungal resistance has developed over a period of time, especially in the crop sciences. So this is a slide, which I really like, especially to the audience who are not doctors, to illustrate how, the fall in the number of antibiotics which are effective in our arsenal has a direct correlation to the death rate, right, to the mortality. I am using death rate because, I don't want to use some of those jargon which probably is specific to medical people. So when antibiotics are falling and when the resistant bacteria is on rise, this is like a double whammy. Double whammy because we have so many of these multi-drug resistant, pan-drug resistant kind of organisms which are getting developed, but on the other side, we don't have anything actually to deal with them. It is a situation, a grave situation, where if it is going to continue, it will have huge consequences for all of us. And many people talk about the failing market because big pharma no more is interested to invest their top dollar into the research and development of new antimicrobials because it is not viable proposition. Not viable proposition because of 3 reasons. Number one, there is a word in the marketing which is called as addressable market. The addressable market for the new antibiotics is small. Second is, within no time, these products which are being introduced are finding themselves of not use or not in demand because of the resistance. The third thing is it is very, very expensive actually to do that. And the return on investment is so low that none of the companies are interested actually to put their top dollar into this. That's why we don't see any of the major classes coming out. So we talk about resistance. I thought, we should first define it, before actually we go into the detail, like talking about the stewardship and various aspects of the stewardship and policy, etc., etc. First, we should define what is antimicrobial resistance. It is bacteria change over a time in response to the environment. That is how the resistance actually develops. So, a lot of people have a misconception. When we talk about antimicrobial resistance and antimicrobial stewardship, a lot of people think, okay, if we take out antibiotics, probably there would not be any resistance. It is not so. It is a natural process, right? I keep giving this example to some of the undergrad students or even college students, saying that it is like we as human beings in our evolution, we find the adversities in the environment, isn't it, right? So that we can thrive and we can have our progeny and our life on this earth continues. It is the same for these microscopic guys who would like to thrive against all the odds. And one of the odds is, of course, antimicrobials, which are kind of trying to annihilate them or kill them, etc., etc. So this natural process which happens when you are going to add, like you are adding ghee to the fire, when you give more and more antibiotics, when we are going to overuse them, misuse them, that is when the whole process gets accelerated and becomes a global problem, what we see today. Very briefly, it was touched by many speakers in the morning that there is a number finally put to this problem. How many deaths are happening and what actually is the size of this problem. It was put in a 2019 study, which was later published in Lancet, where they have put the number saying that 1.27 million people are already dying because of the problem, which we call it as antimicrobial resistance. And of course, the forecasts, whatever are available today, they are not giving really much hope that we will be able to reverse this situation. So, and these are some facts, again we had to know. It is not the bacteria, it is not humans become antibiotic resistant, it is the bacteria. That is something, what we had to know. One of the speakers was saying in the morning, it is not bahar, andar hai, it is inside. So it is not humans becoming antibiotic resistance, it is bacteria. That is one fact what we had to know. The resistant bacteria can spread like other germs or microbes. For example, through contact, that is shaking the hands, etc., etc. Today, I am trying to make it as simple as possible so that, the audience is going to get a true sense of the problem. Resistant bacteria can be carried by anyone, healthy or ill. There is a possibility that, even the pathogens can be with us when those are the people called as colonizers, where the bacteria or other microorganisms can stay there without actually giving any clinical symptoms, right? So that is called as colonizer. And another fact is the use of antibiotics in animals and agriculture contributes to the problem, but to a lesser extent than human consumption. The more often or longer we take antibiotics, the more likely we are to see the kind of resistance problem what we see. So we understood, how the genesis actually of this problem. Of course, the genesis of a miracle, but the genesis of a problem too. Then we also talked about the size of the problem. Now let us look at, what are the drivers, right? Today, many a times you heard the word called as One Health. That means the problem is not in one sector. It is not only related to the human health, but it is multi-sectoral, right? As you can see here, the humans can be the drivers, or the human activity, or we call as anthropogenic activity, the food, the plants and crops, environment, water. In all these areas, we can find the drivers of antimicrobial resistance, right? So when we, again, these are all various factors which contributes to the AMR. These are the various mechanisms of AMR. What happens, when we take the antibiotic is that the selection pressure, which is going to happen on the microorganism, is going to result in acquired resistance through mutations, horizontal gene transfer, and also the mobile elements like transposons, insertion sequences, etc., etc. I think, there are some of you are microbiologists. I'm sure you are able to appreciate these things. So why is it a problem? It is a problem because, especially for the low medium income countries, it is a problem because there are hundreds of people or thousands of people or lakhs of people are dying from antibiotic resistant infections each year. And India, per capita consumption is quite high. I am not among, the developing nations we have got per capita consumption as very high. And much of that is inappropriate use. Some of the statistics show that every second dose which is being used in India is basically, it could be avoided. That means it has no, in the first place, there was no reason actually to take that antibiotic. And using antibiotics for too long or too short, that is also a problem. And few antibiotics, as we discussed earlier, are becoming available. If you look into this picture, which I have taken from the City GPS publication, it is based on the UK guys and the World Bank publication, which says that by 2050, if we are not going to address this problem, there could be kind of three scenarios. The worst case scenario is high AMR, where it is going to have the consequences not only in terms of morbidity and mortality, but also, like earlier speakers have talked about, it would have consequences on possibly every sustainable development goal which we are supposed to achieve by 2030. That means we are not in there. 2030, I think, it is a pipe dream, with the kind of problems what we have, that we will achieve SDGs. What are the other things, which are going to be impacted? It is the global, the growth rate in terms of GDP. Various estimates say that anything between 2 to 3%, 3.8% is going to be the loss to the global GDP. And millions of people would be going into the poverty because of the antimicrobial resistance. And it is also going to have impact on the livestock production. Of course, India, our consumption of meat is very low, but if you look at the Western countries and some of even the developing countries where the animal-based protein is the main source for them and for all of us, it is going to be a crisis in terms of food security. What are the key challenges? I am not going to go into the detail, but some of the key challenges is that many of LMICs lack strong antimicrobial stewardship programs. This is what is the topic, which I was asked to talk about, the stewardship programs. And you see that many of our countries in the global south, that is the word which we use for the developing countries now, have, not really very strong antimicrobial stewardship programs. And of course, we have other issues coming in our way, which is only precipitating the problem, like the economic stability, food security, sustainable development, etc., etc. So why are we, talking about low, medium income countries, and what are the specific problems to the global south? As I told you in the beginning, that access without stewardship to the antibiotics is happening in 2/3 of the countries. If you take Asia, Africa, Middle East, and certain regions in Spanish-speaking South America, and also a part of the Eastern Europe, you would see that OTC antibiotics are available in 2/3 of the countries, which is a major problem. I think today somebody asked a question regarding the over-the-counter selling of the antibiotics. And out of 1.4 billion population, I think easily about half of us, access these, very essential drugs without having any prescription, without having any diagnosis. And the diagnostic gap, less than 20% of prescribing guided by lab confirmation, right? It was last year, the DGHS has come with an advisory that no confirmed diagnosis, no prescription for antibiotic, right? But, in India, we have a lot of good rules and regulations. it is not the rules and regulations the problem is their implementation, and hence we still have a big gap in terms of confirmed diagnosis and the prescriptions. And prevention failures. We have a huge burden of healthcare associated infections, which is pegged at anything between 10 to 20% depending on the setting. What do I mean by setting? It could be the private sector or secondary healthcare or tertiary healthcare. That is what I mean by setting. Depending on the setting, it could vary anything between 10 to 20% in India, but some of the other nations in Africa, they might have even higher, like sub-Saharan region, they have this problem even bigger than what we have. And 64% of the population are not aware that antibiotics cannot treat virus. That is why what happens whenever there is galle mein kich, the people go and take the lovely azithromycin and pop them for a day or two, and then they say, okay, I am okay, right? So according to one of the surveys, about 64% of the population are unaware that antibiotics don't work, when it is a viral infection. And most of the upper respiratory tract infections are viral infections. That is a known fact. But still, the people go for antibiotics. And behavior. And behavior is a big problem in terms of actually both antimicrobial resistance and also other things like infection prevention and control, right? Most of the people know, but they don't act. What is causing that inertia? It is $1 million question. Anybody who is going to solve that problem probably is going to get next Nobel, right? Because everybody is knowledgeable, right? Especially, those so-called specialists and experts. But when it comes to implementation, it is a big failure. Policy changes, and only about 1/5 of LMICs have got national action plans which are actually implemented, costed, budgeted, and really actually have got dashboards to see what is happening with them. And unfortunately, India is one of them, right? And Dr. Anuj was talking about in India being federal government, states having the responsibility for health and education. Only 7, I think he has shown very clearly, only 7 out of 28 states and 8 union territories have got plans. So that means we have a long way to go in terms of at least having plans first, right? That is where probably, some of you had to act as catalysts in terms of bringing these plans, in your state, that is Karnataka. So, we talked about problem, but what we had to do in terms of containment. They can be broadly divided into global activities and the domestic activities. You had to have the advocacy, governance, political agenda, surveillance, reducing the burden of infections in humans, animals, promoting R&D. All those things come under global activities, and domestic, that is improving IPC practices, improving access to and use of surveillance data, etc., etc. So to make it, easier to, bite and chew, these are broadly kind of 10 steps to tackle antimicrobial resistance. A first set of them, they are mostly on the preventive side of it, right? You see hygiene and sanitation, vaccines, following the advice of healthcare professionals, public awareness, stewardship, etc., etc. And you have the second cluster of interventions which are aimed at reducing the use of antimicrobials, right? that is antibiotic stewardship, having the surveillance to define, what is the usage and all that stuff, having the confirmed diagnosis. So all these, interventions are, targeted at reducing the use of antimicrobials or the antibiotics. So again, the topic I have taken is something like, from policy to the action, right? Or policy to inaction, whatever it may be, however you want to read it, right? Not that, nothing is being done. From 2014, the first ministerial conference on AMR, the formal process of, clear understanding how to move has started forming, right? And in the last 10 years, from 2014 to 2022, when the UN General Assembly high-level meeting has happened and the second political declaration has happened, we have moved quite a distance, right? But all this, journey had been more about the policy proclamations, declarations, and all that stuff, and less of actually doing something which has got a definitive kind of impact on reducing the burden of antimicrobial resistance. That is why in the September 2024, in the second political declaration, they have talked about reducing the estimated loss of 1.8 years of global life expected by 2035 due to AMR had to be curtailed, right? And they also talked about urgent need for equitable access to antimicrobials, diagnostics, and vaccines, which are going to make a difference. And then in that journey, as you have seen, we talked about the Global AMR Action Plan, or GAP. So the GAP has, these 5 elements, right, which is probably going to be talked about in the today and next 2 days. So I will not dwell into the detail. But as far as my topic today is concerned, that is to optimize the use of antimicrobial agents. We will see subsequently in subsequent slides on how do we go about that. And then subsequent to the UN, UNGA AMR declaration, there was also Jeddah commitments, where they talked about, various things, but most importantly, reducing the global AMR related deaths by 10%, and, reducing the consumption in animals by 30%, reducing the usage of antimicrobials in humans by 20%, the base being 2024. So we said we have actually looked at, what is the problem, how big is the problem. We also talked about what are the containment actions. And one of the major things in terms of containment is optimal use or the rational use of antimicrobials. That is where the antimicrobial stewardship comes into the picture, right? What is antimicrobial stewardship, right? If we are going to define it, then probably it would make life easier. When we talk about, I will not go into formal, definitions, but I would like to say, this word. It is not, what it is not, the antimicrobial stewardship. It is not about not using antimicrobials. It is about using them rationally. So we should not be like extremists, say that because there is an antimicrobial resistance problem, no antibiotics. No, that is not the solution, right? The solution lies in optimal usage of these antibiotics which are available in our arsenal. It is to identify that small group of patients who really need antibiotic treatment and then explain, reassure, and educate the large group of patients who don't. This is what is the problem. This is the second one is very, very important. We had to explain, reassure, and educate the large group of patients who don't need it, right? So that is where, the antimicrobial stewardship is going to play a very vital role in terms of reducing this problem. Where do we use? You all know about it. I will not stop here, but certainly I would like to emphasize on this. Antibiotics, they are like fire extinguishers. We would like to have them, but we would like to have them, on the wall of it, or have it in our arsenal, right? So that's why antibiotics are like fire extinguishers. We don't want to use them all the time, but we are happy to have them on the wall of it, right? I think it explains everything in terms of what we have to do. How antibiotics work, this is very, very important for you to know that there are narrow spectrum and broad spectrum, and defining where to use what is going to make all the difference in terms of containment of antimicrobial resistance. The narrow spectrum, it is like this hook, which can kill only a few type of bacteria, right? Using as much as possible the narrow spectrum antibiotics, would do a lot of good, not only in terms of stewardship, not only in terms of actually containing the resistance, but also it would be devoid of all the side effects which usually come with broader spectrum antibiotics, right? I'm not going to go into the microbiome and how it is going to change your gut and all that stuff. But broadly, narrow spectrum antibiotics contribute less to the resistance. That's why Dr. Anuj talked about the AWARE classification and ensuring that a large part of the consumption of the antibiotics coming from access group of them. And it is appreciable that Kerala has taken such a very good decision to make almost 100% the access group usage. Broad spectrum, I don't think I need to explain. It is like the net what you are throwing, right? So naturally, they contribute to more resistance and hence should be avoided by all means. There are 5 R's, which we usually talk about in antimicrobial stewardship. That is right drug, right dose, right route, right duration, and the review at the right time if, to de-escalate or if to change or to stop or whatever it may be, right? AMS, again, it is not about restriction, but it is about precision medicine for infections. This is what had to be, always remembered. And nowadays, when we talk about the stewardship, we talk about the integrated stewardship model, where, all the 3 cousins had to come together. That is antimicrobial stewardship, infection prevention and control, and diagnostic stewardship, right? So, as you all know, if there is no infection, if we are able to prevent it, then there is no need for antibiotics. If there is no antibiotic, then there is no problem of antimicrobial resistance, to a large extent, I mean. If there is an infection, if we are able to diagnose properly through the diagnostic stewardship and give a more precise antibiotic, then also we will be able to arrest the growing problem of, this is what we call it as, theragnostics approach, right? All 3 of them coming together. So, why diagnostics are important? Because diagnostics, especially the good diagnostics, they answer the critical question, does this patient need an antibiotic at all or not? That's why it is very, very important that especially, a lot of people have this question coming. We don't have the lab capacity, how do we deal with that? Especially in our kind of settings, in the primary and secondary settings in India, especially in the public sector, we may not have, the advanced diagnostics or even lab capacity. In those cases, even the basic things like, clinical algorithms and simple POC tests can be better than actually giving in blind the empirical treatment, right? So there are several implementation challenges in resource settings, right? I would not go into all of them, but of course one of them is resource limitations, especially the limited microbiology laboratory capacity, infectious disease specialists, etc., etc. But here again, the call is these resource limitations should not stop us from making the right decisions and right implementation practices, right? It should actually sharpen our mind in order to come with innovative solutions to overcome these resource challenges by finding the frugal, or I keep using this word, low cost or no cost kind of interventions which are going to really help us in those situations when the resources are limitations, which is usually the case. And for especially developing countries with the kind of rapid revolution, rapid movement and revolution which is happening in the digital space, especially in AI, probably that could be something which can come to our aid, right? Where we have poor lab capacity, where we don't have enough resources, etc., etc. Probably digital tools can democratize expertise and extend the reach of these antimicrobial stewardship programs. So some of you coming from engineering background and digital backgrounds, probably this you could look at as an opportunity in order to develop the digital technologies to address the problem of antimicrobial resistance. There are already several such things which are happening. Today we talked about CCAMP. In Hyderabad we have Aspire Bionest, CCMB. All these guys actually are doing a very good job in terms of bringing innovative solutions in therapeutics and diagnostics, especially in diagnostics, which are AI-driven point of care kind of diagnostics, which probably are going to revolutionize and help us actually to overcome this problem. One of such, I see 3 of delegates coming from Satyasai University. In their university, this was developed a tool called as AMRX in order to predict UTI in their AMR lab. A group of scientists coming from both microbiology, biotechnology, and also the digital technologies, they have come out with this AMRX tool, which is advanced culture-free AML based UTI diagnostic tool for new era of antimicrobial resistance management, which can help reduce unnecessary tests, resource efficient support decision making, and gives instantaneous results, which also complies with various things. And drug discovery. We talked about companies not investing their money because of very long gestation period for the research and also the high cost, which is exceeding $1 billion. Probably again, the digital technologies can come into the picture in order to shorten the period and reduce the cost so that more new generation antibiotics can come into the market. So when we talk about so many things, usually the people get overwhelmed and so, we have to do so many things. So don't worry about it. Start something small, right? Start something small so that you are not going to be overwhelmed, right? And I usually keep saying that start where you are, use what you have, do what you can, rather than actually procrastinating, thinking that it is overwhelming problem, right? So everybody has a role to play. I think today's Dr. Anu's presentation and his title was very apt, that everybody need to participate in this, and it is everybody's problem actually. AMR is everyone's problem and everyone's responsibility, and hence all of us have to come together in order to solve this problem. What healthcare professionals do is understandable, but what individuals can do is they can prevent the infections and don't request antibiotics for cough cold from medical doctors, and if you have unused antibiotics, dispose them responsibly so that there is no problem with that. If you are prescribed an antibiotic, if you are a lay person, what do? You always actually ask your doctor whether you need it or not, right? And what researchers like you can do? What researchers like you can do is developing the antibiotics, the alternative treatments. I was talking to the colleague who is developing the alternatives, which are much more sustainable, right? And antibiotic repurposing, etc., can be done in your lab. I'm sure you know this man. Who doesn't, right? Our beloved President Kalam, who the missile man. I think we need true missiles today in order to solve this problem. And we all had to come together actually to walk in his path to find the solutions to this problem. And in the last, I would like to say that antibiotics transformed medicine once. Now it's our turn to transform how we use them so that we can postpone as much as possible this apocalypse called as antimicrobial resistance. Bacteria have been evolving for 3.5 billion years. They will always adapt. Our advantage is that we can choose, we can change our practices before nature forces us to do. Are you ready? Are you ready? Yes, excellent. Thank you very much. These are my details. You can contact.
Thank you, Dr. Rangareddy, for the nice presentation. Now the floor is open for discussion. Yes.
I am Balakrishnan Nair, working in TDU. He was already mentioned that I was asking him, India has a very, very sound alternative systems, medicine is there. Why can't we look at that particular system where we can use an alternative to antibiotics? I have already proved that it is working in animal. It is there. Indication is that it will work on human also. Thank you.
Yes, sir. Actually, if you look at this, which we wrote as a policy document, policy advocacy document during G20, I think it is not covering everything, but we talked about sustainable alternatives. And it is very, very clear that antimicrobials or the antibiotics are not a sustainable alternative to go into 21st century and beyond to make the human life easier on this earth, right? So definitely we had to look at alternatives to antibiotics. They had to be sustainable. Sustainable means basically they had to be like renewable energy. We can keep using them, but devoid of, such things are available, right? Like bacteriophages is something, which already the people know about, but it has got its own technical problems, right? They are so precise, they can work only on specific bacteria, and also, again, I don't want to go into the detail, but it is so precise that, it is very difficult to make it commercially viable and commercially available, right? But based on that, I think, we had to do a lot of research to find, other things like lysins and, there are multiple other things, right? So we had to get into that mode, or otherwise, we are condemned as human race. That is what is my opinion. Thank you.
Any other questions?
Okay. Hi, my name is Lena. I work for the Swiss Science and Technology Consulate, Swissnex, here in Bangalore. I have a couple of questions. One is like when we talk about AMR stewardship, do you think medical students and pharmacy students are trained enough, or is there more that can be done to already get people ready before they enter the clinical practice and system? And the other is we talk a lot about antibiotics and bacterial infections, but especially in the light of climate change, Antifungal infections will be on the rise, and we have very limited resources at the moment to combat them. Is that also a topic? And the last one, of course, preventive care, like our conversations about vaccines in the context of stewardship to prevent diseases in the first place, also part of the training of building champions and stewards.
Thank you. That's a wonderful question, very important question. I know that the Swiss colleagues are doing on all these parameters a better job than what we are doing. Yes. Medical education, as I told, we don't have these things in our curriculum. That is where I think we are moving in the right direction to build some of these concepts into the curriculum. Either it is the medical curriculum, that is, we call it as in India as MBBS, or it is in pharmacology, bachelor's in pharmacology, or the nursing curriculum. Today, all that curriculum is devoid of these concepts, right? So slowly the work is going on. I think as a part of AMR 2.0 also, it is being very widely discussed on how to actually bring more. I think the new curriculum, especially for the MBBS graduates and BDS graduates, there are already elements as a part of clinical microbiology. There are already certain elements which are making students, aware of these aspects. I'm sure they are going to be better clinicians, better nurses than probably my generation or the current generation, right? In regard to the prevention, right? Again, it's a big topic because of various reasons. We don't have, or rather, we lost actually the habit of hygiene as a central idea of India or Indian philosophy, because Indian philosophy at the core of it is purity. Purity including the physical purity, right? I think, over a period of time, we lost it. We need to regain it. Our Prime Minister has given a call, Swachh Bharat. I think as a part of Swachh Bharat Abhiyan, we are moving in that direction to keep our communities, our houses, our workplaces, our hospitals cleaner. I am sure, it is going to have its own impact. But these things take time, right? And as far as specifically hospitals and clinical establishments are concerned, infection prevention and control for very long was not a priority, neither for the regulators, nor for the clinicians, or for the administrators. But with the rising incidence of, treatment failures, right? And rising incidence of mortality, especially in the high dependency units, or what we call it as ICUs, I think it is dawning on everybody. We need to get into act. That is infection prevention and control. Again, infection prevention and control is a behavioral issue. It takes a longer time to see the results. The seeds what Dr. Anuj has sown, a decade or so back in India, I think for that to see they germinating and giving the fruits, I think it is going to take a long time. But as somebody who is working as a in civil society and also in academia, and IPC being one of the major topics, I see that there is a gradual change, and this gradual change is going to accelerate as more and more people are going to be aware, more and more people are going to be trained and educated in these areas. I think that is not too far away. I think we will be going in that direction. I think the last one you talked about is the antifungals, right? Fungal problem, as we all know, it is now becoming a true fire, right? Like a wildfire, right? Especially in high dependency units, I keep hearing from the researchers, who are my students who are doing research as part of their projects, or from colleagues, who are working in ICUs, they are losing already a lot of patients, to the fungal resistance, right? More than bacterial, it is fungal, which is because very few alternatives are available today. And that arsenal is so small. Otherwise also actually antifungals are very, very small in terms of their number, but they very quickly are becoming useless, and very unfortunate that we had to lose. And this number unfortunately is going to grow in terms of the mortality till we are going to get with some very potent antifungals in the nearest possible time. Thank you.
Hello, good afternoon, sir. Adding to the last questions, like what she addressed on the antifungals, I am a general microbiologist, not a clinical microbiology, but I worked in a health sector for my PhD. So what I got to know is, as you said in the ICU, a lot of bacterial components are worked, but not the fungal infections. So recently when we screened for an ICU with a fungal, a lot of organisms which are showing the resistance, but still I think so in the clinical healthcare, only much efforts or much components are seen only from the bacterial aspects. So you said the overusage of or a misuse of by a patient. So how you put a point of view from a prescription, because usually even if there is a catheter associated in infection caused by a candida, most of the times antibiotics are given, not the antifungals, because they will be not at all tested. And the other view, being a general microbiologist, what I feel is, in the farm, in the field, example, the aspergillus infection for our BSc students, they'll just open the aspergillus culture and they'll work. So, and there is an erratic use of fungicides on these aspergillus. So the same aspergillosis is taken as a severe component in the health care. So how do you just share your point of view in the gap between the agricultural sector as well as a clinical sector?
I think Dr. Vandana would be the right person, or probably Dr. Anuj, they being the microbiologists, knowing actually the mind of microbes better than me. But my broad view is like this, that this is what demands actually our approach to AMR to be One Health. We cannot, anymore work in silos. We need to look at the entire spectrum, right? And we need to actually collaborate and see what is the impact of some happening in one sector is having a reflection on the other sector, right? One thing happening in one sector, how actually it is getting noticed, very alarmingly in another sector. I think, our One Health approach is going to be the solution going ahead. I don't know if Dr. Vandana would like to further comment on her question, specifically no, she is talking about how the impact of that is being seen in human sector.
No, I'm not a qualified person to talk on the non-clinical settings, but evidence is lacking, because we need a lot of evidence to understand that which fungi, what is the antifungal, then is that environmental fungi causing human infection. So we need, but definitely this One Health approach has broken the barrier between the sectors. So more people are coming together across the specialities, and definitely these all will be needed to be looked more detailed manner. That's all would be my answer. I know it is not very appropriate, but that's all I can answer.
No, I totally agree. As I said in the beginning itself, we need One Health approach. Several attempts are being made, either it is globally or nationally or in a regional level. I am advisor to AP government now. I am expert advisor to Telangana government for AMR containment. This is what I keep bringing back, saying that we need to have a multi-sectoral kind of coordination, and we had to really share these perspectives, knowledge, etc., etc. Like being very eminent microbiologist, she had to, lift her hand, say, I don't know what is happening. So this is where, the multi-sectoral coordination and sharing of this knowledge is going to really get us to the solutions rather than looking at stumbling at the problems. I think, this is what probably my answer.
It is revealed as a pathogenic component. So how exactly a probiotic person, because this is what exactly one of our troop who is working on a probiotic, they had isolated a yeast species which is serving as a probiotic, but on the other end, when they just they wanted to publish, but all of a sudden the WHO has released that it is a pathogen. So now how exactly?
So you're talking about 2025?
Yes, 2024, the pathogen list, what exactly has been shared.
I mean, I am not really qualified.
Probiotic, it's Candida species. Pathogenic Candida is a priority pathogen. Pathogenic Candida. I'm not sure about the probiotic.
I am also not sure. But you also need to, I'm sure as a microbiologist, you know about commensals, right? So the role of commensals also had to be, kept in mind. I'm not specifically trying to comment on the priority pathogen list which you are mentioning. Neither I am qualified actually to do that. Thank you.
Sir, one very basic question. Sir, you said bacteria is evolving. That's why we should not say that because of antibiotic it is getting resistance, right? Are we evolving? What about our immune system? Like superbug, do we going to have a superhuman? Moreover, I feel everyone here are COVID survivor.
I would love to become a super human being, a superman, but I think, our evolution, you need to take the gestation period for the human evolution to take, right? Because our age is, let's say 70, 80 years is the lifespan. So our evolution would be seen maybe in 2 or 3 generations. But they will be, what is their lifespan? So that is probably the answer, that they replicate, much faster. Their lifespan is shorter. The gestation period for them to get adapted and adjusted is boundless in comparison with our lifespan. I think that is how I can actually answer your question. Madam.
Yeah, thank you, Mr. Chair.
It is going to be Viva now.
No. I'll take 2 minutes. One is antibiotic resistance is much older than the discovery of antibiotics. That is one of the first points. And this has been amply shown by the resistant genes in the Mexican cave and all the organisms several billions of years ago had. So to think that resistance came about after the use of antibiotics would be too, I think, premature to say. Selective pressures and the discovery of these antibiotics from the organisms themselves that are there in nature shows that maybe you are encountering it, but they have been there before. I was initially wanting to tell about antifungal. I've been working and we've been publishing about recalcitrant dermatomycosis, okay? And it is very interesting there in recalcitrant dermatophytosis that the kind of fungi that we were isolating when I was a student maybe 45 years ago is different than what we get now. Earlier times we used to get a lot of trichophyton rubrum. Now we don't get as many, and sometimes trichophyton mentagrophyte, a new one called indigo is trying to trichophyton in the new species is reported. But the thing is, with regard to treatment, we have found, and I heard this from the dermatologist who was an examiner for the PhD candidate, that years ago, see, the kind of steroid that was used most of the time was just betnovate. Whereas over the years, it has moved to say being given clobestol and things like that. That actually he has brought a High Court order that without a prescription from the clinician, it should not be given. It has been passed. Whether it is implemented or not, that is another question. And then now drugs like fluconazole, which is given, in all these recalcitrant cases, they don't work at all. Terbinafine is the main thing that is now working. So I think we have brought it upon ourselves by moving even in terms of not just the antibiotic which is being used, but even the steroid that is being used. Steroids were very good earlier and it was like Ramabana. But now those steroids are not helping at all. So if even a Supreme Court order has come, well, this is by our dermatologist, Dr. Ramesh Bhatt in Mangalore, who is the president of the Indian Dermatological Society, and he put it forth. Because he said we dermatologists also have a role to play in telling that the public should not be allowed to take, prescribe for themselves. Betnovate was fine at that time, but not all the advanced steroids that are now being taken off the counter.
Yes.
Thank you.
Absolutely, absolutely, ma'am. That's what I try to emphasize. Also saying that this phenomena of resistance is not only related to, it is a natural process. We are only accelerating by misusing, overusing, abusing. That is what has been told. So,
I think one last question.
Yeah, just one clarification. The fungal priority pathogen list has 4 Candida species. It does not have the one that you are mentioning. 2 are Candida auris and albicans are part of the critical priority group, and Candida tropicalis and Candida parasilosis are the high priority group. Other than that, they are not part of the priority pathogens.
I think lack of time, we will stop the questions, but the youngsters can interact with the speaker during the tea break session. So listening to Dr. Reddy, I was wondering, as a science curious person, I read somewhere in the journal Nature, the Western scientists are looking at Indian slums, because in Indian slums there are a lot of resistant human beings. So like resistant bacteria, we have resistant human beings. So somewhere there is a chance that more cleanliness and more civilization leads to this resistance. I'm not sure. This is a lighter note. And recently what I observed is, after COVID, whenever we travel in train or when you go to a doctor, in my childhood days when you go to meet a doctor, after touching a patient, he will wash his hands using that Lifebuoy, that carbolic soap.
There used to be a tray.
That was the culture. But post-COVID, everyone is using the sanitizer. So it has become so, what you call, I don't know, people have become scientific or not scientific. After washing with soap, they will pour what you call sanitizer in the hand, then they will eat rice. So I was wondering whether they are taking toxin. Because during COVID time, if you observe the TV advertisement in the initial times of the lockdown, the government has given a statutory warning. After using this sanitizer, wash your hands with soap. This sanitizer contains a toxic substance, but slowly it has been removed. So I think more educated, we become more ignorant. So please be with nature and follow the rules of the nature.
Dr. Biju, just on a lighter note, maybe they were taking before lunch or dinner, before food, as an appetizer. Alcohol is there.
I saw both are educated, highly educated family. So in the train, husband is not using sanitizers. Wife is scolding. He's an old person, 70 plus. She is scolding. Why you use sanitizer? Then she's pouring sanitizer. Okay. So thanks for the nice interaction.
Thank you.
Sir, please. So thank you very much, sir, for your scholarly and impressive lecture on this occasion. I request our teacher, Professor Karunasagar sir, to please present a memento to both of them as a token of our respect. Please, sir. Rangareddy sir. Thank you once again, sir, for your wonderful lecture. And also we thank Dr. Biju Dharmapalan sir for chairing this session. Thank you very much, sir. So now we have a quick tea break. So 10 minutes, please assemble back, and I will announce the names of the presenters. Please assemble here, and I will announce. Then those people will please go to the meeting room for the presentation. Please have a quick tea and come back.
Sir.
No, it's worth taking.
Transfer that to this, I think. Then I'll take it. ಅದರಲ್ಲಿ ತುಂಬ ಇದೆ, ನಾನು ಹೇಳ್ತೇನೆ. Too many things are there. ಇಲ್ಲಿ ಇದೆಯಾ ಡೆಸ್ಕ್ಟಾಪ್
ಇಲ್ಲಿ
ಇದಾ ಇದಲ್ಲ
ಇಲ್ಲಿದೆ
ಟುಡೇ ಇಲ್ಲ 3 days ಪ್ರೆಸೆಂಟೇಷನ್ಸ್ ಅಂತ ಒಂದಿದೆ.
AMR ಅಂತ ಹಾಕಿದ್ದೀನಿ ಇಲ್ಲಿ.
ಇದು ನ್ಯೂ ಫೋಲ್ಡರ್
ಇಲ್ಲಿ ಓಪನ್ ಇದೆ.
ಹಾಂ ಇಲ್ಲಿ 3 days ಇದರಲ್ಲಿ ಇದಲ್ಲ ಇದು ಓಕೆ.
ಸ್ಟೂಡೆಂಟ್ ಆಫ್ ಫೈನಾನ್ಸ್ ಸರ್ವಿಸ್.
ಹೌದಾ? ಓ, ಮಂಗಳೂರಲ್ಲಿ ಓದಿದ್ರಾ? ನೈಸ್.
ಥ್ಯಾಂಕ್ ಯು.
ಫಿಶರೀಸ್ ಮೈಕ್ರೋಬಯಾಲಜಿನಾ?
ಹಾಂ, ಫಿಶರೀಸ್ ಮೈಕ್ರೋಬಯಾಲಜಿ. ಪ್ಲೀಸ್ ಕಮ್ ಟೀ. ಭರತ್ ಇಲ್ಲಿ ಹೊರಗಡೆ ಇದ್ರೆ ಸ್ಟೂಡೆಂಟ್ಸ್ ಎಲ್ಲ ಕರೆದು. So once again, good evening to one and all. And today is the last session. We have distinguished speaker, Dr. Vandana Madam. And this session is chairing by Dr. Akash. So I request Akash sir to please come on to the stage. And I request Vandana Madam to please come on to the stage. Please, Madam. I am very happy to introduce our one of my seniors. He is very friendly and he did a very good job, and he started his own company, and many microbiologists and also biotechnologists are working under him. Dr. Akash Navile Basappa, founder and managing director of Metaomics Lab Private Limited, Bangalore, a pioneering organization specializing in advanced omics sciences for precision healthcare. Dr. Akash holds a PhD in biosciences with over 2 decades of experience in mass spectrometry, analytical diagnostics, and also multi-omics research. Dr. Akash previously co-founded and successfully led Equity Labs Private Limited, significantly advancing newborn screening and also biochemical genetics testing across India and globally. Dr. Akash is highly recognized for his impactful contribution in preventive medicine and also personalized diagnostics. With this brief introduction about Akash sir, on behalf of all of you, my own behalf and KSTA RT welcome you, sir, for chairing this session. I request you to please introduce today's speaker, Vandana Madam. Please, sir.
Thank you, Srinivas. Dr. Vandana, Professor in Department of Microbiology, Kasturba Medical College, Manipal. She is also a coordinator for Center for Antimicrobial Resistance and Education, CARE. She's also a coordinator for Manipal Biomedics Center for Excellence in Antimicrobial Stewardship. Her areas of interest are AMR, AMS, IPC, invasive bacterial infection. She also got a lot of awards, and out of which Shia International Ambassador 2016 and Dr. Time Pai Endowment Chair in AMS is another award. And she has a lot of publications as well, more than 100 publications she holds for her credit. And I welcome you, madam, for this wonderful presentation. I wish you to take care.
Very good evening to each one of you, and my special thanks to Professor Karuna Sagars and Professor Ramesh and this entire team of KSTA. It's a happy moment for me to be here amongst all, and I try my best to connect with my little information with you. But bear with me, if you feel little uncomfortable, you can stop me and ask me to explain little more. I'll be more than happy to do that.
This is more of an experience sharing than theoretical concepts. I'll take you through the journey, how we participate in a national surveillance program. Just to give you a little background, we talk about antimicrobial resistance, and there is a conference, n number of conferences, lot of information sharing on antimicrobial resistance. But where do you think is the point of the origin of that information which makes us talk about antimicrobial resistance? Is it a bacteria? Is it a patient? Is it India, or it is sewage? It's none of these. It's just a lab which tests and tells that it is resistant. If we don't tell, you don't know it is resistant, right? It's a lab work which gives you an information. A good information will make you and every scientist or a physician or a health professional or a policy maker to think in the right direction. If a lab doesn't do a good job, rest of the things also will go wrong, because you all believe that one information, yes, this bacteria is resistant, or this bacteria or a fungi is susceptible. Let us begin from that. Okay, we talk everything about antimicrobial resistance, but we forget from where that information originated. They all originate either in the health laboratory or a veterinary laboratory or a fishery laboratory or an environmental microbiology laboratory. The information originates from there, then everything begins. I agree that bacteria were resistant much before the antibiotics were put to human use, because that is needed for their survival. If they are not resistant, they die. They get extinguished completely, because that particular strain or a species will completely be vanished if they do not have that resistance mechanism. So, I like 3 quotes of some society where they planned the antimicrobial resistance combat strategies. First, they started with the, hit them hard. That's what everybody used to do. When there is an infection diagnosed, kill them with the biggest bullet. Then now, the thing is, the sentence which catches everybody's attention is, don't irritate them. Just bear with them, because if you irritate them, they'll come back with the, higher energy to develop resistance. Don't irritate them, tolerate them, and improve the hygiene, prevent the infection, because you cannot reverse the antimicrobial resistance. Once it happens, it takes many, many years, or it may not happen because it evolves. So, we need to know how to live with that and how not to increase it further, because we are paying the price for someone's mistake. Somebody overprescribed, somebody didn't do the job well, somebody didn't keep the hygiene well, somebody did not prevent the infection well, somebody did not give the vaccination well. So, that is the, the effect. We are living in the era where there is no antibiotics to treat any infections. So, going back to that laboratory information, how that laboratory information correctly captured, correctly transmitted, correctly analyzed will help somebody, the policy makers, the researchers, the scientists, the intersectoral group to work together for a common goal. So, before that, I will take you through the brief introduction of antimicrobial resistance. Though everybody knows about that, but still I would take you through this slide, without which any talk doesn't appear to be complete. By 2050, it's O'Neill's, the famous publication. By 2050, antimicrobial resistance is going to be the top killer in the world. With that background, why we need to think more of antimicrobial resistance when we are in India? Because we are going to be the worst sufferers living in the low middle income countries, not any developed countries. The consequences of antimicrobial resistance are very well known. It may be at an individual level, at a public level, or at a societal level, or at a national, international level. At an individual level, an individual may face the treatment failure. What will happen if a patient suffers from a bacteria which is resistant to infection? He will not have any opportunity to have a good treatment. He might not recover from his condition, or he may die. That is at an individual level. But what follows is a very bad thing. There is an economic loss that family may suffer, and then the resistant bacteria will stay in as a flora of that patient if he recovers, and then it will spread to his family members, his children, and we do not know how long it takes for an individual to completely eradicate it from their gut, because studies have shown that the people who get discharged from the ICU carry that resistant bacteria even up to 1 year, 2 years, we do not know. His subsequent infections will be by that resistant bacteria. And he may develop additional infections and lot of adverse drug reaction, because very few drugs that are available for treatment are highly toxic. Very expensive and then highly toxic. And then we are not going to go detail about the societal influence, which appears very scary. So let me not go to that level, because we have seen people selling their houses, selling their properties to save their loved ones in the ICU. And what is in return for them? They just take the dead bodies back home, because the patient doesn't recover. So the society at large suffers. That's why we are all here together, representing all sectors, to talk on antimicrobial resistance. So in the hospital, if anybody develops infection, it is mostly by the drug resistant organism, and they face 30 to 50% of death if they develop drug resistant infections in the hospital. And definitely it will add to the incremental cost of treatment. So we do the calculation of the money spent on antibiotics. That amounts to the highest amount they spend in the hospital. It almost comes to few lakhs, because each the course of one expensive antibiotic per day would cost around 30,000 to 50,000 rupees per day, if anybody is developed infections by a resistant microorganism. So we talk of antimicrobial resistance, it is a global problem, but do we act globally? Any effort you follow the West will not be effective for India, because India has a different strategy, different lifestyle, different type of infection. The public health policies are different. You understand the problem globally, but act locally. Why? Because India is home to 18% of the world's population, and one with the highest level of antibiotic resistance. And then now you all know that the major pharma companies exited this research area several years ago, because it doesn't give them much benefit, because it is good to invest on lifestyle diseases like diabetes or hypertension, because more and more people are developing those lifestyle diseases. And India has a unique health system. Unique in the sense, let me brief you about how much of the expenditure of the health cost in India is by insurance company. Even now it is around only 30% have health insurance. Most people spend from their pocket for their health expenditures. That concept of insurance is recent evolution. It's not an old concept. And thanks to the central government, because of Ayushman Bharat, recently it started. Otherwise, before that, every single expenditure was self. And even today, we see nearly 20 to 30% of the people leave the ICU because of cost constraints. They cannot afford the treatment. That's why they leave the hospital, not because they don't want to live. because they can't, because they have to sell whatever they have to stay back in the hospital. That's why they prefer to go home. So again, I would revisit, where do we stand? Morning, Dr. Anuj has exhaustively alluded on to these National Action Plan of AMR, which in line with the Global Action Plan. In India, this was started in 2017 with the 6 strategic goals. And the topic what I am going to take you through stands here, the surveillance of antimicrobial resistance across the sector, human, animal and environment. Me being a clinical microbiologist, I will talk only about the human antimicrobial resistance surveillance in the healthcare settings and what India is doing currently on that. So currently we are in the NAP AMR 2. NAP 1 is over, that period is over. Some things are achieved, many things are not achieved. So it is continuing in the form of NAP AMR 2 until 2029. So they have added few more important areas to it, such as improving the surveillance across the country, across the sector, strengthening the infection prevention control, mostly of an implementation variety and looking for the results of implementation, promoting antimicrobial stewardship and enhancing research and innovation with One Health approach. So that is an important objective added to the NAP AMR 2. So what is surveillance? What are we talking of a surveillance? Initially I told you the testing of an antimicrobial resistance, whether a bacteria is resistant or not, is tested in the laboratory by some standard methodologies. How great is that methodology? Not very great, very simple methodology, but one methodology which is suffering with a lot of quality control issues in India. One very simple test where each time you do has a different testing results because of various quality issues of testing. So surveillance is nothing but the routine collection of health related data. Nothing special. What you already do, collect the information, analyze these data and give feedback of the results and interpret to the relevant stakeholders. Communicate that result to the relevant stakeholders. Somebody will analyze the data and do the next level of the job. If you don't know what you are doing, if you do not have any measurement of what the problem is, you cannot think of a solution. You should know how big is the problem. You say AMR is a problem, but how big is the problem? Where is the problem? Who is the cause of the problem? You need some numbers, right? Without the numbers, you do not know what is the problem. Yes, it is a big problem, but what is the width and the breadth of the problem? At least some idea you get by surveillance. Is surveillance everything? Absolutely no. Surveillance is one part of the bigger game. If you don't do surveillance, you cannot go for that bigger game or you face bigger challenges. So what is the benefit of doing surveillance? At a local level, if I do a proper surveillance, if I do this appropriately, I will be better informed to take better clinical decisions and patient outcome will be better. Because I know what's happening around me. I don't have to know what is happening in the next taluka, but first I need to know what's happening in my hospital. That is the local surveillance. Next is regional. In the region, I compare several hospitals or several groups data and then understand the local trend. What happens in this region? What happens in Bengaluru? What happens in Mysore? Is Bengaluru resistance is equal to Tumakuru? Should I follow the same treatment protocol if I practice in Bengaluru or Tumakuru? No, it's not. You need to know the local data. You cannot take the Delhi data and practice in Trivandrum. You cannot do that. At a national level, it will help to guide the policy and ensure appropriate and timely public health interventions. some aberrations might happen, some new resistance mechanism might develop. Some things will tell some hidden stories even by analyzing these antimicrobial resistance data. You can know what is happening in the background, because resistance is an indicator of use. Somebody use it inappropriately, the resistance is the outcome. It tells you it's a surrogate marker, or it's an indirect evidence of what's happening, what is a practice in that region. Globally, of course, the expanded benefit happens at a global level too. Now let us come to what we do at Kasturba Medical College. We are a part of one major national surveillance program, which functions according to the NAP-AMR program. But is it the only one? No. There are total 3, and in the health sector, I am not talking of the agricultural or a veterinary environmental sector, my talk is only limited to the health sector. We have 3 major stakeholders or the authorities who conduct surveillance for India. One is, of course, National Center for Disease Control, which reports to Government of India and then to WHO, that GLASS, what Dr. Anuj mentioned in the morning, GLASS, is from this pool. The HUNET and the GLASS network is NCDC, National Antimicrobial Surveillance Network, NARSNet. They do AMR surveillance and antimicrobial use surveillance, because they both are interconnected. Next is the Indian Council of Medical Research. They do antimicrobial resistance surveillance and research along with that. They add a little more components to the routine surveillance for research component, including genotypic resistance, and they integrate several other important health related matter like more infection control, more stewardship emphasis is there in this network of surveillance in India. One is antimicrobial resistance, next is stewardship and healthcare associated infections. Are they separate? No, they are integrated, because you cannot separate infection control from the antimicrobial resistance. Poor infection control practices, more infection, inappropriate use of antibiotics, more infection and more antibiotics, more drug resistance, more transmission. These 3 are very well connected. So that is why all the 3 are interconnected in this particular program. Initially, it began in the tertiary care hospitals. I'll tell you what are those tertiary care hospitals. For the past 6 months, it has been expanded to secondary care hospitals also. There is one more network which is also supported by ICMR. Initially, there was a CDC funding under the Global Health Priority projects. It is run by AIIMS and ICMR together. The same network hospitals here participate here also with a little overlapping or deletions. They do primarily healthcare associated infection. Why they do separately? Of course, they are complementing each other, and this is the core healthcare associated infection, increasing the capacity building, training, education, and in that network there is also development of guidelines of India, the healthcare associated infection guidelines for India. So far we follow ventilator associated guideline by CDC, someone else. We do not have our own guideline because our practices are different. So this is an overview of what the healthcare sector does in surveillance alone. I have not touched upon the large AMR, we are just in that. Surveillance means data, looking at the data, doing the things and looking at the data, analyzing the data and monitoring with the feedback system, what to do with that data. It is not just to make graphs and enjoy, but there should be an action, workable action coming out of this result analysis. So this is how the ICMR AMR surveillance network functions. There are these many centers, they are categorized into nodal centers and regional centers, and then All these nodal centers are the premier institutes of medical colleges in India. AIIMS New Delhi, JIPMER, and PGI Chandigarh, and then CMC Vellore. So these are the nodal centers. Why they are nodal centers? They are given the responsibility of certain groups of microorganisms to go to the detailed analysis. All the regional centers will collect the data, get trained, do the test correctly, and then send the data to the ICMR data management system. There is an online portal where the data goes into this, and then analysis, the genotypic analysis is done by them for certain groups of microorganisms. And if you look at these regional centers, they are all medical colleges. They are all big medical colleges, mostly government, very few private, and we are one among them. And there are many private laboratories. We call them standalone laboratories. These are the medical colleges, these are the standalone laboratories. Of course, there are few hospitals also attached to microbiology laboratories. So this is the ICMR AMR surveillance network looks like. Coming to NCDC network, NARSnet. As of March 2024, there are more than 45-50 centers. They keep adding centers each year as they evolve. Their idea is to encompass all the healthcare systems in India, but it takes a huge effort, so they keep adding institutions over the years. The NCDC involves only government medical colleges. There are no private medical colleges in India. Okay. While ICMR has both division of government as well as the private data collection. I am not going to tell anything about the NCDC because I am a part of ICMR network, so I will be telling only about the information what is generated out of that ICMR network. So what microorganisms are under the ICMR network? Of course, they align with the WHO priority pathogens, the Indian priority pathogens, everything, because these are the common infections which any tertiary hospital or a medical college encounters. Members of the family Enterobacteriaceae, mainly E. coli, Klebsiella and all others. Salmonella, non-fermenting gram-negative bacilli, highlighting Pseudomonas aeruginosa, Acinetobacter baumannii, and any rare, not rare, Stenotropomonas, etc. Staphylococcus species and Enterococcus species. Diarrheal pathogens including Shigella, Salmonella and Vibrio, and fungi. These are the group of microorganisms which are covered under the ICMR surveillance. Do we do anything extra for this surveillance? No. These are our routine patient diagnostics. Ours is a hospital with the 2032 beds. We receive nearly 1000 samples per day, out of which 500 samples, in the sense the clinical specimen coming to the laboratory. The patient footfall is many thousands per day. Nearly 1600 patients are admitted at all time in the hospital. 30% come with the infection, but 80% are on antimicrobials. So, who suspected infection, definitely clinical specimen comes to the laboratory. All clinical specimen do not have bacteria. I am just giving you the background. If at all a bacteria is isolated from the clinical specimen, I will give you one example. A patient A comes to the hospital, gets admitted with the severe pneumonia, lung infection. His respiratory specimen is cultured in the laboratory. We isolate Klebsiella pneumoniae. That is a clinical isolate of Klebsiella pneumoniae in the laboratory. We do the testing. we do the antibiotic susceptibility testing, which will help the doctor to treat the patient correctly, to choose the right antibiotic therapy. So that information is lying with us, irrespective of ICMR or NCDC. What we were doing so far with that result, we were analyzing at a hospital level. We were developing our own hospital antibiotic policy, and we were evolving within the hospital. But that's not sufficient. AMR is a global problem. You need to know what's happening in my town. Hospital A should know what is happening in the other hospital. Then only we can practice better. So that is the basis of surveillance. Now what is happening routinely, information is given to the ICMR for a better analysis at a national level, for inter-hospital comparison, to bring in better public health policies and research. So in a nutshell, that is what is a surveillance. I am not doing anything extra to give to ICMR. I do my routine diagnostics, I do my work regularly. Only thing is that I submit the data to ICMR. There is a catch here. There needs to be a harmonization of the test results. If you test that same Klebsiella, if someone else tests that same Klebsiella, all three of us should produce the same result. That means I should participate in a quality assurance program. That is the benefit of participating in the surveillance network. The same with the NCDC or ICMR. Otherwise, I say resistant, you say susceptible, then the testing is wrong. The wrong data going to the public health policy will give rise to wrong information, wrong decision, wrong research, everything goes wrong. So that is the foundation. Me working in a private hospital of repute, we had a privilege of this quality assurance program much before we participated in the ICMR network, because ours is a fully automated laboratory. So we run the programs for long, but several hospitals got benefit because they were forced to participate in the quality assurance, harmonize the testing. So the capacity building also parallelly happened with the surveillance program. So now we see several groups of microorganisms here. The nodal centers are responsible for certain groups, because you cannot handle all types of microorganisms because the genetic resistance is so complex. You cannot handle Salmonella, then suddenly you jump to Enterococcus. It becomes a chaotic thing. So each nodal center is responsible for these groups of microorganisms, and whenever we send our isolates to the national level, we send Salmonella to a particular nodal center, non-fermenter to a particular nodal center, Staphylococcus to a particular nodal center, and so on. So we sent the first 30 isolates, that is called as a representative samples, because we love to test genotypically, but resource is very high resource is required. So we send the representative isolates sent to the genetic analysis. So we get to know what are the genotypic mechanisms of resistance. So is my empirical therapy or the antibiotics what I use in my hospital is appropriate, or I need to change anything, or my pattern, my genes are similar to somebody in Chandigarh or in Tamil Nadu or something like that. Okay, so that gives a comparison and tells you a story, at least a partial story. I would never say this is a real story of India, because whole India is so big and it cannot be represented by few medical colleges at all. And you see who go to medical colleges? Only who have a access, who live near to the medical college, right? Only those who live near the medical colleges can go to the medical colleges. It doesn't mean only medical colleges give the best care. Many people go to the nursing homes, and even larger number get treated at a taluk level hospitals. Much bigger number is treated as at a individual practitioners. We call them freelance family physicians. None of them get tested. So you can understand how tip of the iceberg is represented at the surveillance information. But am I demeaning it? No. At least that we have now. We never had anything before that. We didn't know what is, because even hospitals were very much afraid to disclose their antimicrobial resistance because it reflects my practice. If I say my Klebsiella is 90% resistant, I am worried people might mock at me, but it should not happen because antimicrobial resistance is a national problem, global problem. I cannot hide the resistance data. So this is about the organisms which are covered under this surveillance system. So these all represent the real patients all time, the regular workup what is done in the hospital. So that brings me to say that there are many limitations to it. Let us not discuss that. I will get a bacterial isolate only if I test. What if I don't test? So we know the demerits of that, but still this is the basis of very many things. Let us not go to the drawbacks of it. Let us look at the only positive side of it and then go further what we do on a regular basis as a part of surveillance center. So what do we do in the as a part of the surveillance activity? How ICMR initiated? They started the nodal centers way back in 2013, 12 years ago. So they started developing these individual organism group expertise, and then they standardized their genetic testing of resistance and their capacity was improved. They were already having a high capacity, but they were recruited to test those organisms specially. Then lot of work the policy makers were meeting and the guidelines were, the SOPs were made, and it took nearly 4 to 5 years to establish the regional centers. The regional centers started functioning from 1st September 2018. It was a project for 5 years up to 30th June 2023. It worked under a name of a regional center of AMR, National AMR Surveillance Network. What did we do in that? Every center standardized their AMR testing. They participated in the quality assurance program. Interlab comparisons and the material comes from the nodal centers and our results has to match what they really expected. That is the meaning of quality assurance programs. Then share the AMR data with the ICMR portal surveillance system and share the representative bacterial isolates to nodal centers. So this data entry is a huge work. So every day in our hospital we have nearly 400 isolates, and 400 isolates will have at least 20 antibiotic test results. So you need to get them, then clean them, clean the data, and then put it in the portal manually. So the manpower is supported by the ICMR with the funds. That needs funding. Otherwise we have lot of other work and we do not have dedicated manpower to share the data with anybody. So next, did the surveillance network stop? No. It took another shape. In 2019, the ICMR also started antimicrobial stewardship program in the same network hospitals. New set of manpower was recruited. Stewardship activities started in the selected number of beds in the hospital. Ours is a 2000 and odd bedded hospital. The entire bed we cannot. You need at least 10 dedicated personnel to run stewardship in that hospital. So a small percentage, maybe 100 beds were, 100 to 200 beds were dedicated for a stewardship beds. We implement in those beds only. With few wards, few ICU beds were dedicated for that. And then after 2023, now this got integrated into the AMSP program. So now the program has surveillance, antimicrobial surveillance plus antimicrobial stewardship combined now. It is going on in this mode. The AMSP had different phases. COVID has a big blow on the AMSP activity, but again it came back to life and started functioning. Now we are in the phase 3. Every 1 year, 2 year they sanction extra funds and add little more objectives. So that is the AMSP combined with the antimicrobial surveillance network. In 2024, in the beginning of 2025, this is going on. They added the secondary care hospitals into the regional network, encompassing mainly capacity building, appropriate testing, the correct testing, and then the data sharing of the secondary hospitals to the ICMR portal. Because if you look only at the medical colleges, you are looking with the biased eye. The true India is not represented by the tertiary care hospital. Only a small percentage you are representing, but AMR is at every level. Okay? So, to expand that vision, they included the secondary hospital. Currently, under our center, we have 2 secondary care hospitals under our mentorship. So, our responsibility is to train those hospitals to do the correct testing, train them to understand the troubleshooting of antimicrobial resistance, handhold them for a better infection control practices, and also measure their antimicrobial use. With that objective, we have expanded into a secondary hospital from the beginning of this year. So, this is about the summary of the activity of AMR surveillance network, and we being a regional center. So, I will just take you through few slides how this data appears. I am not going to the details of that because you can access that publicly if you have time, because you cannot go through all those microorganisms because there are so many organisms to analyze. We analyze the data of these antimicrobial resistance of these bugs. This is how the analysis appears. This is the summary of our 5 years antimicrobial network participation. We were doing it even without participating in ICMR surveillance, but only thing is that now we compare ours with the others, and our data is available to Government of India for use into the policy or bring any new research activity or bring new drug research or whatever research they want to use it, and also we use it in exclusively for our internal practice improvements. So, this is the antimicrobial resistant trend graph. All of you are aware of this, but just to take you through. So, here this is a analysis is a susceptibility to various organisms. This is amikacin, then ciprofloxacin in grey, meropenem in yellow. So, the rate of resistance of Enterobacteriaceae, Escherichia coli to these drugs over the years. If you see, the susceptibility reduced significantly to ciprofloxacin, while other drugs we maintained almost a status quo in our hospital. Not to, it looks like a little skewed result, but in 2016, ours was the first private hospital to start antimicrobial stewardship, even without the support of ICMR. So, we had a massive, kind of a ambush type of reducing the antibiotic use. So, that has led to the stagnation of resistance in our hospital. But is it a sustained effect? No. COVID has significantly troubled our efforts, and the resistant rates are increasing, the hospital infection rates are increasing. We are not very successful, we are losing the battle. It does not stay for long, but this result shows that we did not drop in our susceptibility significantly. It is not, I am not saying it is a plus point, but not very bad decline happened in our hospital. This is we in comparison with the other centers, the average of other Indian centers. If you see again E. coli resistance to particular, this is amikacin, the green percentage reflects susceptibility. We are around 90% susceptibility, that means 90% of our E. coli are susceptible to amikacin, while the rest of the India it is maybe around 70%. That means our susceptibility is good compared to the national average. Okay? If you see the national data, if you see the Delhi, Mumbai, the metropolitan cities, Chennai, the resistance rates are extremely high, extremely high. We come from a very remote place, that might be the reason for our better susceptibility. Other than that, there is not major difference. But if you see Delhi, it's a huge resistance compared to rest of the world, rest of the Indian centers. So the same pattern is reflecting in most of the antibiotics except here and there. Okay? So our susceptibility is, even in Klebsiella, slightly better than the national average. National in the sense it doesn't represent the entire nation, but the hospitals that are participating in the network activities. Yes. These are the clinical isolates, the patient samples. These are the infection causing microorganisms. These are not the colonizers. These are the disease causing E. coli. This is not a gut colonizer E. coli. These E. coli caused urinary tract infection. These E. coli caused bacteremia. These E. coli caused sepsis. These E. coli caused serious kidney infections, just to give you some examples. They are all clinical pathogens. Contaminants and colonizers are not included in this analysis. Yes. No. This is completely no environmental surveillance in this network. We don't do environmental, we do it for a different purpose. Yeah, the bed rails and floor and all. No, it doesn't reflect, because we are more worried about what is causing infection in the patient. Because invariably the hospital environment will have MDR bugs. It's a known entity. More resistance, because that practice, it's a big city. I come from Manipal, where patients come from little smaller region. If you see in Bengaluru, it will be much higher. Yes, that is the reason, because the more remote you go, you will have little better performance. But yeah, that is the reason, like if you practice in...
I request you to keep it for the end of the
Okay,
discussion.
fine. Sorry.
Otherwise it will extend.
So I'm almost completing. So another, this is about the phenotypic resistance. I have just put the snapshots to take you through the journey, not the detailed analysis. There are a lot of information available as an outcome of this network. So the representative samples go to the nodal centers and they test genotypically. They test those bacteria for their genetic mechanisms of resistance. So this is again one such graph I have put up. If you take that same E. coli from each center is given a number, regional center 1, 2, 3, 4, etc., etc. So I know my center, so what is my resistance mechanism, genetic resistance? Suppose, CTXM15 is one of the ESBL enzyme gene that is present in, varied percentages across the different centers. That means E. coli in Manipal is different from E. coli in Mysore. Maybe E. coli in Manipal is different from E. coli in Mangalore, because that regional influences, the practices, what the family physicians prescribe, what is the hygiene concept, all those factors determine significantly to the bacteria what you harbor and you develop infection. See, some do not have any that enzyme, some have. Another is one important thing is KPC enzyme. Okay? So we don't have much of a KPC enzyme, unlike the American isolates. Are we happy that we don't? Yes, of course, there are few centers who have KPC, but it is not as high as IMP or Vim or these other enzymes. Okay? OXA48 is present in good numbers, TEM is in good numbers, NDM you see, metallobeta-lactamase, New Delhi metallobeta-lactamase for carbapenem resistance is in such high percentage. Some centers have even up to 80%, some have 7%. So that represents their regional diversity of antimicrobial. That makes us understand that how important is surveillance. Without knowing this, you cannot take up research locally also. Any implementation strategies should be based on the findings of that place. That will tell you many stories how the transmission of the MDR bugs happen, how the transmission of resistance mechanism happens. That will evolve, that will make the scientists think, let me look more detailed into the evolutionary biology of the microorganism, or someone who wants to develop a new drug can look into those mechanisms and start looking into this. And it will even help the policy makers to bring in several policies based on these mechanisms. Not directly, there is a big process behind it. So next couple of slides on what we did include. We are a part of healthcare associated infection surveillance also with the ICMR and AIMS. So this is again a network laboratories. Just we understand what is our healthcare infection rate. So far we were all pushing it under the carpet. Infections are happening, but we are not revealing that I have a ventilator associated pneumonia in my hospital, I have the device related bloodstream infection. Nobody tells that rate. Okay? But now because of this surveillance, we know our rates. The COTI, catheter associated urinary tract infection rate, 3 per 1000 urinary catheter days. These are just the numbers, I am not going to the details of that. These are all healthcare jargons which will help the infection control, infection prevention is to bring in, reduce the reducing strategies, etc., etc. So this was also published as a result of this network. See, this is what is, this tells what are the common infections and then the common microorganism. Klebsiella is the number 1 in healthcare associated infection, followed by Acinetobacter, Candida, Staphylococcus, Enterococcus, etc. Unfortunately, 80% of Klebsiella here are carbapenem resistant, 80%. So I will just give you a real life scenario. If there are 10 healthcare associated infections by Klebsiella, 8 of them have a very difficult chance of survival because 8 out of 10 are resistant to carbapenem, which is the last resort good drug to treat Klebsiella. You are left with colistin or polymyxin. You have no guarantee how they will work in that particular patient, because by that time they develop healthcare associated infection. They do not have that one infection, they have multiple other moribund status. So no drug will be completely able to cure that patient. So we take that, how many people had a chance, easy chance to live, 8 out of 10 didn't have a chance to good life. 5 out of 10 in the hospital didn't have a good chance to good life or an easy recovery. They went through a very difficult path and we don't know whether they survive or they stay for a long time. They spend so much of money, what happens is a real question in the healthcare setting. So just to summarize, this is the AMR trend which came out of that surveillance network. There is a high burden of gram-negative pathogens in India as expected. Wherever there is a low hygiene, poor hygiene, gram-negatives are predominant. ESBL rates are as high as 70% in E. coli and Klebsiella. Some centers have much more than that. Carbapenem resistance in E. coli overall 10%, Klebsiella pneumonia 40%, Pseudomonas 25%, Acinetobacter 70%. In our hospital it is 100%. All Acinetobacter are resistant to carbapenems. Colistin, we called it as a last resort, but there is increasing resistance. Salmonella typhi, almost resistant, all are resistant to fluoroquinolones. Thankfully, with us, it is sensitive to cefixime or ceftriaxone. We don't see much of that resistance, but some centers do have them. Among gram-positive, among Staphylococcus aureus, 40% are methicillin resistant. Fortunately, the rate is quite static. But worrying is increasing resistance to linezolid. That is the last drug available. We see resistance to linezolid also. Vancomycin resistance increasing very much in enterococci. That is an indicator that someone, because it's a gut organism, very resistant, any assault is seen with the enterococcus. We have very high resistance of enterococcus faecium for vancomycin. Phosphomycin resistance is increasing. Candida, glabrata, nearly 30 to 40% are resistant to caspofungin and fluconazole. And this candida infects individuals in the intensive care unit who are very sick. They cause serious invasive infection. And there is emergence of Candida auris. Almost all drugs, it is a doubtful activity on Candida auris. So that is also coming up. The rates are quite high on the north side. South, not that bad, but it is appearing and increasing. So much more to that than what I mentioned here. All data are publicly available, in this website. You can go through that, and all results, annually these results are available. You can visualize any data and make a comparison, make your own drawings, analyze. These are all done with the national money for the national use, and more people should be using this information for more research and more understanding. It's your data, you have a right to, but it's too big a data because they have compiled each and everything. Lot of unusual, unnecessary information also is available, but whenever you get time, please go into this information also. As a result, there are several guidance documents came up. One is a treatment guideline which came up for a common syndromes, but I would like to draw your attention on this drawback, because this result is generated only from the medical colleges, level 3 hospitals. So this treatment guideline is applicable only to level 3 hospital. Practicing in a village, practicing in a taluk, you cannot use this, because more resistance evolves in the tertiary care. So you cannot use this for a secondary care. But there is a national guideline at least for a medical colleges to follow, if not for the primary health or a secondary care physician. But I hope with the inclusion of more and more secondary care, we will be able to, by another couple of years, we will be able to bring out guideline at a little secondary level also. So that's all. This is our team, and thanks to ICMR under the leadership of the ICMR, the AMR chief is Dr. Kamini Walia, and she heads that division of descriptive research and antimicrobial resistance. And these are our local team. We work with the multiple different specialists we have our own consortia for antimicrobial resistance at a university level. We take more of a public health research and an epidemiological research, relatively much more than the core research on antimicrobial resistance. Thank you very much for patient listening. No, I'm standing here, so I didn't put my photo again there.
Thank you for your
Thank you.
It's a wonderful
It is just a very tip of the iceberg.
Yeah, I think it was a very interesting presentation and a lot of data and very impressive. And I think India has done great in at least gathering so much of data. But I think now what we need to see is the impact of this data.
Of how it is used for the
whether it's bringing down. But one interesting information I saw in one of the slides, you said Salmonella typhi is now MDR, but it is 100% sensitive to chloramphenicol, ampicillin. So is it because, of course, people have been using more advanced drugs, or when the third generation, fourth generation drugs come, the prescription is more towards that.
More towards that.
So the older drugs,
it's reappearing. Chloramphenicol is mostly
it's an interesting trend. So I think that indicates that, of course, there are resistance related to use.
Yes.
So as you change the usage patterns, then you see the change.
It's reflected.
Yeah. So,
but one thing is that if you start using chloramphenicol, again we will lose it. It may not last long, but like nitrofurantoin for E. coli.
Yeah. So now what is the guideline for typhoid?
Ceftriaxone and azithromycin.
Oh, okay.
Cefixime, ceftriaxone and azithromycin.
Okay. And what is the linkage between this ICMR data and NCDC? Because I think are the organisms different, or
no, the same organisms, but in ICMR has fungi also. NCDC doesn't have the active fungi data into their pool.
Okay, but
they're evolving, but they are mostly all government medical colleges, and there is no genetic detection. Genetic is with this, with the ICMR data.
But you said the WHO net reporting goes from NCDC.
NCDC.
So the ICMR data
has their own portal.
Okay, but it doesn't go into the global network.
It doesn't go to the.
Okay. Okay, thank you.
It was a very vast presentation, ma'am. And one thing I'm curious is, after entering to the ICMR surveillance as a private hospital thing, was there any pressure of changing the prescription or the antibiotic stewardship, what you were following? Because quite a number of times you specified that you were practicing earlier also, but restricting to the guidelines, was there any changes made?
If I have to answer your question frankly, we do not exactly follow ICMR treatment guidelines. We customize to our hospital, because each hospital should have their own antibiotic policy based on their own background resistance. We have lowered our empirical much below ICMR, because we always believe if I use, because according to the ICMR guideline, the empirical is colistin, because the rule of making empirical guideline is anything which has an above 70% resistance, you should not use it in empirical, because 7 out of 10 people you don't have a chance to hit in the beginning, right? There is a rule in treatment. When you say this many number is crossed, you cannot use it as a standard practice. So we have to go for colistin. But can we go for colistin empirically? Absolutely no. So we start with the meropenem, and then we have 24/7 running laboratory. So we are in touch with the hospital all the time. So it is not just a testing and the treating, that is the availability, the team. When we are available with the test results, there is something to fall back on. So we still lower down our empirical. There is no pressure from any corner, because ICMR doesn't influence in any of your treatment practices. They just need your quality data, that's all. And as per the objectives, did you implement a little more of IPC, little more of stewardship, but in treatment they don't influence us.
You said about the example of a linezolid as well as the chloramphenicol. Is there any experiences that going back to chloramphenicol again, or because already you have jumped, like the people have jumped to
chloramphenicol is not a friendly drug. It is a highly toxic drug. So people don't prefer chloramphenicol to use in the modern time. But we reserve chloramphenicol for extremely rare cases. We do use chloramphenicol, but not as a going back, because the more I use, again we lose it. That's all. It's just a matter of time. In our hospital, we have Malditoff. Yeah. Yeah, we too use this for antibiotic sensitivity. We too use Vitek, but identification with the Malditoff.
You said that the protocols are uniform across all the
Laboratories.
So every lab that has been included will use Malditoff.
No,
Will use
not that kind of a harmonization.
Okay.
Majority have Vitek with them. Still, some people still use disc diffusion.
Yeah, so that's what I was coming to. So if they are using disc diffusion, there are some antibiotics and the preferred method may be microbroth dilution, right?
Yes, that is the yeast. We don't have data with that.
No, that's why. So would it not be something, of course, that you can suggest as a partner that all the laboratories use microbroth dilution, because then the quality of the antibiotic that is used also will impact the results, because see, when you do a disc diffusion, we know about the excipients that will be there. Don't you feel that microbroth dilution will be preferred even for treatment of a patient?
I do agree, but considering the labor intensive in a clinically relevant time frame, doing
like colistin, you have to do microbroth.
For this surveillance network, colistin drug was supported by the ICMR funds. So we have done colistin by microbroth dilution. All the centers have done by microbroth dilution for colistin. For fungi, even now we do not do any microbroth dilution. The yeast go to PGI and they do microbroth dilution.
Okay, so that's
because it is too labor intensive and the drugs are too expensive. Because for a patient treatment, we need to give results by 24 hours, which is impossible in a diagnostic laboratories. Colistin is yes, all results are by broth dilution.
Yeah, that's what I was. Thank you.
Immunology sense, like infants.
Antimicrobial resistance is in the bacteria.
Infants or
the age influences how the patient responds to infection, the progression, their ability to withstand or recover depends on the age. Age has a serious role in response to infection. Yes. At a advanced age, immunity reduces. In this, we have not segregated age stratified information, but it is available because the data comes with the patient age and the syndrome. It is possible, but it's not done here.
There is predominance of gram negatives.
Yes.
I know that in the tropical country like India,
gram negative is the one that strikes. But in the West, it's when you see some publications, it's a lot of gram positives, right? What could be the reason?
It's a cultural practices generally. We are more of washers and they are wipers. It's a hygiene concept because, there every environment is dry and dry. Because dryness doesn't like, the gram negatives don't like dryness, they like that wet atmosphere. So, and a poor hygiene and all fecal bacteria, E. coli, Klebsiella, that's the reason, because of the fecal hygiene and the sewage.
And what about fungus then?
Fungus, I do not want to give any data on fungi because we are not diagnosing fungi at all. We are not diagnosing. Fungal infections is significantly there. We don't do tests. We don't do tests.
Not because of this project.
Recently, I am seeing exotic fungi coming in unsuspecting patients. Because just to, out of the context I am because your question stimulated me to say that. Just last week we had a patient where his urine had Cryptococcus. We would never imagine in the urine in an unsuspected patient. By the time we rushed to the ICU, patient went home, DAMA, very moribund, no scope in the hospital, so we lost what happened, why Cryptococcus is, and nobody suspected Cryptococcus in them. We would never think crypto would come in the urine, means he must be having such disseminated cryptococcemia to push it in the, through the kidney and come in the urine. These are the exotic, and we have cryptococci which is not clearing in the patient blood and the CSF for the last 7 months.
Is there
he
a tissue
lives with
tropism?
that and he comes back again.
So is there a tissue tropism for that?
We do not know. We do not know what is pushing them for that, because you need lot more research to understand why that individual is not clearing. He lives with the Cryptococcus in his brain.
Wow.
For the last 6 months despite therapy, because we do not have further advancements, advanced testing to, because test whatever we do should be helpful to the patient by another 1 week or so. We don't have anything. And rare molds are coming. Rare molds are coming, rare yeasts are becoming pathogens, which we thought once upon a time not pathogen. That is where we lack, diagnostic skills for fungi. Not many are there in a clinical mycology laboratories. That is a drawback.
So do you think because of COVID, there has been some kind of immune depression, which has also allowed some of these?
That is true. That is for zygomycete, it was there for other viral infections, other viruses also were leading to mucormycosis, but COVID made it very evident.
Is it a result of long COVID also? See, long COVID we are talking about,
Sure.
we are just speculating, not that tests are done, it is for, they are researchable areas.
Yes.
But you hear of people coming up with something they never
Generally,
had.
increased fungal infection is due to climate change, global warming. Global warming will make fungi, any fungi become pathogen, and we have in India ample opportunities for exposure to fungi, because we have all dead vegetative matter everywhere, and we get cuts every now and then, and we inhale, we inoculate. We do all sorts of, we do get even brain abscesses with the aspergillus. Spinal abscess with the aspergillus.
No, opportunistic.
It is, we diagnose only when you chase it. You need to chase them, that what could be the answer. So fungi is there. We were not diagnosing.
Maybe it wasn't there.
True. Partly true, yes, it's increasing, it was not there, it's increasing.
And you started looking for it.
Yes.
So that also is there, of course. Very interesting, sad for the patient, but interesting. Thank you. It's out of scope of whatever you spoke, but still it's exciting to hear.
I have a couple of tangential questions. One is, do any of the tertiary care hospitals go to pharmacies in and around, not within the hospital, and try to figure out how many of your patients that are in OPD and things like that actually purchase medicines according to course? Do they complete the course? Is any such thing done?
I can't give you an exact answer, but I can tell our perspectives. In our hospital, it is 90%, 100% IP is purchased inside. Around 70% of the antibiotics are purchased within the hospital, because we have our own pharmacy. 30% purchase outside. The sale of antibiotics, yes, we have a pharmacy college, and under our AMSP program, we have clinical pharmacists involved. Once in a while, we take up surveys, send the students, pharmacy students out to the outside pharmacy for their prescription audits or educational awareness. How much the patient consume? Absolutely no data.
Okay.
But over the information is all patients do not purchase the full course.
Second question I have is anybody monitoring the hospital drains?
Hospital?
Drains.
Drains. As a part of research, we do, not on a routine scale.
Is that any different from what you see in the ICUs and your? One of my PhD candidate was working on a hospital sewage, and there are many studies in India on the hospital sewages. We have the similar hospital resistance is also seen in the hospital sewage. Okay, so what sort of control is being applied for?
But we have a sewage treatment plant.
Okay, so after the treatment, are you monitoring?
All the AMR bacteria are nil. That is the result.
Okay. One final question. For the SOPs that everybody is following for the national surveillance, where is the overarching monitoring?
The thing is, these SOPs are already available SOPs, but they were made mandatory to be within them. And all these laboratories are NABL accredited. So there is an ongoing, surveillance or the monitoring of their processes and procedures. That is one. It's an ongoing, integrated into the system. And secondly, from the ICMR, as a project mode, there is an additional external quality assurance program run, which will have a second level emphasis on the, continued monitoring of the quality.
And how do you think that could be implemented in secondary and primary care?
That is a really tough question to answer. We just started adopting one secondary hospital, and we were so surprised. We are worried how we teach them now.
Yeah, I know, I understand. Yeah.
Yes. We need time to, because it's a government hospital, any quality requires money. Who will pay the money is an issue. There may be some money coming from ICMR in the initial, but we need to work with we need to take people along so that it becomes a part of their program much.
Yeah, we need to start somewhere.
Somewhere, yes.
Thank you.
Thank you for that. We have a course for clinical pharmacist. We completed one cohort last year with the 6 months course, 2 weeks on site and the remaining online, and this year is going to be launched in the month of October. It is going to be little shorter, 3 months course. So they will be equipped to start stewardship in their new roles. And for medical undergraduates, the current curriculum has a brief component of stewardship, which is insufficient definitely for their practice, because ultimately what they learn is from their professors. I think that answered several of Lena's questions in the morning. Yes.
Thank you all. Thank you, madam.
Please, yes. So, thank you very much, madam, for your very much interesting and scholarly lecture on this occasion. I request our CEO, Dr. A.M. Ramesh sir, and please present a memento to Vandana madam as a token of our respect. Thank you, madam. And I request Ramesh sir to present a memento to Akash sir for chairing this session. Thank you very much, sir. Thank you, madam. Thank you. So those who are going to present the oral presentation is still going on. So So tomorrow those who have oral presentation schedule, now please go and present. And tomorrow the session will start at 10 o'clock sharp. Please be at the venue at the 10 o'clock, and breakfast will be arranged at 8:30. So thank you one and all for your patience listening. And you please take abstract we kept outside, and tomorrow the conference kit will be given to you. So thank you one and all once again.
ನಾಳೆ ಸೇಮ್ ಇದೆ ಥರನಾ